એફેક્ટ જ છે ને.
We are going to start within 4-5 minutes, so please call your friends, those who are outside taking breakfast. Because after first lecture, we will give 3 prizes, those who are in the hall. So please call your friends.
जाते नीचे तो हम જૂમ જવું હોય તો થોડો ઝૂમ થાય કેમ એટલે આપણે તો આટલો થાય ઝૂમ મારે કરવો થોડો બાજુની ગેપ નહીં જોઈતી મને પસંદ નીચે ઉતરી ગયો તો સારું રહેશે फिक्स करना बोल लेना हाँ ये करो जो बस હા હા
આ ખોટું માથું વચ્ચે આવે મજા ના આવે.
હા કેમ કે બારોબાર લાઈવ બધે જ હશે એટલે
ખબર છે, હું કરું જ છું એટલે મને ખબર છે, એટલે મેં તને આઈને પૂછ્યું.
અને વાંધો નહીં.
કેમ કે અહીંયા ઉભો રહું ને તો પાછું માથું આવે, નકર તમે પોસ્ટમાંથી પાડી દઈશ તો વાંધો નહીં આવે. એટલે પ્રેમ જેવો આવે તારે તારે પાછી મારે બારે ઘડીએ બૂમ મારવી પડે.
ગયા
Good morning, everybody. I, Dr. Arvind Kanchal, on behalf of AFPA, I welcome you all. Now we start our program, and for that, I invite Dr. Krishna Rathod as the reporter. Now he will handle the whole session. The session contains of 15 minutes of 4 lectures. And the timer is also there.
I request Chairperson Ken Hari Kumar and Jignesh Godani to come on dais.
Dr. Harish Kumar is from Bangalore and Dr. Dinesh is from Bhavnagar. We all welcome.
Good morning, everyone. On behalf of AFPA, I welcome all of you in this beautiful morning for our national conference. Today's first speaker is Dr. Rohit Joshi. I would like to invite him for his first lecture. And I welcome all of the dignitaries who are sitting here and myself, Dr. Dinesh Gohil. Our reporter is Dr. Rathore sir and my colleague Dr. Harish Kumar sir. Thank you very much. Please. Yes. I also welcome Dr. Jay Shah all together. And second, he will be talking about the nephrology tips for day-to-day general practice. All of them will remain. All the food. Thank you. Over to Dr. Rohit Joshi, please.
Conference of AFPA Ahmedabad, and what a coincidence, the same year they have brought in the Federation of Family Physician Association of India, whose current president belongs to Ahmedabad, Dr. Abhay Dikshit sir. So what a coincidence, and it deserves to have a thunderous applause so that we can right away congratulate all these organizers for all the hard work they have put in. Now, giving just an outline of this session, we are having an hour session. It is dedicated to urology and nephrology session. So I will be giving some insights on urology for the family physicians. What is there beyond horizons? Subsequently, my colleague Dr. Jay Shah will speak about nephrology for family physician. And I have been talking to several meetings, different crowds, surgeons, urologists, even non-urologists, non-doctors, professionals. Monologue never works. It's always a dialogue that generates interest, provided the people have more interest in attending session than having breakfast. So let us have more people from breakfast session to get over and then come inside. So for that dialogue thing, the third session will be a kind of a panel discussion where I have put in 5-6 case scenarios which has been actually happened with me, and then I will get inputs and feedback of all these expert family physicians sitting over here, and we can have your insight as well. And remember, as I am told, there are a couple of prizes to be won, so please be attentive. Coming to the first session, let us start the first session. Initially in our conferences, we used to start at 8 o'clock. In US, when I go to America and Canada, we start at 6:30. And at 6:30, the entire hall is full. If you come at 6:35, there is no entry. But in India, it is always like this. So we started to get it done at 8 o'clock. So there was a Paki Hajri, like 8 o'clock, 9 o'clock. And they have done a very right thing. They have taken it to 9:30. But India will take an India. So even if you take it 12 o'clock, people will come at 12:30. But never mind. Let us have, thorough scientific content into this. Yes. I would like to acknowledge. But whom do I acknowledge? Whenever I make a presentation, I always acknowledge the organizing body. But I am told by my colleagues Sanjay Bhai and Abhay Dikshit sir that we are not organizers. This entire team. We don't want to have a single 2, 3, 4 or 10 names. It is the entire AFPA, the whole body of Ahmedabad who has done this. So I acknowledge this to the entire body of AFPA, not singling out anyone, which has been headed by spearheads like Abhay Dikshit sir, Jiren Bhai and Sanjay Bhai. Thank you so much for this opportunity for us to enlighten our family physician friends. Now recently I had gone to Montreal, Canada. It was a Society International Urology meeting which was attended by 1800 urologists across the world. I was one from India, I had a couple of talks and few of symposium over there. So there was a lot of talk going on about this robot. We all know this is a robot. You all must be knowing by this. This is the Da Vinci robot. It's a big boom currently in all the subspecialties. Now I happened to meet Michael Wong. He was from Singapore. And he very proudly said, Rohit, we have one robot in our hospital. Do you have one? I said, let me wait. Then I happened to meet Rogers. He was from USA. And typical arrogant US accent, he said, come on man, we have one robot in each state of the USA. So then I thought, I am from a poor country. And we don't have this many robots. So I feel very, very inferior. But then I scratched my head. And then gradually I thought, no. We have many robots, not in each state, not in each district. It is each street of each city of India, we have robots. Now, who are these robots? These robots, they can get neurosurgery done, they can do plastic surgery, they can do cardiac surgery, they can do everything. And this robot happens to be the family physician. So you guys are the robot. Because you are the one who divert the patient to the correct place, to the correct consultant, and that's how I feel proud in being practicing in a country like India, where we don't need those robots who don't have emotion. We need to have emotional robots who can take care of the patients when we operate them subsequently. So it's all in the name. Family physician is a wonderful name. I don't know who has given this name, but I really respect that fellow who has given this name, family physician. Have you ever heard family surgeon or a family neurosurgeon? No one calls me family neurosurgeon. Because physicians who treat families, they become their family members. So that's again one more respect to all of you sitting here, that you are the guys who become family members to them, and that's why you are called as family physicians. Now patients are shunted here and there. In middle of night, something goes wrong. I operated a patient. But if something goes wrong, he won't call me. Even if he calls me at times, I might not respond. But there, that time, very goes, he reaches out to you. And that is why you deserve more respect than all us so-called super specialists. And I'm yet to see a patient who gets convinced. मेरे पास कोई भी patient मेरे पास आता है. This is a metro crowd, so I'll speak in Hindi in between. कोई भी patient आता है, मैं उसको समझाता हूँ कि लेजर सर्जरी करना है. सर मैं 2 दिन में आपको बताता हूँ. For these 2 days, he will go back to the physician who has referred to him. Sir, ठीक है ना ये करवा लो. Once he endorses, then only he comes back to me and gets himself. That's the confidence the patients are having in family physicians. So kudos to all those family physicians. The health sector of India is largely depending on you guys. And that is why, that is the reason why I am here, because I need my family physician network to be updated regarding what is going currently, what is in thing, what is in recent advances, so that whenever it comes to passing on that clinical care to the patient, you are all as updated as me. I will give you one more example what a family physician is. See, now this is the Pandora's box. So, first I called upon a surgeon. Open this. Surgeon told me, give me a key, I open it, and we will come to know what is lying inside. Then I asked an orthopedician, क्या चाबी वाबी की जरूरत है? Give me a hammer, I will break it open and see what is there inside. Why use mine? Then I asked a physician. So physician told me, उसका length कितना है, उसका breadth कितना है, उसका वजन कितना है. उसके बाद ये gave 5-7 differential diagnosis. इसमें ये हो सकता है, ये हो सकता है, ये हो सकता है. Then lastly, I asked a family physician to predict what is there inside this Pandora's box. He silently moved the box away. He asked me, whose box is this? Which locality is he residing? How many family members are there? What is the neighborhood? आसपास में कोई नदी है कि नहीं? So he was going right to the depth of the intricacy of that box where the box was lying in. Then he could predict the most near thing which is lying in this Pandora's box. So that is what family physician. All respect to you, sir. So you are the bridge for an optimal care of patient between the super specialists and the patients. And that's why I need you to be updated as like me. And for that, I am here. And the most two common urological disorders which you come across, I believe, is BPH and stone disease. I guess everyone will agree to that. Every one of you see right and left patient with stone, patient with BPH. So let me speak on these two disorders today. And we'll speak about both the medical as well as surgical management. First, let's have an update on BPH. I would be proud to share this thing with you that we always follow guidelines used by US and UK, but this time, a couple of years ago, we have formulated our own guidelines on behalf of the Urological Society of India. It's an association, our national association of more than 4,000 urologists across India, and the three of us took that responsibility on us, and we formulated guidelines, and that guideline gives us the protocols how to manage a patient of BPH, and that is the experience which I am going to share with you today. There are different terminologies. Many people use this terminology interchanging. There is no problem. Ultimately, it boils down to the same thing whether you call it BPH, SEP, bladder outer obstruction, or whatever you say. Now, pathology, you all know, basic pathology is the enlargement of the prostate. I am not going to much detail because there is nothing much into it. And subsequently, symptomatology. Now, there are two classic group of symptomatology. One is the voiding symptoms, which is obstruction. It leads to hesitancy, intermittency, sense of incomplete emptying, weak urinary stream. Patient has to strain to pass urine, and takes long time to pass urine. Same thing, there are storage symptoms. Like patient passes urine every hour, in night he has to wake up more than 3-4 times. There is an urgency to pass urine, and if the bathroom is not available, he has to rush and he might pass a couple of drops leading to incontinence. So these are two classic setups of symptoms which happens with the BPH patients. Now, obstructive symptoms again are because of two components. One is the anatomical mechanical component because of the size enlargement. Second is dynamic obstruction, which is mediated by alpha blockers. You all need to know this because the medical management largely depends on this knowledge, which molecule to offer to whom. Let's not go to the further pathophysiology. If untreated, for a patient who doesn't get adequate treatment in time, he can end up having hematuria, he can have recurrent UTIs, he can have acute urinary retentions, he can have multiple stones, he can renal impairment, or he can have a bladder decomposition. These are all the complications of untreated patients of BPH. Now these are classic set of evaluation. How do you see patient? How do you clinically evaluate? So this is IPSS score. I will pass on that IPSS score to each one of you. So these are purely mathematical scores on a scale from 1 to 7. And there are scores you need to give to the patient. So it can be minimum 0, maximum 35. So depending on the score the patient has, we can categorize whether he is having mild symptoms, 0 to 8 is mild symptoms, 9 to 20 is moderate symptoms, and 20 to 35 is severely symptomatic. Digital rectal examination. We never do this, but it has to be done. There is a sentence in textbook of surgery, if you don't put a finger in somebody's rectum, you might end up putting your face in the rectum. So it's a very important aspect because it helps you to detect any hidden carcinoma inside a patient. We need to get a transrectal ultrasound sonography and a uroflowmetry. These two things are a bit advanced investigation. You can refer the patient to us and we can do it for you and get back to you. Now coming to the management, because evaluation is fine, once you diagnose the patient, there are three options. First is conservative management, there are no molecules, then there are medical management, then there is surgical management. The conservative management is all about suggesting few of the lifestyle modification, avoidance of too much of cold, take lower sodium, avoid junk food, have adequate sleep, adequate exposure to sunlight. All these, a known kind of medical or non-pharmaceutical management options, they do work well in early stage of patient who is having mildly symptomatic. So once patient is beyond that, we need to institute some medical therapies, some pharmacotherapies for these patients. These are the patients who are having mild to moderate symptoms, or those who are having severely symptomatic, but there are many patients who are unfit because of one or two other comorbidities present in these patients, or those patients who are not willing to undergo knife. And then there are patients who are waiting for surgery. Somebody is on a blood thinner, and if you want to wait for 5-7 days, till that point of time, we can maintain those patients on this pharmaceutical management. Now, there are classically 3 groups of drugs: alpha blockers, 5-AR reductase inhibitors, and PDE5 inhibitors. These are the commonest molecules you can prescribe to a patient when you encounter patient who does not require surgery. Now, this alpha blocker, you are all very senior, so you must have prescribed terazosin or doxazosine. I have never prescribed, but I think many of you who are very senior might have prescribed Terapress and Doxacar. These are the antihypertensive medications which were accidentally known to help patients with BPH, but because of the side effect profile, they have now vanished. They actually work on the alpha-1 receptors and they decrease the tone, so the prostate gets opened up and patients notices improvement in the flow. So in nutshell, terazosin, doxazosine are no longer used because of the adverse effect profile. Currently, either you can select tamsulosin, which can be available as different trade names, Urimax, Veldum, you all know that. The newer one is silodosin. So that is still super selective. So it is equally effective and having less side effects. And alfuzosin is one molecule which is to be reserved for a patient who is relatively young and who is sexually active. Now the sexually active is a very relative term. When I see patients from Canada, US, they are active even at 75 years, and we hardly bother about asking any Indian patients, are you sexually active? They will say, kya baat kar rahe ho sir? But these are different, demographic criteria. But we have to keep it in mind. I had a Muslim patient who came with his wife, BPH, a little bit of by the side. So he came and I prescribed him silodosin. Next time he came, he was satisfied. The wife was satisfied. Then second time he came. That time the lady was different. So the patient was satisfied. Why are you here? You are doing well. Why you need to see me every month? I don't want to see you. This lady wants to see you. Who is she? She is my wife. But she is not the one who will come to you first. Sir, हमारे यहाँ 2 दिन होती हैं. Second wife है. So she was not satisfied because of the erectile dysfunction which happened as a side effect of the alpha blocker on silodosin. So second wife had a problem. She was much younger than gentleman. So then I had to switch him over from silodosin to alfuzosin. That is the day when I never see any more wives of that patient. So next group of drug is 5-AR inhibitors. We all must have known this by finasteride and dutasteride. They inhibit the conversion from testosterone to dihydrotestosterone, and this is the dihydrotestosterone, that is the hormone which stimulates growth of the prostate. So they decrease the volume of the prostate. They shall be used only when patient's gland size is more than 30 to 40 grams. So I see many times, we prescribe just like that without getting a sonography. Why you need to get a sonography? Because we need to know if the gland size is more than 40 grams, then only there is a rationale of using these drugs. Because these drugs can reduce the volume, but for that you need volume to be there. Right? And it is usually taking more than 3 months. So if you ask someone to take only finasteride or dutasteride, and if you expect him to recover within 7 days, it's not going to happen. So always counsel your patient, 3 mahine raah dekho, uske baad I'll see you. That is precisely why patient's compliance is poor with the single drug. That is why these drugs are more often used in combination with alpha blocker. So the alpha blocker takes care of early part, he improves within 2 or 3 days, and then the improvement is sustained because of these drugs. So that's the role of combination therapy. PDE5 inhibitors, sildenafil, tadalafil, you all know this name, and this is a very unique thing that this particular drugs which was invented for the sexual thing, they have a very good effect on prostate as well. So they can be used either alone or in combination in sexually active men. But yes, at times patients come. They are having only the urinary problem. So we are inclined to treat only the urinary problem. But once the urinary problem gets settled down, the next visit they say, sir, वो तो ठीक हो गया, अभी थोड़ा इसका कुछ करो ना, किसका कुछ करो, sir वो थोड़ा सा आप समझ जाइए ना. So they will always be little bit bothered. That's a social taboo. Patients do not discuss things. Then we get to understand. We have to, ask our assistant, might be she is a female, to get out of the room, and then he opens up. Sir, what हो गया? अभी ये problem है. So in this kind of patients who are having combined urinary symptom as well as erectile dysfunction, we can use combination therapy of tamsulosin with tadalafil. That works really well. Now there are certain contraindications to the medical management. Refractory retentions, refractory infections, hematuria, stone, renal failure. These are the patients who need surgery. You all know there was prostatectomy, then TURP came, and now we have laser enucleation. So let's see what difference between laser and TURP. This was done 1932. This is this picture is right of the riverfront, which was looking in 1932. The first TURP was done in 1932. It was gold standard because of the reasons. It was time tested, no complications, mortality was very rare. It was minimal invasive, no cut, very safe. So it was considered as gold standard. But there are problems. You all know the problems. Bleeding, clot retention.
Sir, sorry to disturb you. Your time is over since last 3-4 minutes. So
Sir,
please complete it within 2 minutes.
I beg to
It is my
differ.
humble request.
I beg to differ. We have 60-minute session. We started at 9:40. I'll give you session at 10:40, sir.
Okay, sir.
Simply
Sir, sir.
because we are having the panel discussion is only
Sure, sir.
15 minutes. So we
Sure,
have
sir.
10 to 10.
Sure, sir. And that time, it is at the running time.
I have one more, sir.
Please.
Because of this
Thank you,
got
sir.
little late. Yeah, I'll
And
get
I'm
that.
sorry to disturb you again.
Not at all,
but,
not at all. 10:40 you will get it. Don't worry, sir. So these are the problems with the TURP, and there are patients whom we cannot offer TURP. These patients are having bleeding problems, patients are having renal failure. So for those patients, TURP went. What came in was laser therapy. That is laser enucleation. So these different kinds of lasers are there. The most in thing is holmium and thulmium lasers. Now, advantages of HOLEP is it's bloodless. There is no need for blood transfusion. There is no need to stop blood thinners. And these patients can be operated who are having stents or CABG. We can operate them without any need to stop these anti-blood thinners. Now, if you want to see this, these are two clips. This clip is of TURP. Just give some time to look at this clip. Now, this is a grade 2 enlargement of prostate. You must have seen this TURP. But why I want to see is that now let us see both the things together. On the right is the laser enucleation. On left there is the TURP. See how much bleeding is happening in the TURP. And look how bloodless is this laser enucleation. So this is what matters, because this all blood which is lost during a TURP can lead to significant renal complications and cardiac complications. So 1932 has gone. Now we are living in 2023, and this is the current riverfront. So we need to change. With the time, even the standards are changing. Which was gold standard is replaced by platinum standard. So now the holmium laser enucleation is a platinum standard. However, there are few concerns, because not everything has what rosary thinks. You know, today is an era of combo. Salary comes with TDS, MRP comes with GST, and a loving wife comes with an equally loving mother-in-law. So it's a combo package. So we have to accept certain ifs and buts with everything. Cost is a very significant factor. The insignificant cost is more than ₹1 crore for that machines. It's difficult to master. Not everyone, not every urologist of Ahmedabad will speak about it. There are 80% urologists will say, "Nahi, yaar, wo TURP theek hai apne liye." But that is because if you know it, you can promote it. If you don't know it, you cannot demote it. And laser machine is not mobile, so you need to reach out to the center where it is. So that's all. That's all from now. This was all about the update on BPH. I'm right down at 20 minutes. Now I'll hand over the mic subsequently to my colleague Dr. Jay Shah. And lastly, I'll come back. Till the time I'll keep the mic change over. So kindly have detailed knowledge of this, because lastly we are having panel discussion. So many questions will come from what I have updated you on that. So this is all from me. Thank you so much for patient listening. And yes, sir. Over to you, Jay.
Thank you for good lecture and informative and useful to general practitioners. Thank you.
Prize for those who are attending this first lecture.
First lecture who has came earlier when the hall was empty, Dr. K.M. Patel, please come on guys. Dr. Mukund Bhai from Anand. अरे ત્યાં ઉભા રહો ત્યાં આપી દઈએ
एक बार लगाई दीजिए
Yeah. Ready from right side. Yes, madam, you can.
Thank you, Bhaiya. Thank you.
Yeah.
Before our
Hello. Good morning, everyone. First of all, I would like to thank organizing committee, scientific committee, and Dr. Rohit sir for giving me such an opportunity to share my views on the nephrology in front of such an esteemed audience. As sir has already mentioned that family physician is a key between the patient and the super specialist, and they are playing an immense role. For nephrology consultation, people are coming, traveling across hundreds of kilometers to few kilometers. They see us monthly, 2 monthly or 3 monthly. But if they have minor ailments, they will come to you only. So basically my motto of today's talk is to have a conjoint management for such kind of CKD patient, to update you and to give insights about them, how we can help them better, and I am sure this lecture will going to help everyone in their day-to-day practice. As we all know, nephrology cases, kidney failure cases are increasing very rapidly, is seen in young age patients also. Hypertension, diabetes are going like epidemic, and so with the aging population, hypertensive, diabetic patients all are suffering at times with renal failure. Cases of renal failure are increasing day by day. Early recognition is the key for any kidney disease, kidney failure patients. For CKD, we do say knowing is half battle won. If we know that patient is suffering from CKD, is at high risk for the renal failure, we can change our approach, we can change the management, and we can save years together for the patient to have a good renal outcome. Early recognition and early intervention are the keys. Aim for today's talk is to avoid common pitfall in the recognition and treatment of such disorder in the conjoint manner with family physician and super specialist. Talk is in 4 parts. First is correct interpretation of the creatinine. Second is correct interpretation of the proteinuria. Third is early detection of the CKD, and fourth is drugs in CKD. Coming to the first part, correct interpretation of serum creatinine. As we all know, for calculation of renal function, we do see creatinine in our day-to-day practice. But however, many of the labs all must have gone through this. Some lab will say 0.5 to 1, some will say 0.6 to 1.5, some will say 0.8 to 1.4. Range will be variable. But in today's practice, we do calculate estimated GFR, that is eGFR, because creatinine has various non-GFR determinants like age. With increasing age, there is decline in creatinine. Sex, that is with female, they have less muscle mass, so they will have lesser creatinine value. Patients who are severely cachexic with muscle wasting, with advanced cirrhosis, advanced heart failure, amputation will have less muscle mass, so less creatinine. So we have derived formula of eGFR. How to calculate eGFR? That is pretty easy. eGFR calculators are available across Play Store as well as iOS. If we in the Play Store, if we write eGFR calculator, ready-made calculator is there in which we have to feed age, sex, and creatinine, and calculator will calculate the eGFR for you. We'll take an example. A 66-year-old gentleman, diabetic, hypertensive, came to our OPD with fever and minor ailments. Patient is having creat value of 1.4, and in the bracket lab is showing 0.6 to 1.5 as normal. This is our day-to-day scenario, right? While looking at the create value only, we will give him any sort of medicine. But if we calculate EGFR by CKD EPI formula that has been suggested by the KDIGO, which is our international organization for the kidney disease, EGFR comes to 55. Patient is having diabetic hypertensive, so is at risk of CKD. EGFR is 55, so it tends to G3A CKD. So what are the implications for our practice? Such kind of patients are having a high risk for renal insults, AKI. So they should not be given NSAIDs, they should not be given nephrotoxic agents, and one should be very vigilant for the treatment of such kind of patient. This is one of my favorite slides. Slide is from NKF, that is National Kidney Foundation, US based organization, kidney organization, in which there is 3 different case scenario. All 3 patients have creatinine of 1.4. If we calculate EGFR by CKD EPI, for 24-year-old fellow, it is normal. For 66-year-old male, it is slightly less, that is 55 mils. And for 59-year-old female, it is significantly less. All 3 have 1.4 create, but different GFR values. So by calculating EGFR has definitely a role in our clinical practice. Our KDIGO recommends that EGFR create by CKD API formula should be calculated in our day-to-day practice. And we at times also recommends laboratory also associated with us, and nowadays many of the labs also give EGFR value along with the creatinine in the report itself. Now coming to second part, proteinuria. It has to be evaluated thoroughly. Common causes of transient proteinuria is like fever, heavy exercise, UTI, uncontrolled diabetes, uncontrolled hypertension. However, persistent proteinuria is classified into 4 categories: glomerular, tubulointerstitial, post-renal, and overflow proteinuria. Main key for our day-to-day practice is if we are seeing a patient with urine routine analysis showing +1, +2, +3 proteinuria, that should not be left uncovered. If patient is having minor ailment like UTI, uncontrolled diabetes, uncontrolled hypertension, and if we are suspecting a case of transient proteinuria, then one can always repeat urine RM after 2 to 4 weeks. Quantitate, and further if patient is having a heavy proteinuria, then detailed evaluation is needed. Patients with diabetes should always have once in a year checkup of spot urine albumin to create ratio, as microalbuminuria we all know is the first thing that will happen to the patient for the diabetic kidney disease. If we are having a patient who is gradually progressing renal dysfunction, hypertensive, proteinuria with active urinary sediment, that is microscopic hematuria, then we should be having a very high suspicion of glomerulonephritis, and urgent nephrology consultation should be sought for. Now coming to the third part, early diagnosis of CKD. What is CKD? CKD is any abnormality in the kidney structure and function which presents for more than 3 months, which has implications for the health. This is very interesting study done in US. CKD study, roughly 8 to 9,000 of number of patients were enrolled, done in type 2 diabetics. Even in US, they found that almost 50% of the diabetic population were not appropriately tested for diabetic kidney disease. For the diagnosis of diabetic kidney disease, we just need 2 basic tests. That is create. With the help of create, we calculate the estimated GFR. And second test is spot urine albumin to create ratio, that is albuminuria, microscopic albuminuria, microalbuminuria. Even in US, 50% were not tested, roughly 40% were tested but not diagnosed. Patients were not knowing that they were having diabetic kidney disease, diabetic CKD, diabetic nephropathy, and hardly 10 to 12% were appropriately tested and diagnosis was made. Why such gap should be filled? Because we can see in this slide, if patient is detected early, if we know that patient is having a high risk of renal failure, patient comes to concerned specialist early, then we can save many years of the patient. If patient is being diagnosed at this level, there is slow and steady decline in the renal function, which is there, we can save the kidney for decades together. But if we don't know that patient is having a diabetic kidney disease or early CKD, then he might have exposure for NSAIDs, he might have exposure for contrast, he might have exposure for others nephrotoxic stuff, and there is a rapid decline in the renal function and patient land up in the ESRD early. And believe me, with practice we can tell us that this difference is of years. We can save many years of the patient just by diagnosing early and with a good management, proper education to patient. If we know that patient is having a DKD, we can aggressively ask him to control hypertension, control diabetes, we can address the cardiovascular risk factor, we can give him soda bicarb, alkali therapy, we can correct the mineral bone disease, we can correct the anemia, and we can have a good overall outcome of the patient. Whenever we have patient of advanced CKD, only two options are available, dialysis or transplant. Transplantation is the modality of choice, treatment of choice. If patient is not candidate for transplant or is not able to do transplant, then hemodialysis or peritoneal dialysis can be done. Peritoneal dialysis is one of the very important modality, as we all know we are having a very high rise in the geriatric population. Even we have done PD at home in geriatric population, octogenarian, more than 80 years, and they have done well. Now coming to the last part of the talk, that is drugs in CKD. This is one of the very important aspects for all of us. CKD patients are at very high risk of drug related adverse event, both nephrotoxic drug events as well as other organ effects are also high in patients of CKD. Several classes of drugs are renally eliminated, which needs to be calculated. Whenever we calculate the dose of any drug for the CKD patient, we always calculate the EGFR. We categorize the patient as per staging, and then only we decide the dosage of the drugs. So, to conclude the talk, take home message is one should always see the creatinine in clinical context. Normal creatinine level may not be always normal. One should always calculate estimated GFR. Proteinuria should be evaluated thoroughly. Early diagnosis of the CKD is the key for CKD management, as CKD is a silent killer and knowing is half fatal one. And drugs in CKD should be used very cautiously, as many drug interactions are there in CKD patients. Thank you.
Thank you, Dr. Joisha sir. Again, I will invite Dr. Rohit Joshi for the panel discussion. He will be the moderator.
Thank you, sir.
And again, before that, I would like to invite Dr. Manoj Ghoda sir on the stage, please. Thank you.
T20 ને રમવાનો વારો આવી ગયો છે કેમ કે સેશનની જે રચના છે થોડી ફરી ગઈ. I'll keep myself to that. Initially we were supposed to have 60 minutes. Now I'm told we have 45 minutes. No problems. Rohit Sharma can play test match as well as T20. No problem. So coming fast to the first case, gentlemen, be attentive. 54-year-old male presented with lower leg symptoms. He had undergone angioplasty 2 years ago. At that time he was catheterized because he had retention. Sonography showed 38 grams prostate, thick wall bladder, so there was significant prostatomegaly. Patient was prescribed alpha blocker, sent home. Patient did not improve on alpha blocker, so he came back. Again, because of the size was nearby 40 grams, so again combination therapy was advised. In between, patient developed retention, and he went to see me from you. So we could not catheterize, and SPC diversion was carried out. Now what? So, may I ask with you permission, what would have been there? If there is a prostatomegaly, would you be able to put a catheter? I think we all be able to put catheter. So whenever there is a difficulty or a failure in putting a catheter in a patient with retention, you should always have that thing that we are not dealing with prostatomegaly, there is something else. And there is nothing like significant prostatomegaly. We need to tell our radiology colleagues that you just mention the size. Significant है नहीं वो हम पे छोड़ दीजिए. 80 grams prostate may not be significant for a patient. 30 grams can be significant for a patient. So never look at the only size. Always take a very careful history. That patient had a history of catheterization. So any guess what it can be if not prostate with a history of catheterization? What it can be? Stricture. So my family physicians are very well updated. So it was actually a urethral stricture. Just a quick update, how do we diagnose this? Very careful history taking. If there is history of traumatic catheterization, you are pakka dealing with VIU, urethral stricture. These are the things which you need to do. You need to do uroflowmetry, RGU, MCU, and this is the uroflowmetry. This can be done at our setup. You just ask patient to keep full bladder and visit us. He can pee in a special container, then we can get this graph. If this is less than 15 ml per second, your suspicion of urethral stricture becomes very high. This is RGU and MCU, so it outlines the actual stricture, and then the myth. You all must have come across that stricture means either dilatation or VIU. So I need you to take this myth out of this, because this is practically obsolete. With every dilatation, there is further worsening of stricture. The scar exacerbates, and then the patient will return with a worse stricture. So what is there? VIU can be done only for a soft and very small mucosal stricture like which is shown in this RGU. For rest everything we need to do urethroplasty. So we need to transect the urethra and have either end-to-end anastomosis, or we can bridge with the help of buccal mucosa. So these plastic surgeries are very technically demanding. Not everyone does it. So there are people who will tell only what they know, but we need to tell the patient what is to be done as per the international guidelines. So I want you to know this, that do not just think that stricture means dilatation, stricture means VIU. There are better options available with which patient can get a long-term cure. So the take-home message is there are diverse reasons for lower tract symptoms, prostate strictures many. Alpha blockers cannot be prescribed as a blanket to each patient. Failure to respond to this therapy should raise a concern or refer, something else might be there. And stricture urethra can be treated with so many better options rather than just dilatation and VIU. Yes sir, going next. Second case, 65-year-old patient, same acute retention. This time catheter went in very easily. Now the patient is again a history of ISD, had undergone angioplasty in past, 2 stents. He is on diplet and ecosprin. So now he is in retention, so now we all agree that he needs to undergo surgery. Can we offer him TURP? Yes? No? Can we offer them TURP? If at all we need to offer them TURP, he needs to be off this diplet and ecosprin. And there are many patients who end up in problem. Like this patient had a problem. Third day he accidentally pulled the catheter out. Massive bleeding per urethra. He was given Trenexa by the local treating doctor. Because of the Trenexa, his stent got clogged. And patient had massive MI. In emergency, stent blockade was noticed and the patient had to undergo second intervention. So lessons learned out of this is extremely dangerous to stop blood thinners, patients who have undergone angioplasty, who have been stented. TURP, one needs to stop these antiplatelet drugs at least for 5 days, and during these 5 days anything can go wrong with this patient cardiologically. With laser prostatectomy we can safely continue and operate these patients. Last, never use tranexamic acid. We use it like chana mamra. Never use tranexamic acid in such patients who may turn really worse. So there are increasing number of elderly patients. Even now to 35-40 years patients, they roam around with 2, 3 coronary stents. They are very high surgical risk. TURP is absolutely contraindicated. And that is where laser enucleation is safest and should be offered to these patients. Yes, number 3. Young male with left flank pain. There is a 1.5 centimeters stone on the left side at the level of L3, L4 vertebra. Sonography confirmed it to be 1 centimeter stone. Now you all know there is a mobile van, there is a lithotripsy van which roams around in city, and you can call them at your own clinic and the technician can do patka laga ke wo stone tod dete hain. So that was done, everyone was happy, patient was happy, surgery nahi karna pada, doctor was happy, technician was happy, van owner was also happy, he earned money out of it. Next, what happened? Patient reported back in 3 days with severe pain and urosepsis. Total count was 22,000, 90% polymorphs. Yes. I'm told to conclude, so I think this is, we can't conclude. Anyway, over to you, Manoj Goda sir. Because of time constraints, we can't move it forward. No.
Thank you, Dr. Rohit Joshi, for being the moderator for this wonderful panel discussion. Thank you, sir. I now welcome Dr. Dinesh Goel to hand over a bouquet to Dr. Rohit Joshi. Thank you, sir.
And now I will request my colleague Dr. K. Harish Kumar sir to present a memento to the second speaker, Dr. Jay Shah. Okay, now we'll proceed the session. Okay, over to you, sir. Over to you, sir.
Third lecture is by Dr. Manoj Goda, and this will be the last lecture of this session. And after completion of this session, there will be one quiz, and this quiz will be displayed on the screen, and you have to answer by, first of all, you have to go to the website which will be displayed on the screen, and on that you have to give the answer. Those you have to open through your mobile, and those who gave the first correct answer will be given a prize. And the first and correct answer will be decided by the laptop, computer system. Welcome, sir, Dr. Manoj Bhai.
Hello, good morning everyone. Thanks for inviting me. Now we straight away go for common GI symptoms. How is the Josh, by the way? Are you all okay? Yeah. Full of energy? Yeah. Okay. The commonest thing we see in our practice is obviously acid peptic disease, reflux and all. But it doesn't come up with a single symptom. So we discuss what are the symptoms and how to differentiate it from other conditions that you can have in the chest. The first symptom is heartburn, jalan. And the thing it can confuse is heart attack. So the body language of jalan or reflux or heartburn is like this, always like this. Patient will delineate the whole esophagus. If they have other symptoms which consistent with reflux, and if they have junky food, like you are going to have for 3 days, I think, very rich food, you will have reflux. Heart attack is like this. The pain, body language of heart attack is like this, or pain here, or pain somewhere there. In a cold windy day like today or after exertion, please refer to cardiologist first, because you may be killing patient by persevering with your reflux treatment. Any headache in a patient with reflux or acidity is by definition has to be acidity related. It may not be your migraine. So that's a very common symptom that we see. Belching. Oh, patient is sitting in your clinic waiting room and they have this large belching. That is gas reflux, no issue. Water brush or very pungent fluid coming back in your throat is obviously a symptom of reflux. Regurgitation, especially at night, When esophagus and stomach are at the same level, wall is relaxed, everything comes out, and patient wakes up with coughing, nocturnal coughing, is a symptom of reflux. Burning in throat, which we saw so many cases in corona, because we all took a lot of lemon juice and ginger and soot and what have you, kadas and all, and everybody developed reflux esophagitis, and every evening they would have corona. They say, oh, I've got corona. Do RT-PCR, do everything. But it's a plain simple reflux. So any burning in the throat or pain in your styloid process in a proper setup is a reflux symptoms. Chest pain sometimes everywhere, all over the chest is very well known factor, but it will go on for several days. So you can easily differentiate it from heart disease. Globus is a sensation where patient will say everything is stuck here. सब कुछ नीचे नहीं जाता है, लेकिन they can complete the meals. It's because of esophageal spasm and a very important symptoms of reflux. Nocturnal coughing we described. And last is incomplete inspiration. Patient says, I can't take proper breath, my lungs are not expanding. And you think it's all IBS, it's psychic, but it's not psychic. They have this sensation that 85% of the lung expand, and the body language of that is, now I feel better. So that is reflux. So these are the common symptoms which you should not miss. Odynophagia is painful swallowing. Patient has a lot of pain. It's not that they can't swallow, but they are afraid of swallowing. This painful swallowing is odynophagia. Invariably, it's esophageal ulcer, either pill-induced. Sometimes, in olden days, we used to get a drug called LAA, long-acting doxycycline, something like that. Very acidic pH, big tablet. Or you can take diclofenac, big tablet. You are lying down, lazy enough not to sit up, don't have water, so you swallow it and hope that it will go inside. It gets stuck at 30 centimeters, and next day you have big ulcer, very painful. That is your odynophagia. This history will tell you that this is the reason. Give them few days of PPIs and all, and they will be fine. Otherwise, they have candida infection. HIV is not common these days, but at one time we used to see a lot of odynophagia because of herpes or cytomegalo or candida. So these are your odynophagia. Dysphagia, difficulty in swallowing. Patient has to change the caliber of the food, or they have to do various maneuvers. In an echalalia, they will do this and that and everything to push the fluid down, or they used to take a large amount of fluid to wash it down. That is dysphagia, difficulty in swallowing. Now we have this slide here. In the lower panel you can see on the left you have a stricture here. And this patient, if they take large bolus of meal, they will suddenly impact, like in this case. And from that moment onwards, halfway down their meal, they can't take even a drop of water. Not even a drop of water. That is acute dysphagia. Almost invariably you can predict that this patient has either big swallow or a silent stricture or a borderline stricture, which allows to happen overnight. So you can say almost certainly that this patient probably has some kind of benign disease, stricture or a big bolus or what have you. But if you have progressive dysphagia, day in and day out, first they take full meal, then they say semi-solid diet, next week they take liquid diet, and then suddenly they say, I can't eat anything. That's your progressive dysphagia with weight loss. If you have this, you have this esophageal malignancy almost certainly. And the picture is shown here. This is the picture. Esophageal mass, and endoscopy will immediately tell you what is what, and you can get on with your treatment. So that's dysphagia. Vomiting, very common. All of us see vomiting, but try to define vomiting. Many times people come with all kind of history which is not vomiting. So only forceful expulsion that you can hear in the next room of gastric or intestinal content is vomiting. If it's passive regurgitation, something coming back very easily. In children, you see, you get small children, 1 year, 6 months, they easily, happily vomit out. That's regurgitation. If you are happily vomiting out, that is regurgitation. That you see in reflux, as we discussed, at echalalia cardia, where a large amount of food is collected in esophagus, mega esophagus. And at night, esophagus and stomach at the same level, everything comes back and through the nose. If you get something coming through the nose, it is almost always a cholangiocardia in a young patient with proper history. Okay. Nausea is a very, as we all know, very unpleasant sensation that you are going to vomit. And retching is in between nausea and normal condition. They feel like they want to vomit, they are feeling uncomfortable, they are taking deep breath. That's retching. When you are vomiting, don't just stop it there. Look at the associated things like color. If it is bilious vomiting, it is small bowel obstruction unless otherwise proved. Green vomiting. So it is very important to ask for the color, or in fact have a look at yourself, because patients don't know what is green and what is black and what is brown. They can confuse you. But if you see, diagnosis is simple. Brown is your hematemesis, light yellow is from stomach. And if there is any pain, any acute condition of the stomach will give you a lot of pain, will give you vomiting, whether it is your biliary colic or pancreatitis or what have you. But generally it is first pain and then vomiting. They want a first vomiting and then pain. Then there's something different. First vomiting and pain is different. First pain and vomiting in any acute condition. Obstipation, no gas, no stool, with distension and gola formation. In any patient, this is small bowel obstruction. And if you have a scar below umbilicus, open surgery, or even laparoscopy sometimes, even TL or a hernia, you have to presume that this is the cause of this obstruction, okay? So this is vomiting. Hematemesis, now we all have all kind of assumption about hematemesis and what we call rumor. Many times we get called from the ward that patient has hematemesis, and many times it's just a rumor. So bright red blood is almost never from upper GI, very bright red blood. From the blood in clumps, again most likely from lungs. Epistaxis is never ever a part of hematemesis. More likely that blood is swallowed inside, blood being irritant, patient will vomit it out. So any patient with epistaxis has no only coffee color or black vomiting is hematemesis, and it will be spread all over the across because they don't get any time to rush to the toilet. So then you refer your patient to GI physician or surgeon. Bleeding PR and bloody diarrhea are two different things because they have two different implications, two different set of underlying causes. Bleeding PR is drop or jet red blood either at the beginning of the stool or at the end of the stool or on the surface of the stool. But stool itself is normal and separate. Sometimes they separate from the stool. Stool is separate, blood is separate. So either it is your piles, like a fissure or low rectal tumor or low rectal polyp, and this is what it will look like a drop here. Bloody diarrhea is mixed stool and brownish blood. You have amoebic colitis, you have ulcerative colitis, cytomegalocolitis, anything, but it won't be your fissure or it won't be your piles or something like that. Rectal symptoms. What are rectal symptoms? If you have urgency that you have to go to the toilet, if somebody is inside, you have to ask him to come out quickly. And if it is extreme urgency, it is called incontinence, where you soil your clothes. Tenesmus is where you feel heaviness in the perineum. You finish your bowels, but you are not happy. You come out, you go in again, you come out again. So that is tenesmus. And it will straight away refer to rectal pathology, because rectal pathology, rectum has a lot of sensors. And if they get misfired by inflammation in ulcerative colitis or amoebic colitis or low rectal tumor, you get urgency and incontinence and tenesmus. So your diagnosis is totally different here. Diarrhea, as we all know, loose or watery stool, by definition, anything is not diarrhea. If you're going 3 times a day, it's not diarrhea. But it has to be loose, more than 3 times a day, more than 200 ml per day. If it's acute, it's less than 15 days. But mind you, acute diarrhea, if not treated well, can mimic chronic diarrhea. Frequency is normal stool where you have to go go several times a day, but every time stool is normal, and it will be included in the definition of constipation. Spurious diarrhea is where poor patient is immobile for age reason or some fracture or what have you, and then the relatives complain that every 15 minutes his nappy is soiled, pad is soiled. That's not your diarrhea. Don't treat with Lomotil, etc. Put a finger in rectum, you will see hard mass of stool. It's spurious diarrhea, stool leaking by the side of the liquid stool leaking by the side of solid stool. That is spurious diarrhea. Any chronic diarrhea without red signals, no weight loss, no fever, no joint pain, there is chronic diarrhea without any red signal, and ask about anti-diabetic drugs or something like that, lactose intolerance, etc. Flatulence, we all know, bloating and everything, excessive gas, and borborygmic. Patient will say, good hota wala gas. There are two gas, one which comes up, oh, and second is good wala gas. Good wala gas is fermentation, either it is lot of undia that you are going to eat these days, or lactose intolerance, celiac disease, lactulose, dufalac, or loose ingestion, amoebiasis or giardiasis. But remember, we are world capital of diabetes. So acarbose, voglibose, and gliflozin newer all can give large amount of flatus. Abdominal pain. Now there's so many organs in our abdomen, so different system, that if you don't have a pattern, you will be lost. So pain is either abrupt. 1 minute patient is totally normal, and next minute is stuck with severe pain. It has to be perforation or embolization, mesenteric embolization, or in a patient who has missed the periods, it is ruptured ectopic pregnancy unless otherwise proved. It's an emergency, rush them to ER. Acute is, appendicitis, biliary colic, renal colic, pancreatitis, ischemia and all. And these are the area of radiation appendicitis, starting with umbilicus, then settling in RIF, biliary colic. If you have any...
Excuse me, sir, your time is over. Please conclude within as soon as possible.
I think we have finished.
Okay, sir.
Biliary colic, if you have stone stuck in the neck of the gallbladder, pain will be here. If it's in CBD, it will go here, and everywhere. And renal colic, if the stone is in the renal pelvis, you will it here, like this. This is the body language of renal colic. And if it is ureteric colic, it will go right into the ureteric pathway. So that is about the last slide. Do not forget diabetes with pain, porphyria, lead poisoning. Ayurveda is getting a lot of popularity these days. So a lot of lead is being ingested. And spontaneous bacterial peritonitis. Thank you all for patiently listening to me.
Thank you, Dr. Manoj Bhai, for giving wonderful talk. It really touches our day-to-day life, in practice also and in person also. Thank you, sir. Now I request Dr. Dinesh Bhai to give a moment to Dr. Manoj, sir. I request Dr. Shah to give a moment to Dr. Dinesh Goyal. Now I request Dr. Vishnu Bhai to give a moment to Dr. Harish Bhai.
Now I request Dr. Arvind Bhai to give a memento to Dr. Balkrishna Rathod. As you all know, our first session is completed, so I request to give a quiz question on the screen.
What is the website?
Yeah. Website is www.afpa.co.in/quiz. Question will be also seen on the this website as well as on the screen, but you have to answer your question on your mobile through this site only.
See, the organizing committee members and members of the AFPA
Will not participate.
will not participate in this quiz. So there is no any internal setting of their quiz.
Everybody downloaded this site? Can we put the question?
Can we click the question?
Okay, wait for half a minute. Now from next session quiz, there will no need of again you have to download the site. It will be easy. Everybody ready? Yes, question will also come on the site and it will be also displayed on the screen. But you have to give the answer on the site only. Time will be given 1 minute or 1.5 minutes. And those who give the first answer, this is multiple choice question. 4 answers will be given. Everybody ready? See, we are getting late. Maybe your internet speed is slow. We are putting the question and time will start. Put the question. Are you?
Have you got the question?
Question has come on the site. Time is started now. Don't discuss with other. Many of us have submitted the answer and last few seconds. So we complete and our winner is Dr. Krishna Veni YA. Please come on the stage. He gave the first answer and correct answer.
Please come. A beautiful silver coin is waiting for you.
Dr. Krishna Vedi. Congratulations. Dr. Balkrishna Rathod, you give. I hope you all have enjoyed this quiz. Now I request Dr. Gunjit Parmar, rapporteur of our second session, and the first lecture is a plenary session by Dr. Udmandru, and Dr. Gunjit Parmar will also invite our chair and co-chairperson. Please come. Correct answer will be given. I invite Dr. Gunjit Bhai and he will invite the chair and co-chairperson.
Now our next session will be from 10:45 to 11:45 और हमारे चेयरपर्सन डॉक्टर अशोक लंगर और डॉक्टर रश्मि मनोरनी आई काइंडली invite them to come on the stage and chair the session.
Okay.
Our first session, Dr. Urman Dhru sir.
Good morning everyone. This is a plenary session and I invite Dr. Urman Dhru for his topic Tips to Expand and Extend Scope of Family Physicians Practice. Please Dr. Urman Dhru. Please stick to your time. We will inform you before 3 minutes. Thank you.
Thanks AFPA NATCON 2023. What I am going to describe in next 15 minutes or so.
Please silence.
Would be something that the faculty of physicians themselves are facing. So I have to simply change the name to family physician. Otherwise the problem of family physician and physician remains the same. Few of my slides would be a little bit theoretical. But
please be silent. Please be silent.
But after that there would be few practical points which can definitely change your practice or the scope of your practice or even the extent of your practice. So let's start. First of all, thanks to AFPA NATCON committee and my chairpersons and also for giving me this plenary session. Extending the scope of family medicine is something that I am going to talk about. And remember, it's an art and science both. So, greetings from Dr. Urman Dhru. What are the issues? As I said, few of my slides might sound theoretical, but they would be very useful. But after that, there are few slides which are going to be practical. So, privatized, expensive, urban-oriented. Our practices. We like to stay in cities only. Metro cities, mega cities. We are not inclined to go to smaller areas. Despite the fact that now, in the era of globalization, wonderful roads and all technology available even in the smallest center in India, we are not inclined to go because of our system which is urban oriented. Tertiary care hospitals, even for minor illnesses. So everywhere you will find a corporate hospital engulfing the family medicine or the family physicians. Demand for specialization. I don't believe there is demand for specialization. This is something I never agree with. If a physician is good enough, he can become the minimal referral person, and that is exactly true for a family physician. So I don't believe demand for specialization is there. Maybe a patient may ask for specialization or specialized services, but a family physician should be capable enough to explain to him that at present there are no needs for referrals. And remember, if you open any good organization's website, be it Medscape or be it UpToDate, they've got absolute indications for referral. CKD went to refer, AMI went to refer, dengue went to refer, went to hospitalize. All data are there. So there is no legal issue also. So don't believe that you are legally bound to refer a patient or you are ethically bound to refer a patient. Every MBBS doctor has right to manage till a few of the red flags are seen, and they are all narrated. Even the health department has come out with practically 343 diseases when to refer and when to hospitalize. So demand for specialization is not agreeable. Acute shortage of rural family doctors may be true, and lack of primary care approach. So you can divide all these factors into different, that is, one could be personal factors. A family physician is inclined to stay in a metro city because of the education of his children, that's a personal matter. He may be inclined to stay in a particular area because of his parents who are senior citizens and not doing well. So they are all personal factors. Then comes the workplace factor, where the person likes to work at a particular area because that area is known to him, or in that area the community is known to him. All Punjabis, all Sindhis, or all Jains. So a particular doctor would prefer to work there with these ideas of caste and species in his mind, and that's not unacceptable, that's fine. Environment, there is rural location, again the people do not like to work at particular areas because they are not on national lines. So a person may be ready to go to any place between Ahmedabad and Surat, but not at Kapadwanj because it is not on the national lines. So these are environmental factors. And then comes the population factors, that is age demographics. Like there are certain areas like Bhavnagar where you will find lots of older people. So there you will get a lot of geriatric patients. But a newly passed family physician, it may be tough for him to work in that area. So these are the 4 factors that are there. We may take each one by one. Personal factor, each physician brings life circumstances, personal qualities, training and skills with them to the workplace. So you may occasionally like to work at a workplace, especially in a group scenario, because 2 of my colleagues are well-read, they are well experienced, so I would like to work with them. So that may be a possibility. Family circumstances, as I told you, desired place of residence and work-life balance, and training and resulting skill sets. Workplace factors, workplace culture would make a difference, administrative challenges, and scope of practice limitations set up by system administrators. Like, suppose you are working in an area and suddenly the government announces that now this area would be declared a cholera affected area, and then you will be working only with cholera, nothing else could come. Now frequent infectious illness, endemics, epidemics or pandemics would really cause lots of problems with a family physician. Environmental factors, social and physical context that affect the individuals. Geographical local provider mix. So there are people who would like to work in infectious diseases, but if you go to certain areas of Gujarat, there is high number of coronary artery disease and strokes, and these have already been extensively studied. That which are the areas where there are a lot of coronary artery disease, which are the areas more diabetes, which are the areas where there are lots of infectious diseases. The mix of clinician in an area often influence the scope. And then there are population factors that we already narrated. So then there comes the stressors and supports. So what is stressors and support? When I finish my MBBS, I come out, I am going to work ethically, I am going to work professionally, I will be a skilled person. So on one side, desired of scope of practice. But on the other side, as you can see, actual scope of practice. There are a lot of stressors. Want to give time to family, want to have a good educational area, want to have good company of doctors. These are all stressors because they limit your scope of practice. On the other side, there are supporters. So these are different stressors and supporters that can be considered, and there are answers to them. So now we go to the practical consideration where most of you are interested. So these are 7 T's: training, tools, TRP, teamwork, tough health, tight auditing, and last but not the least, I'll tell you in the last slide. So what is training? Where a family physician need not be only MBBS. He can go ahead and have some training. The training could be in the field of HIV, geriatrics, COVID, diabetes, even he can study law, and then can take a lead in the area of medico-legal problems of his community. So don't just be MBBS, you can get training, and there is a long list of training areas, and thereby you can be a step ahead to the rest of the family physicians in your area. But do not make a mistake of having a specialized practice, because that would cut down your scope. So continue with all the patients, but simultaneously let all the patients realize that I have got a diploma in diabetes or I have got a diploma in geriatrics. Tools. Now there are so many tools a family physician can use, and still most of them are not aware about it. Like glucometer. Now how can you use glucometer? Anybody has idea? I've been telling this since long in all the lectures of family physician. You can have 5 or 10 glucometers with you. Keep it with you. Any company would give you 5 or 10 glucometers. Keep a bottle of glucose sticks. And don't ask your patient to buy glucometer. Hand over a glucometer, keep the track. That is what we as a physician or diabetologist do. We ask them to keep a record of 5 days. You can do it. There is no need for you to be an expert diabetologist for simply telling this. So hand over a person whose HbA1c is 9, simply hand over a glucometer, hand over sticks, chart for the sticks, it is absolutely ethical. He doesn't need to buy something and still he can come out with records to you after 5 days. Same way, ambulatory blood pressure monitoring. The services are now easily available. You should not be in a dilemma whether the patient has hypertension or not. It's a time for ambulatory blood pressure monitoring as a recommendation, and these services are easily available. So you can even earn out of these tools. CGMS, continuous glucose monitoring system. A child who is coming to you with a hypo, just don't treat hypo. Ask him to undergo CGMS. That's what the diabetologist is going to do. These are all simple ways to utilize these tools that are available to everybody. Like blood pressure instrument. Don't ask the patient to buy blood pressure instrument. Hand over blood pressure instrument to him and ask him to bring it back after 5 or 7 days. Just have a look at your memory and you'll get all the results. You will be able to judge whether the patient has white collar hypertension or not. ECG, all you know, and most of you are using also express ECGs. So that's also coming with the reports. Holter monitoring, risk calculators, whether to give statin or not. Open your smartphone. It's so simple to decide whether this patient requires statin or not. So utilize all these tools. Whether to give aspirin, whether to give pantoprazole, whether to give clopidogrel, whether to give acetron. Simple. There are bleed score, and all cardiologists depend upon bleed score. So there is nothing a super specialist is doing as long as technology is concerned and it is available to you at all levels. Training tools. Then comes TRP. What's TRP? TRP I mean in the form of the media. So utilize the media properly. Social media is not there for forwarding messages. Create your message and forward it to all your patients. That now onwards in my clinic so-and-so facilities will be available. Or on so-and-so date we could salvage a patient's life. Don't name the patient. Salvage the patient's life by doing CPR. This is something you can definitely forward without naming anybody. Right? So use social media, have brochures. You can print out brochure and simple things. A patient suffering from constipation, look for 5 things. A patient suffering from diarrhea, look for 5 things. Have printed material. All these things are so easy to do, and just give 5-10 minutes, create it, and then hand over to the patient of constipation along with your name and address, your availability. So you can do YouTube rather than posting anything silly. Why don't you put a 2-liner, 2-minute message on YouTube?
You have 2 minutes.
I'll finish. Teamwork. Again, you should have a team like suture specialist or geriatric skills and work. Refer to them. Why do you refer to? Specialists. Tough health. Remember, you must be absolutely healthy if you really want to practice till 80. We see family physicians working till 80, and that's all because of the fitness. So your diet, your exercise and your sleep should be perfect. Again coming to tight auditing. Jare free बैठा हो, जब भी आप free है, open your previous cases. How many patients did not come back? Why did they not come back? Give a thought to it. In how many patients the fever did not subside within 5 days? How many patients had to be referred? Auditing is the best way to improve your scope. And Then comes, last but not the least, you all know the story of this gentleman. He was sitting in his veranda one evening. ZTV was shooting from outside that he is supposed to sell jalsa, and everybody was on the toes. He had brought 2 rented cars to put in the portico, and then suddenly he realized that my father used to say that do only those things where you are expert. And then he went to Yash Chopra and got Mohammed. So, what is the thing, message? The message is have introspection. Why my father was a successful physician, family physician? Why my father's father was a successful family physician? Ask for the answer. Try to go back a decade or so. Why my practice was 100 patients a day, now it has gone down to 10 patients a day. Why a family physician was so favorite of families? Because he knew the families. He knew every person of the family. Why did he know? Because he was not only a part of medical treatment, he was a part of their happiness and sorrows both. And why? What was the reason? And the answer is very simple. He devoted time. Most of the newer
time is over, sir.
My last thing. So because he devoted the time, lot of time. सब सुबह से लेकर शाम तक वो लोग वहाँ बैठे रहते थे, and people knew that they would be available. They did not think that I need to give 6 hours to my family, 3 hours to my son. That is not a family physician. Pardon me if I am little rude, little hard, but the newer family physicians have cut down the time very drastically, and that is probably one of the reasons why the scope of family physicians have gone down. So, with the national trend indicating a more narrow scope, it is not true. You can still do it, and you can do it with the help of updating yourself, use your resources to the fullest, keep yourself fit, and most importantly, a family physician needs to give more time to patient's family than his own family. So, try to be indispensable for the family, create an out-of-the-crowd image. Thank you very much, and don't forget to attend Lost Paradise, which is being organized by the committee. Very nice program. Thank you.
Thank you very much, sir, for your very informative talk. The memento will be given by Dr. Gunjit Parmar.
Those who are out of Ahmedabad, I am giving a brief introduction of Dr. Urman Bhai. He is our beloved teacher. We Ahmedabad family physician all are very thankful to him. He has conducted so many lectures. He has updated our knowledge quite a lot. He is a director of HCG hospital, and he has arranged so many lectures particularly for family physician in his hospital. So we are very much thankful to him. And today also he has given a very good talk on this good topic. Thank you.
Good morning. I invite Dr. Sorin Shah to deliver a lecture on recent advances in joint replacement surgery. Dr. Sorin Shah. Thank you.
Good morning, everybody, and thank you very much organizing committee of AFPA and all organizing members for having me here. Now my topic is recent advances in the joint replacement surgery. We all know that joint replacement first thing comes in our mind is a knee replacement surgery, but I will speak little bit about hip replacement and shoulder replacement also. We all know that knee replacement or joint replacement surgeries are very much successful. Like we may say this is one of the 5 successful surgeries in all surgical field. But when we come out of the operation theatre as a surgeon, we are happy. But when at the line of 6 months or 1 year or 2 years, the 10 to 20% patients are not happy, and that is where the advancement comes. The advancement I usually elaborate in the terms of the techniques, technology and material. And what about the techniques? First we speak about, I will speak about total knee replacement. Nowadays more than 50% of the patient we are using a hypotensive anesthesia. Hypotensive anesthesia is, we are thankful for new medicines which are available for hypotension and controlled hypotension. So we don't use tourniquets. Tourniquets are the bait we use for decrease the blood supply, stop the blood supply of the limb to decrease the blood loss, but it causes myonecrosis and muscles injury. So post-operative pain is very less when we are not using these tourniquets in the surgery. At the time of the surgery, it is not advanced, but it is now a routine that we are using minimal invasive surgeries, the subvascular approach, no muscles cutting. And out of the 4 ligaments in a conventional TKR, the 2 ligaments are cut, anterior cruciate and posterior cruciate. But in many designs now we are used to cut only anterior cruciate ligament, and posterior cruciate ligament is preserved. So proprioception after surgery is very good. And quick and quick out surgeries. Quick and quick out means after skin incision, last stitch is usually 30 to 40 minutes only. So operative time is very less. And again, use of tranexamic acid and hypotensive anesthesia, blood loss is very less. This is routine for us. Now this is advancement, what we are calling a kinematic or functional alignment. I will elaborate something like that. If you see your legs, normal knee is, the femur is like that, and the tibia is little bit of valgus, 3 degree of valgus on an average for a majority of the patient. So when I stand like this, the normal tibia goes 3 degree of valgus from the femur. It is known as mechanical alignment or anatomical alignment of the patient. But when the patient is having a varus deformity, patient ऐसे चलता है जब, तो उसका kinematic alignment is changed. So what newer advancement is कि when this deformed leg we are changing to mechanical axis of almost normal 3 degree of valgus, the patient is having a lot of stretching pain and uncomfortable feeling. So nowadays the kind of anatomical kinematic functional alignment, that means we are keeping little bit of varus for that particular patient, and then they are very happy. The advantage is very less soft tissue releases and post-operative recovery is very fast. So this is very new, the kinematic or a functional alignment of the patient. A stitchless surgery. Stitchless surgery means it is not like we are not taking the stitches, but we are taking stitches. But for the skin itself, we are using something called zip lines or some Fevikwik like a glue, which used to stay there for 20 days. But after 20 days, just patient has to remove that zip line or just remove the dressing. There is no need to remove staplers or some suture materials. So post-operatively, when patient comes to our dressing room for stitch removal, he is very much scared about sir pain hoga, ye hoga. But this is the technique where we have to spend 5-10 minutes more during the stitch. During the surgery, but this is very helpful for the patient, especially outside of the city patient or overseas patient. And post-operative pain control. Nowadays we are having a very good pain control. We are giving intraoperatively cocktails. Cocktails contains of local anesthetic agents, clonione and analgesic, as well as in some selected patients steroid injection. So decrease the inflammation and pain after the surgery. Along with the femoral nerve block or adductor canal nerve block, USG guided adductor canal nerve block. Patient is having a no pain or other less pain during after surgery. Patient कभी-कभी ये भी बोलता है कि सर सर्जरी में तो पता ही नहीं चला, घर जाके पता चला कि सर्जरी हुई है. So this is a really good thing for the patient because जो patients are very scared of the surgery, post-operative pain specifically. So this is the good technique for the pain control. And this is not the advancement, but this is what we have achieved by this kind of techniques, no tourniquets, hypotensive anesthesia, quick in, quick out, and less tissue trauma, and absolute aseptic control with the antibiotic protocols. We have achieved a zero infection rate since last 8 years. Initially when we were researched, it is said that 1% infection rate to hota hai, it is good. It is good result rather. It is not good but good result because 99% का infection नहीं है. But nowadays, zero infection rate is our target and we are achieving that. Now about technology. Technology in terms of the implant. Now newer designs are very, we all know that there is a high flexion variety. We can ask the patient to sit cross-legged, to take Vajrasana or a Namas position with the high flexion of joints. High flexion variety of joints. It is very low profile. Low profile means weight may it is less and the weight is less and the profile means the thickness of the joint is very less. So patient को heaviness नहीं लगती after surgery. And many companies, 2 companies are having Anatomical tibial base plate. Tibial base plate means we all know there is a femoral component, tibial component, and a plastic in between. The tibial base plate is a side specific right and left, so more of a natural filling of the joint. And during the surgery, we are having almost 11 sizes. We all know that ऑडिटोरियम में जितने भी लोग बैठे हैं सबके शर्ट की साइज, पैंट की साइज, कपड़े की साइज अलग होती है. बट एट द सेम टाइम नी में भी ऐसा ही होता है कि सबकी नी साइज अलग होती है. मैनी कंपनी हैज डिजाइन्स विथ हैविंग 11 साइज ऑन टेबल टू चूज फ्रॉम. Approximately 1 to 2 millimeter of differences are there. So again, it causes less stuffing of the joint, and patient is feeling a very natural kind of a joint post-operatively. Continue with the technology. Newer designs are medial pivot design. Medial pivot, we all know that knee joint is a hinge type of joint, but it is not the simple hinge. The hinge with the abduction, adduction, rotation and transition movement, and it is a medially centering and laterally rotating knee joint. Everybody is having in a natural knee system. The same thing, some companies are having a medial pivot design. It is a kind of a rotating knee which gives a very kind of a natural feeling. It is again with a very few companies are having, only 1 or 2 companies are having the same. And a bicruciate retaining. Bicruciate means we are not going to sacrifice any ligaments. It is not in the pipeline, not yet launched in India, maybe in some centers only. But one company is having that, and we are looking forward to this design. So proprioception and post-operative feeling of the patient is very good. So ultimately, with the technique, with the designs, and we can pick out less tissue trauma, infection control. What we are achieving is absolutely great result. With almost many patients can sit cross-legged after the surgery. Another advantage or advancement is a design in a technology. This is a unicondylar knee replacement surgery or microplasty or half joint replacement. You are going to have a dedicated lecture for this particular thing. The concept is the first figure you can see on the left side is the total knee replacement. The middle one is the arthritic joint. We can see on the medial side there is arthritic, lateral side there is a preservation of the cartilage. So on the third figure X-ray you can see only half joint has been replaced and not the total joint. The advantage is again a small incision, very natural feeling. Patient can go 3rd, 4th day immediately stair climbing and cross leg sitting, and 20 days he can go back to the work. And initially it was thought that it may not last long for 5-10 years, but nowadays it has been said that with particular designs it can last for more than 15 years. Now the talk of the town is robotic knee replacement surgery. Again you are going to have one dedicated lecture for the same, but in the shortly speaking, it is a computer assisted surgery with the robotic arm, and the surgeon is always in the control. Only one slide for that. Advantages of that particular thing is it is a highly accurate implantation for the particular patient. And मैंने तो पहले बोला जो kinetic alignment और functional alignment we can achieve very good with the robotic knee replacement surgery, and it is a high satisfaction ratio at least for the surgeon. जब OT में से बाहर आते हैं तो वो बहुत अच्छा surgery हुआ है. But the clinical significance yet to come out with the long term results. It is a cost effective. There is some cost for this newer advances. In some robotic system, there is a radiation CT scan करवाना पड़ता है pre-operatively. So patient is exposed to the radiation, and there is always time for the surgery is 10 to 15 minutes more. Now to increase the longevity, normally जो knee use करते हैं so COCR metal होता है, but to increase that up to 30-40 years, the newer material is gold or opulent material. It is not the original gold. It is a titanium nickel alloy. Some companies are having an oxidized zirconium material. This company is having oxidized zirconium since last many years, and Australian registry has published that it may last for more than 35 years, 30 years to the patient. Now this is again PIC material, polyether ether ketone material. It is now in research phase. It may come. The advantage of this material, the material is a radiolucent, and second advantage, the density is same as the bone. So patient को जो heaviness लगता है after surgery, it will be not with the PIC material, but it is not yet in the market. Now something about the hip replacement surgery. We all know that the advancement, and now we are routinely doing is a minimal invasive hip replacement surgery. Minimal invasive means initially we used to take 12-15 centimeter of incision, but nowadays you can say it is almost 5 or 6 centimeter incision with minimal tissue trauma. And again, one more advancement is that initially we were doing 90 to 100% of the surgery with the posterior approach. Posterior approach means पीछे से फीमर को हिप को खोल के सर्जरी करते हैं. The disadvantage of the posterior approach is it may cause hip dislocation in 1 or 2% of the patient. Even if implantation is very good, ambulation is very good, सब कुछ सही किया है, फिर भी hip dislocation के chances रहते हैं. The direct anterior approach जो anteriorly हम hip को खोल के करते हैं, it is a newer thing and newer approach which causes dislocation rate to nearly 0%. So in selected cases, in non-hefty patient, now we are doing this anterior or a direct anterior approach for hip replacement surgeries. Robotic hip replacement is not yet that common, but it is in few centers in India they do. It is not totally robotic, only acetabular part is done by the robot itself. Not going much detail about that. Materials we know that for the hip replacement initially it was a chromium cobalt material, some ऐसा बोलते हैं steel use करते हैं, but nowadays in majority of the patient ceramic में भी काफी सारे टाइप के ceramics आते हैं. We are using a delta ceramic with a highly cross-linked polyethylene with vitamin E impregnated. What is vitamin E impregnated poly? Is the antioxidant quality of that particular plastic is very good. So wear and tear जो कुदरत ने बनाया, भगवान ने दिया, वो भी अगर घिस गया तो जो man has manufactured उसमें भी घसारा लग सकता है. So this ceramic with the highly cross-linked vitamin E poly gives tremendously good result for more than 30 years. One more advancement is the dual mobility hip replacement surgery. Dual mobility means a double bearing hip replacement surgery. We are using since last 2 or 3 years, and it is available in India since last 4 or 5 years. It is also newer for the India but not for the world, using since last 20 years in the France. The advantage of this particular thing that it is almost natural kind of a movement with longevity when we are using a ceramic head, and this highly cross-linked polyethylene may last for more than 30-35 years with a cementless joint. And last slide is for shoulder replacement. Only one slide is there. It is very rare to replace the shoulder. But nowadays, shoulder replacement is there for shoulder arthritis, severely comminuted 4-part fracture of the proximal humerus, and rotator cuff में जिसमें degenerative tear हो गया है, उसमें कभी-कभी severely painful होता है, not really with the physiotherapy or any kind of medicine. Then we are advising shoulder replacement surgery. Conventional shoulder replacement, we know that the shoulder is a ball and socket kind of a joint. But this ball and socket में जब reverse कर देते हैं, ball की जगह पे socket और socket की जगह पे ball मतलब humerus head की जगह पे socket आ जाता है, glenoid की जगह पे हम the globe आ जाता है. So it is a reverse shoulder kind of thing. There is no need for rotator cuff in this particular design. Deltoid muscle जो होता है वही पूरा take over करके पूरा shoulder movement करता है. It has a very good result nowadays. So whenever in doubt, we are going for reverse shoulder replacement surgery. And thus in summary, newer designs in a more natural feeling with increased range of motion, newer materials increase the longevity more than 30 years, improvement in the techniques, kinematic functional alignment for the knee, and minimal invasive techniques for the fast recovery, and increase the satisfaction of the patient. Thank you very much, and this is just to show our result for the knee replacement surgery. We are used to gather the patient every year and make them to play Garba. This is show the confidence of the patient after knee replacement surgery. Thank you so much.
Thank you, Dr. Sotin. I invite Dr. Ashok Thakkar to give memento to Dr. Sorin. Now I invite Dr. Hitesh Chawla sir to focus on acute abdomen and red flags. Sorry, acute abdomen, red flags. Dr. Hitesh bhai. Thank you.
Good morning everyone. I thank AFPA NATCON 2023 for giving me this opportunity to speak on acute abdomen. I am going to speak on GI topic after a long time. So acute abdomen means a sudden, spontaneous, non-traumatic, severe abdominal pain, typically less than 24 hours. It's very challenging to handle a patient with an acute abdomen. We manage such patients day in and day out. There are a lot of diagnostic possibilities from life-threatening condition to a self-limiting condition in an acute abdomen. It can be a common cause or it can be a very unusual reason for having an acute abdomen. So the recognition of the surgical or life-threatening complications related to acute abdomen is very important rather than reaching to a firm diagnosis with this patient. So there are different type of pains that a patient will experience depending on the site of origin. So it can be a visceral pain due to the embryological innervation of that particular organ. For example, acute appendicitis pain will be in the right iliac fossa. Pain of acute pancreatitis is going to be in the epigastrium or radiating to the back. It can be a parietal pain because of irritation of parietal peritoneum, So depending on the organ which is affected and irritation of that area will cause pain in that particular site. It can be a referred pain. For example, a pain of ureteric colic will get referred to a groin. So this is important to recognize where the pain is originating. So you can see there are 9 quadrants and there are so many differential diagnoses when we see a patient in emergency room with acute abdominal pain, and to pinpoint to a particular diagnosis is extremely challenging. So if a patient has a generalized pain, it can be perforation, it can be mesenteric ischemia, it can be acute abdomen due to aneurysmal rupture, it can be acute pancreatitis, or it can be something non-surgical like diabetic ketoacidosis. If it is central or radiating to back, it can be small bowel obstruction, it can be appendicitis, it can be acute pancreatitis, it can be mesenteric vascular thrombosis. So depending on site of the origin, site of pain, you can localize which organ is affected. If it is in epigastrium, which we see commonly, it can be gastritis, it can be a gallstone disease, it can be a CBD stone, it can be acute pancreatitis, it can be aneurysmal pain. The right iliac hypochondriac pain can be commonly because of acute cholecystitis, can be duodenal ulcer, pancreatitis, or it can be subphrenic abscess. So depending on site of origin, we have to have some differential diagnosis in mind when we see such patient in emergency room. So even a urinary retention, patient having hypogastric pain likely to have urinary retention, or a UTI, cystitis, or a PID in female patient, or an ectopic pregnancy, patient has missed the period, or diverticulitis. We see diverticulitis very commonly now in elderly patient. So common presentation is pain in right iliac fossa that we see because of appendicitis. It can be adenitis in young patient, ileocecal tuberculosis, PID, salpingitis in females, rarely Meckel's diverticulosis or inflammatory bowel disease. So depending on site, you reach to a conclusion that this patient might have this as a differential diagnosis. You have to keep in mind the referred pain. If the patient is having pain in right iliac fossa, it can be a perforated duodenal ulcer. If patient is having pain in groin with symptoms of UTI, it can be a ureteric stone. So referred pain is also very important when we see a patient with acute abdomen. So the approach has to be, first see the patient, resuscitate, take a detailed history. History will give you lot of idea what exact origin, what is the differential diagnosis, what diagnosis you have made, and then you focus on investigation after examining the patient in detail. So the site of origin, the nature, the character, the duration, the intensity, the precipitating and relieving factors and associating symptoms, this will all give you an idea. Any previous episode of pain, any previous surgery, any investigations, or whether patient has taken any medications or not, whether patient is immunocompromised or not. So all this will give you an idea what patient is presenting with and what is going to be your diagnosis. Now, when you look at the patient, how he is sitting, how he is lying down, whether he is bending forward, whether he is moving his abdomen or not, this will all give you an idea how is the abdomen, whether it is distended, whether it is scaphoid. So all this will give you an idea what exactly you are dealing with. So inspection and palpation, these are all important things when we examine a patient with acute abdomen. We must look for hernial site. We see many a times patient coming to emergency room with abdominal pain. If you don't examine groin, you are at fault. We do see patients with strangulated hernia, strangulated femoral hernia in females, strangulated inguinal hernia with acute intestinal obstruction. Many a times in obese patient, this is a very misdiagnosis because the groins are so loaded with fat, you don't recognize inguinal hernia there. So we must see for all hernial sites. We need to see for the area of tenderness, the rebound tenderness, guarding, rigidity, all these when we examine such patients. So it's easy to recognize pain of appendicitis when there is a tenderness in right iliac fossa. It can be something else like salpingitis. If there is a generalized distension, generalized tenderness, the simple tests are X-ray abdomen standing or X-ray chest to see for free gas under diaphragm. This is the test that we used to do when we are doing our residency, and there has been a lot of advancement now. The other thing that is done is an ultrasonograph. So you can see these two pictures. The first one is intestinal obstruction. The X-ray is taken in erect position. The other one is in supine position. So even supine X-ray is fine. You will reach to a diagnosis when you do an X-ray in supine or a standing position. The ultrasonography is another tool which is easily available. It's non-invasive. It will give you an idea of what you are dealing with. If your ultrasound is not conclusive, if you are not satisfied, then there has to be a low threshold for doing a CT scan. CT scan is a very good investigation, now very easily available to rule out any critical issue inside the abdomen. So you can see when there is a retrocecal appendix which is not seen on routine ultrasound, CT scan is a very good investigation which will find a retrocecal appendix which is inflamed, which is usually missed in routine ultrasound. Even a perforation, when you do an X-ray, if there is a small perforation, there may not be a free gas. CT scan is very, very sensitive investigation to find out perforation. So even in emergency situation when even the renal function tests are altered, we do a plain CT scan abdomen to see for free gas. This is routinely performed by most of the practitioners when they deal with acute abdomen. So even a plain CT is fine. You can see in this picture there is a small amount of free gas which is seen, and there is a free fluid. Everything you will have a judgment what you are dealing with. You can see this patient has a mesenteric vascular occlusion with gas in the bowel wall. So all this can be seen even in plain CT scan. You will realize this patient is developing mesenteric ischemia, it's an acute abdomen, or there is a perforation, even diverticular perforation, some collection, even pelvic area. This all can be easily seen on acute abdominal injury or mesenteric ischemia. In such patient, we may have to offer them a diagnostic laparoscopy before we go for a major surgery. So this type of investigation, so laparoscopy may become diagnostic as well as therapeutic. So you can see this patient had a small band. This band was causing obstruction in the small intestine. So this band is very rarely seen on a CT scan. We realize that there is some blockage, but this can be easily seen on laparoscopy and can be dealt with at the same time. So you can see the band of the intestine was released and this patient got relief of the pain. So you will see a large area of strangulation in that place. So this is the area where you will see the obstruction was there. So this can be seen very nicely on laparoscopy. These patients usually go home in a day or two. So this is a very important tool when there is no clear-cut diagnosis and you feel that there is something wrong, then diagnostic laparoscopy can be performed. So what are the red flag signs? When you take a history, you will realize that this patient has some critical problem. Sudden onset, severe pain, pain that disturbs the night, migration of the pain, pain on movement because of peritonitis, inability to take oral intake, patient is not eating, means there is something wrong. Fever, pain out of proportion, especially when we see patients with mesenteric ischemia, elderly patients, patients with GI bleed. Another thing is when you examine the patient, you must see for signs of shock. If patient has hypotension, patient has cold extremities, tachycardia, tachypnea, septic appearance, confusion, signs of dehydration because of peritonitis, rigid abdomen, absent bowel sound, patient lying still, not moving. All these are, you can see this picture, these are called Hippocratic phase, means impending death. So we do very less often see such patients now. We used to see them when we were in residency, but this means patient has septic shock and has severe sepsis and needs intervention. So according to what you examine, according to how you take the history, you will have these red flag signs that what you are dealing with and how to approach such patients. As already mentioned, there are medical causes of acute abdomen that also we have to keep in mind and must see for all such patients where you don't find any surgical causes. So you can see this small video where there is a perforation. This video was taken at the time of COVID. You can see this gentleman had a diverticular perforation with severe peritonitis. It was not seen on an X-ray. It was not seen on sonography. It was seen on a CT scan that he has perforation. So you can see these are jejunal perforation, multiple jejunum with diverticulum and perforation. So you can see edematous bowel. Usually the diverticulum is on mesenteric border. So you can see multiple jejunal diverticula which are inflamed and perforated. So these can be easily seen on a CT scan rather than doing an ultrasound or an X-ray. So you can see this is a patient with multiple perforation in jejunum in the small bowel. So you can see another patient. Whole bowel is gangrene. This is called mesenteric ischemia. The almost entire bowel, large intestine, small intestine, everything is gangrene. This can be seen on a CT scan. CT scan will show you occlusion of the vessels. It will show gas in the bowel. This all can be seen on a scan and then you can diagnose. You can see even the large bowel is, and even gallbladder is gangrene. So there was a massive infarction of all this area and this patient developed acute abdomen. This is a patient with perforation. Can you see this is the colonic perforation? So this small leak can be picked up pre-operatively early if you investigate them properly. You can see there was an area of perforation in the large intestine. You can see there was leakage of fecal material. So it is important to investigate such patients properly depending on how we examine, how we investigate the patient. So the take-home message is an acute abdomen is extremely challenging. Please don't restrict your diagnosis depending on the site of pain. It can be something else. Elderly patients will have more likelihood of having a surgical abdomen. So you have to be very careful because you will have to intervene them early. There has to be a low threshold for CT scan. It is easily available. It should be done. An outcome of treatment will depend on early identification of cause and early intervention, because acute abdomen, if you miss the opportunity, patient will become sick. Early referral to a specialist center is very important, and there has to be a multidisciplinary team of a surgeon, of a senior physician, a team of intensivists and anesthetists to have a good outcome in any patient with acute abdomen. Thank you very much.
Thank you, Dr. Hitesh Bhai Chavda. Now I will invite Dr. Rashmin Prajapati to hand over the memento to Dr. Hitesh Bhai. Very nice, informative lecture. Thank you, Dr. Hitesh Bhai. Thank you, Dr. Rashmin Bhai. Now I invite Dr. Tushar Patel for the lecture of newer management of tuberculosis.
Good afternoon. First of all, I would like to thank the AFPA NATCON organizing committee for giving me opportunity for in this conference. My topic is recent advanced newer management of tuberculosis. Tuberculosis we know all time in ancient era is Kshay Rog and tuberculous organism discovered by 24th March 1882 by Robert Koch. So we are doing World TB Day on 24th March. Global burden of tuberculosis in 2018 survey of WHO incidence around 10 million cases throughout the world and 2.69 million cases in India, and around 27% of tuberculosis cases in India. Mortality rate is also high in India, 4.40 lakhs, and MDR cases around 1.30 lakhs cases. 24% of global burden MDR cases seen into the tuberculosis in India, and child with tuberculosis also incidence is high in India, 3.42 lakhs cases in India. Newer National Drug Resistance Survey done into the 2014 and 2016, drug sensitive newer cases of drug sensitive case 3,000 cases. Among the 3,000 cases, 77% are drug cases, are all susceptible cases, but this is MDR cases newer they are taking a AKT. Previously 2.84% cases of MDR cases. In overall TB cases, around MDR cases is 6.19% cases of MDR cases in India. That's why we need a diagnostic challenge for tuberculosis and newer aspect of drug detection of the TB. For current diagnostic need for tuberculosis, for detections whether the TB or TB presence or not, differentiation NTM mycobacterium tuberculosis or NTM drug resistance, patient is drug susceptible TB or drug resistance tuberculosis, monitoring to the response of the TB, patient on AKT, patient is responded to the anti-tubercular drugs or not, and then transmission and control, patient having the persistence put on positive may transmit to the community or not. This is this 5 current diagnostic need for the tuberculosis. Diagnostic tool for tuberculosis is simple sputum microscopy, ZN stain and fluorescence microscopy. This is a primary tool for the tuberculosis, diagnosis of tuberculosis. Then radiology, X-ray chest we see the consolidation, cavitations, fibrocavitary lesions, bronchiectasis. This is type of findings we see into the tuberculosis in tuberculosis cases, in smear negative pulmonary tuberculosis cases. Also, a CT scan is very helpful for the diagnosis of tuberculosis. CT scan we see the tree inward appearance, the consolidation on the CT scan finding, and culture and drug sensitivity test for solid culture medium, LJ media, liquid culture by the MIGIT 960 diagnostic system for first and second line drugs. Then molecular test, nowadays a very widely used test we are using for the diagnosis of tuberculosis as well as diagnosis of drug resistance cases for CBNAT, TrueNAT, Ultranan and Line Pro SA3 diagnostic tool for the molecular testing for the tuberculosis. First, sputum microscopy. Simple, easy, widely used and acceptable diagnostic test for tuberculosis. In Zn stain and fluorescence microscopic test, we see the reports of various sputum microscopy is a simple, inexpensive, require minimum training, highly specific, highly reliable, inter-reader variable is a different result available very quickly result, and this test is used for microscopy for diagnosis, monitoring and cure. And microscopy we see the result like scanty or scanty 1 to 9 bacilli for 100 oil immersion print, and 10 to 99 plus 1, 1 to 10 plus 2, and 10 to 99 in per oil immersion print plus grade 3 sputum positivity. For microscopy, sensitivity around 70%. It's detect the tuberculosis, yes. Microscopy if sputum positive, positive means positive tuberculosis. For the drug differentiation between tuberculosis and non-tuberculosis mycobacterium not detected by the sputum microscopy. Drug resistance is also not detected by the sputum microscopy. Monitoring to response to the treatment, yes, because patient having a persistent, in spite of patient on treatment and persistent positivity of microscopy, then it detect the tuberculosis positive continuously. And transmission to patient having a drug persistent sputum positive and patient having a sputum positive patient, it might be transferred to the community. Newer modalities of treatment since last NETP program widely used now. All patient having those who are positive for the pulmonary tuberculosis, this test has been done into the government program, freely available by the nearby center of government, and also widely used in the all microbiological lab. This is a molecular based test, RT-PCR test, and its major advantage of this test is no biosafety cabinet available, closed system available, and easily detect Mycobacterium tuberculosis as well as RPOB gene rifampicin resistance is also detected at the same time. In this test, only we will get result within 2 to 3 hours after giving a patient sample, and then sample is processing into the lab, and lab we are getting a result within 2 to 3 hours in Gene Expert. Advantage of role of Gene Expert, advantage of it detect the Mycobacterium tuberculosis, yes, is detect the Mycobacterium tuberculosis, but differentiation is very crucial role of the Gene Expert into our practice. Is the differentiate between Mycobacterium tuberculosis and non-tuberculous Mycobacterium. If sputum microscopy is positive and Gene Expert is positive, then Mycobacterium tuberculosis and microscopy is positive and Gene Expert is negative, then non-tuberculous Mycobacterium. This is a key point for the role of Gene Expert. Then it's detect the resistance detected, yes, it's detect the also rifampicin resistance is also detected. Now a newer kit is also available, then Gene Expert XDR kit is also available for the detection of the drug resistance tuberculosis and first line, second line drugs detection into the treatment. And monitoring to the response, currently there is no response, not available, research work is ongoing. Transmission and content control, yes, because persistent patient having a Gene Expert positive, then might be transmitted to the other, it can be detected. Gene Expert detection limit is 131 colony-forming unit per ml. Is simple Gene Expert, and now a new modalities is available, Gene Expert Ultra 16 colony forming unit per ml. It's detect the bacilli. Gene Expert Ultra is mainly used for CSF, and Gene Expert normal used for the sputum, tissue, lymph node tissue, any tissue, pleural fluid, ascitic fluid. Then Gene Expert simple use. Gene Expert Ultra is mainly used for the CSF. These are Gene Expert XDR, INH, ethambutol, fluoroquinolone and amikacin, and be detected by the Gene Expert XBR, new available. Our newer machine is also a TrueNut, our purely make in India project, and this one is a TrueNut machine, is easily available in all point of care like PHC, CSC level, very effective battery operated system. It's detect also rifampicin and also a drug resistance. So very effective treatment diagnostic tool for that in TrueNut also. Another tool for this Line Pro assay is a PCR based test. Line Pro assay, first line and second line LPA was done after the patient detected sputum positive. Then first line and second line LPA will be done. First line LPA is detect the RPOB gene for R rifampicin resistance and CATG gene and INFJ gene for the first line LPA, and second line LPA, Gyri A, Gyri B for fluoroquinolone resistance detected. And then roll of LPA is detect from directly from the specimen, not from specimen. Culture medium is required. Differentiation between the NTM and microbacterium done. And drug resistance detected. Yes, rifampicin, isoniazide, fluoroquinolone, and aminoglycoside. Transmission is not detected. This is a newer drug susceptible test, DST direct MIGIT with culture medium we are using. Very rapid, fast, like the previously conventional LJ medium, solid culture medium, liquid culture medium is very rapid and fast. We will get result within 42 days, and DST report we will get within after 42 days, within 40 to 26 days. Role of MIGIT, it detect the mycobacterium tuberculosis, differentiated between NTM and yes, all drug resistance first and second line, and monitoring to the response to treatment in MDR cases, yes, and transmission is not. Whole genome sequencing is a newer diagnostic tool very rapidly. In this also directly, this is not done from directly from the specimen, but it is growth is taken from the culture medium, and whole genome sequencing is done, and all first second line drug resistance can be detected. Which patient all patient who first line therapy is failed, first and second line therapy failed, then patient who relapsed from the mycobacterium tuberculosis, and patient who is contact with HIV, diabetic side, high cases, this can be used. Other tests for the diagnosis of tuberculin test and IGRA, we are using TB gold test for the latent TB diagnosis for latent TB in mostly in organ transplant patients. Serological test is also nowadays a ban in India. This IgG, IgM, LMA assay mostly used into the tuberculosis patient. CTB skin test, newly next generation tuberculin test is available. It's newly diagnosed the method for the tuberculosis. Now management of tuberculosis, treatment for drug sensitive tuberculosis. Now a fixed dose drug regimen is come for HERZ. No regimen should be separate regimen for the extrapulmonary tuberculosis. Now a government has a rule for the streptomycin is not used into the NETP program. They are removed from the injectable, all injectable removed from the government tuberculosis program. And now also in various cases AKT is also given for the 3 to 6 months, but some of the cases extension may be for more than 3 months or 6 months, like bone TB, spiral TB, neurological involvement, and also a recommendation for the newer guideline recommended TB meningitis and pericarditis for steroid for the newer TB meningitis and pericarditis for more than 2 months. Treatment for drug sensitivity tuberculosis, fixed dose combination, which increase the simplicity of treatment, increase the patient acceptance, increase the healthcare worker compliance, and drug easily management by the drug to the patient, and reduce the monotherapy because less chances of patient we prescribe separate RFP, ethambutol and pyrazinamide, then chances of monotherapy taken for patient has more chances, or less chances of in this FDC, less chances of drug resistance tuberculosis. This is a weight band regimen. Drug resistance, rifampicin, RR resistance means resistance to the rifampicin. MDR cases which presents sputum sample or any biological samples resistance to the first line like INH and rifampicin called MDR TB, pre-XDR rifampicin INH along with any quinolones resistance. This is a pre-XDR and extensive, now a newer definition of extensive XDR cases, resistance to rifampicin, INH, fluoroquinolones along with group A drug like bedaquiline or linazolid. INH monoresistance. Newer drugs for group for drug resistance tuberculosis group A include levofloxacin, moxifloxacin and bedaquiline. Group B include linazolid, clofazimine, cyclosporin and tazobactam. Group C ethambutol, delamide, pyrazinamide, imipenem, meropenem, amicacin, ethionamide, prothionamide and para-aminosalicylic acid. These are newer drug classification A, B, C group of MDR cases drugs. These are a dose of various drug treatment like up to now a newer various trial also done. Rifampicin give up to the 750 milligrams and according to the weight pain, and now shorter regimen high dose INH up to 900 milligram we are giving. Ethambutol, pyrazine, this is a weight pain different high dose moxifloxacin we are using up to 800 milligram. But watch for the various side effect of these drugs. Newer drug resistance, shorter bedaquiline regimen used into the indication in rifampicin resistance case INH, KG or INHA or fluoroquinolone resistance is not detected. In such cases, a shorter regimen used. Shorter regimen include 4 to 6 months bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose INH and ethionamide, and then 5 months levofloxacin, clofazimine, pyrazinamide and ethambutol. This is a shorter regimen up to 9 months. This and in shorter regimen no one injectable drug is used. And all-time longer regimen of drug resistance tuberculosis 18 to 20 months, levofloxacin, bedaquiline more than 6 months, linazolid, clofazimine and cyclosporin. These are regimen for INH monotherapy resistance 6 to 9 months.
Please conclude, sir.
Yeah, okay. These are newer medicine, bedaquiline, delamide and proteomid. Newer medicine is available. They are newer tuberculosis. Now a government program is also to include the tuberculosis preventive therapy. In preventive therapy, 6 month INH for the close contact of the tuberculosis patients or rifampicin and INH combination for 3 months. And patient those who are drugs resistance tuberculosis 6 months for MDR cases 6 months levofloxacin, and if patient having only INH resistance rifampicin for 4 months. This is a TB preventive therapy. Thank you.
Thank you, Dr. Tushar. Now I invite Dr. Ashok Thakkar to give memento to Dr. Tushar.
I hope you have enjoyed Dr. Tushar Bhai's talk. Actually, nowadays we family physicians are not treating tuberculosis because there is a very huge help by government of India, and government of India is planning to eradicate tuberculosis from India in 2025. So government is requesting all of us mainly to notify tuberculosis disease. I request all of you, please notify your tuberculosis disease. Either you treat or you treat by your government agency, because while you are notifying the disease, there is a huge benefit, like family members of affected persons are also evaluated for tuberculosis. Then certain help is also given to the patient, even help to us is also given. So I request all of you to please notify your tuberculosis patient. Thank you. And now after the end of the second session, we will and the answer was patiently listening to your patients. It was correct answer. So now quiz for the second session is coming on the screen. So all of you are requested to go on the website www.afpa.co.in/quiz. See, this question is very simple. I think you don't require even 15 seconds to answer. Even though we will give half a minute, but you have to be very quick, because prize will be given to those who give the first correct answer. So be ready. All of you downloaded the site? Ready? So question is coming on your site. Please upload. And we are counting the minutes. Answer is very easy. Seconds passed, and now I declare the winner, Dr. Karthik Shah. Dr. Karthik Shah, and I request Dr. Tushar Bhai to give a prize to Dr. Karthik Shah. Question was, the following drugs are new anti-TB drugs except bedaquiline, dilamanide, pretomanide and ethionamide. As you all know, ethionamide is an old drug, and this bedaquiline, dilamanide, pretomanide, all these are new anti-TB drugs. So now I request to start the third session.
I invite Dr. Chirag Soni who will be nominated to reporter Dr. Gunjit Parmar. Thank you. Now we will be nominated to chairpersons Dr. Ashok Thakkar and second one Dr. Rasmi Prajapati.
Thank you, Chairperson and rapporteurs.
Now Dr. Chirag Soni come on as rapporteur of third session.
So now I would like to invite chairperson of this session, Dr. Om Prakash from Indore and Dr. Pamela Ghosh from Kolkata. Please welcome, sir.
Our 12:30 to 1:15 session is postponed on the post lunch, so we will extend the session up to 1.
Please come Dr. Sanjay Prajapati, clinical practice pulse in hypertension. Thank you.
Good afternoon and thank you AFP NATCON committee to invite us for the this presentation and invite us to give a esteemed presentation against the esteemed audience. Today's my topic is practice pulse in hypertension. We know that our routine daily OPD, almost more than 50% of our OPD, outpatient department as well as some inpatient, is always come with an hypertension. So if you see a overall presentation or overall prevalence of the hypertension is almost a 30% and always a male prevails more than the female patients. This is one pool data which shows that if we treat the patients, almost a 17.5% of patients was properly treated in the outpatient department or for the hypertension, but and that too of mainly the west as well as the south regions of the India was mainly treated properly for the hypertension. But despite of the proper treatment for the hypertension, only 1 out of 4 patients in a OPD which is being treated properly or which is being targeted properly for the hypertension and which is having the proper control for the hypertension. So which is not good, because as the hypertension is not controlled properly, the chances of morbidity as well as the mortality increases. What are the different scenarios for the India? Because India we have more of an early onset of hypertension. Recently we have observed since last almost 7 to 8 years, we have seen more of a hypertension starting from early age, from the 30 to 40 years of age. Previously it was almost 50 years of age. Because of now more of an IT people and day and night cycle has been changed, we are seeing a more of an work stress and job related stress. So we are seeing more of hypertension in early onset. Previously it was a rural and urban differentiation was there, but now there is no rural as well as urban differentiation. We have multiple risk factors starting from diabetes, dyslipidemia as well as the smoking and other risk factors for the CV mortality, morbidity as well as the mortality. And overall rising of the blood pressure is also very high in Indian population we have seen. Early hypertension mediated organ damage is also more because we are not good control, as previously I have spoken. That is only 1 patient out of 4 hypertension we have proper control of the hypertension with the medication because of the poor compliance of the patient. So there is a very high chance of hypertension mediated organ damage. So there are few terms we call it as in double trouble. Always we have seen that patients with an hypertension always have associated diabetes mellitus. We have seen a prevalence of almost 21% for the diabetes plus hypertension. From the 2018 we have started a new term, we call it as in lipitension. So if patient with a type 2 diabetes mellitus patient have hypertension plus dyslipidemia, we see almost prevalence rate of 42.4% and we have very higher morbidity as well as the mortality in a lipitension patient, because this chart shows that when the total cholesterol is on a higher side with diabetes, smoking and low HDL cholesterol and very high LDL cholesterol level, with the stage 3, more than stage 2 hypertension, we see the morbidity as well as the mortality is almost reaching to 60%, which is very high. So lipitension has to be treated properly and hypertension in the dyslipidemia as well as the diabetes has to be controlled very strictly. So we have seen a various guidelines that stages differently for the hypertension, starting from the GNC which was 5, 6, 7, now GNC 8. Guideline is also came which has given a GNC 7 that has continued to the GNC 7 staging. We have now an ACC-AH hypertension stage of 2021, which is the normal blood pressure is less than 120 and diastolic is less than 80. Elevated is 120 by 129 millimeters of mercury and diastolic is less than 80 millimeters of mercury. Stage 1 is from 130 to 139 and diastolic is 80 to 89, and what considered as in stage 2 is more than 140 and the diastolic is more than 190, more than 90 systolic blood pressure. But here some difference is there because this is not a single point hypertension recording is there. It is always and 2 times blood pressure recording. That too, if needed, we do an ambulatory blood pressure monitoring to consider that whether patient is actually hypertensive or not, because nowadays we are seeing a more of a white coat hypertension. GNC 7 has classified hypertension according to that normal is less than 120 and 80. Pre-hypertension is 120 to 139 and 80 to 89. There is a slight change in stage 2. It has considered more than equal to 160 for the GNC 7 classification and more than equal to 100 diastolic blood pressure is considered as a diastolic hypertension.
This is very important thing because recently in the last, if you see last 3 or 4 years of all ESC, ASCC guidelines or even GNC guidelines, they have included as an ambulatory blood pressure monitoring for the diagnosis of the hypertension. The ambulatory blood pressure monitoring is very underutilized treatment part or underutilized diagnostic segment for the hypertensive patient because it is very important for the diagnosis of the borderline hypertension, for the suspected masked hypertension, or we call it as a reversed white coat hypertension, suspected white coat hypertension, and presence of advanced target organ damage. In OPD we see the patient is having very high creatinine level. In OPD we are seeing patient's blood pressure is on a normal side. Then what is the reason for that end organ damage or high creatinine level? Whether it is associated with hypertension or not, to detect that one we need an ambulatory blood pressure monitoring for the treatment of resistant hypertension, and whether to see whether we have whatever treatment we are giving, whether actually patient is very compliant as well as patient is achieving the targets or not. That is very important for the ambulatory blood pressure monitoring. So these are the various cutoff levels for the ambulatory blood pressure monitoring. For the daytime we are seeing 135 by 80 millimeters of mercury. Night time is 120 by 70 millimeters of mercury, and morning on an average mean blood pressure is 135 by 85 millimeters of mercury, and 24-hour mean blood pressure should be 130 by 80 millimeters of mercury or below that. So if you see then in office blood pressure is low as well as the ambulatory blood pressure shows and high, then it is called as masked hypertension. If office blood pressure is also high, means at the time of OPD also blood pressure is on a higher side, and ambulatory blood pressure is also on a higher side, we consider it as a sustained hypertension. Another reason, at office we are seeing an hypertension, but at home on ambulatory blood pressure monitoring we are seeing as a normal blood pressure or below average blood pressure, then we consider it as a white coat hypertension. So that rules out the actual hypertensive patients, and we can titrate the patients and modify the treatment for the patients. So what are the risk stratification? This is also very important. This is also very underutilized calculator. ASCVD calculator has to be there in each and every OPD. For each and every OPD patient we should calculate the ASCVD, because this is very important. Just a few terms we have to fill, and that gives us an ASCVD risk calculator, which says that less than 5, 5 to 15, 15 to 20 and more than 20, which gives us a proper risk stratification whether we have we should need a stringent control for the hypertension or not. That has to be decided by the ASCVD risk calculator. There are other factors also which influence the CV risk factors for the patients with hypertension that are considered as risk factors for the coronary artery disease. Means patient is having male sex, male patient more than 50 years, high LDL cholesterol level. There are hypertension mediated organ damage factors, as well as the other associated clinical factors also affects the hypertension related CV risk factors. So according to the risk stratification, we can stratify very high risk, moderate risk and low risk. If you just see the very high risk, then patient is having documented CVD, means patient also having a coronary artery disease, patient is having diabetes mellitus, and a very high risk individuals, risk factor more than including grade 3 hypertension, and CKD stage 3 and stage 3 to 5 is considered as a very high risk for the hypertension. Because of that risk, we are seeing even a normal patient also, if grade 3 or grade advanced stage of CKD is there, even a normotensive patient also we are seeing a very high risk stratification, considered as a very high risk patients. What are the clinical evaluations? How we evaluate for the hypertension mediated organ damage, and why we need a clinical evaluation? Because to establish the diagnosis, we need a screening to detect the early hypertensive patients and identify the concomitant diseases. What are the how we diagnose the hypertension mediated organ damage? Mainly because by the routine history point of view, by the starting from the head to the toe, if patient is having brain related issues, mean patient complains of headache, blurring of vision, transient ischemic attacks. In a cardiac related issues, patient complains, hypertensive patient complains of anginal symptoms, atrial flutter or atrial fibrillation. In a CKD patients, patient is having polyuria, polydipsia is there, and peripheral artery disease, patient is having cold peripheries or a low limb claudication features. This suggests that hypertension is being advanced. Physical examination we usually do for the for the body habitus signs of hypertension mediated organ damage. We see the features for the secondary hypertension also. Assessment of the hypertension mediated organ damage. These are very important things that we routinely are doing on our OPD basis practice. it is mandatory for the 12-lead ECG has to be there for all hypertensive patients. Urine albumin creatinine ratio has to be there for all hypertensive mediated organ damage, and blood creatinine eGFR. eGFR is very good calculator which is available on Google also. In each and every hypertensive patients or even a routine OPD patients also we should calculate eGFR, because if you consider in 1.4 creatinine at the age of 74, if you calculate the eGFR, it comes between 30 to 40. That means he is in a part of a CKD that has to be titrated properly and that has to be controlled strictly for the hypertension. So for the clinical evaluation, we see that 12-lead ECG is a class 1B indication for the hypertension. It is mandatory for all hypertensive patients. If that one shows any changes of LVH, then it definitely requires an echocardiography to rule out for the diastolic dysfunction for the hypertension is a class 1B indication. Clinical evaluation for the renal assessment also, all hypertensive patients eGFR as well as the serum creatinine level is in class 1B indication. And measurement also for the albumin creatinine ratio is in class 1B indication. So all OPD patients needs albumin creatinine ratio, and if you are suspecting for the early hypertension or renal artery stenosis related hypertension, then all patients need to undergo, in an early phase of the hypertension they should undergo for the renal artery scanning. So what are the treatment goals? Every institution has given a treatment goals differently. American Academy of Family Physicians has given a goal that each and every hypertensive patient a stringent control of less than 140 by 90 millimeters of mercury is mandatory for all the hypertensive patients. And European as well as the ACCH also consider that same less than 140 has to be there for each and every hypertensive patients. So these are just a guideline which is given by the JNC 8 that all adults more than 18 years of age, they have divided with an hypertension, they have divided the patient into two groups, whether patient is having diabetes and CKD or whether patient doesn't have diabetes or CKD. If patient doesn't have diabetes and CKD age more than 60, then all has to be controlled. Less than 150, that is only when patient doesn't have any diabetes or hypertension and age more than 60. To prevent any postural hypotension, we are reducing the goal for the hypertension. And for all CKD, diabetes and hypertension and all high risk patients, our stringent control is less than 140 by 90 millimeters of mercury. These are various medications we usually use, mainly for the heart failure in each and every hypertensive patients. We usually start the treatment from the single pill which contains a dual medication, AC starting from the AC-ARB plus or minus diuretics or a calcium channel blocker. For the post-MI as an only for the heart failure patient, we give an AC-ARB plus beta blockers. So beta blockers now indicated mainly for the coronary artery disease patients or heart failure patients or non-IHD patients. Beta blocker used as an antihypertensive agents along with AC-ARBs. So this is a one pill. We start from the one pill, that is a dual combination AC-ARB plus or minus calcium channel blocker. Step 2 is a triple combination of AC-ARB plus calcium channel blocker plus diuretic, and if still not get control, then we add on to aldosterone, mineralocorticoid receptor antagonist, spironolactone and other diuretics plus if needed and central acting agents like alpha blockers also we add. Then we consider it as a resistant hypertension and we refer the patient for the hypertension specialist. So what are the trials and evidence says that, and when we are talking about the hypertension, we never forget about the SPRINT trial. This was the landmark trial for the SPRINT which has given a stringent control for less than 120 and between 140. So whether to control less than 120 or whether it was divided less than 120 and less than 140 milliliters of mercury. As you do a stringent control of the blood pressure, there is a significant reduction in the morbidity as well as the mortality in a SPRINT trial, but also there was an higher rate of adverse event, mainly the postural hypotension was very high in a SPRINT trial. That's why in a recent guideline, everyone has reduced the goal for more than 6 years of age without any comorbidities. The goal is only less than 150. We are not doing a stringent control of less than 120 millimeters of mercury. This is a recently published trial for the time study. There was a discussion for the time whether to give a morning dose of the antihypertensive or night dose of the antihypertensive, and it says that dosing is not important. The choose of the medication or what medications you are giving, that is more important. Between chlorothalidone and hydrochlorothiazide, it has shown that there are no difference between chlorothalidone or the hydrochlorothiazide for the BP control for the hypertensive patients. And recently we have seen that empagliflozin has also came.
that has shown that it also reduces the hypertensive patient. Not a sole agent, but with combination of other medication, it reduces the hypertension. So what is the summary? Early detection is very important for the hypertensive patient, and stringent control of the hypertension significantly reduces the CV death. For more than 60 years, I told only 150 milliliters of mercury to avoid the postural hypotension. Always use an ambulatory blood pressure monitoring in your routine practice to diagnose for the hypertensive patient. Look for the fine signs and symptoms of hypertension mediated organ damage. And combination therapy is always better than a monotherapy in a newly detected hypertension. Thank you so much.
Thanks, sir.
Sir, please wait. Please wait. As we have our fourth session, which is going to be delivered online on Zoom by Ved Prakash Mishra, is being postponed after. Hypertension. So if you have any question, you can ask.
Sir, what are the first step to treat refractory hypertension?
Sorry sir, I can give that answer, but already we have one session by the Dr. Utsav Unadkat. He will be talking on the refractory hypertension, so after that session we can have that question also. No issue, sir. Sorry.
Okay. Why can't you give CCB and ARB together?
CCB and ARB together means for all the guidelines says that CCB and A for each and every patient dual therapy is always start from AC ARB plus CCB. We always give with the CCB and AC ARB. There are no contraindications that CCB should not be given with AC or ARB. It is always a dual combination for the CCB with AC and ARB. If needed, we add on to the hydrochlorothiazide or chlorothiazide for the hypertensive patients. Because whatever CCB, it says that CCB produces an ankle edema which is being mitigated by the use of the ARB. So the ankle edema effect is mitigated by the AC-ARB. So always a dual therapy with an AC-ARB plus CCB is more preferable than an alone use of the CCB, sir.
Thank you, sir. And how you calculate the risk of hyperkalemia by giving ACE or ARB?
Yes, sir.
How frequently you assess the risk of hyperkalemia by giving ACE or ARB?
Sir, if the patient is having normal creatinine at the initial evaluation for the hypertension, if the creatinine is very less or creatinine is on a normal side, we usually prefer to do a creatinine or a renal function test after 1 month. If patient is already having a CKD, stage 2 or stage 1 or stage 2 CKD patient, if we are starting AC and ARB, after a week we check again for the potassium as well as the rise of the creatinine level. If potassium is not increasing, then we continue the AC ARB for that CKD patient. After 1 month we check, if again normal, then every 3 months we usually check for the hyperkalemia as well as for the creatinine level. That's it.
Thank you, sir.
Thank you so much, sir.
Yes.
Dr. Pamela Ghosh will present moment to Dr. Prajan.
So 1 minute. Yes, regarding the timing of giving the dual therapy of the morning, some people they take in the morning, some take in the night.
So there is always a debate for the timing of the patient, but timing of the therapy. Previously, when we started the practicing or for the general also routine practice is there, we usually give whatever sympathomimetic, whatever sympathetic activities there, which is on a more on a higher side, which is in the morning time. So we usually give a beta blocker or a dose of the antihypertensive in the morning time. The thing is, what ambulatory blood pressure monitoring gives us a better idea to control for the hypertension is that whether patient is having a morning hypertension or patient is a non-night deepers. So if patient is having non-night deepers, means whenever patient is sleeping, patient is having obstructive sleep apnea or any other features, when patient is having there is no deeping of blood pressure in a night time, then we target that patient to give a more antihypertensive dosing or the AC-ARB as well as the beta blockers in a night time to deep that patient in a night time. So the chances of CV mortality reduces for that patient. And if you do then ambulatory blood pressure monitoring, and morning time blood pressure is on a higher side and night time blood pressure, there is a normal dipping is there, then we usually subject that patient to give a timing of therapy in a morning session. So in a recent trial also it has shown that time is not important. What medication you choose, ACE/ARB plus beta blocker or ACE/ARB plus thiazide type of diuretic, that is more important rather than giving a timing. And if you still want to consider for the timing, it is always mandatory to subject the patient for ambulatory blood pressure monitoring. That will give you a better idea when to give a medication for that patient. Thank you so much. Yes, sir, please.
Sir, in aged patient having brain atrophy, mild increase in systemic blood pressure is harmful or?
Sir, over age, as the age progresses, there is always a chances of atherosclerosis, renal artery, the overall stiffness of the vessel increases. So there is no risk. There is a risk when there is a sudden rise in the hypertension. When there is a shoot up of the hypertension because of either the renal artery stenosis acutely or abrupt rise in the hypertension, that is more damageful than a persistent rise in the hypertension, or if it is a slow rise in the hypertension. Yeah, definitely, if a persistent rise is more than 160 persistently for a longer period of time, it is always going to damage the there will be a multi-organ damage will be there. To control, if more than 6 years of age, if patient is having other risk factor, we control less than 150, but we are not targeting less than 140 even for the old age patient to control of the hypertension, because we have seen a significant number of postural hypertension with a stringent control for the antihypertensive medication, because they have sometimes prostate issues also. They are already on a prostate medication that also leads to an postural hypertension. That's why in a old age patient we always go slowly, we titrate the dose slowly, and we just control 150. If with 150, below 150, if patient doesn't have any symptom, we continue with the same treatments. Thank you so much.
Okay, thank you, sir. Dr. Pamela is present a moment or two, Dr. Sanjeev sir.
Next question to next speaker, please. Hypertension is going to continue.
How do you interpret only raised systolic blood pressure? And how do you interpret only diastolic raised blood pressure?
Sir, again saying that all guidelines, it says saying that I have written the guidelines also, but the guideline says it is always and or. So if you consider the stage 1 hypertension, if blood pressure is more than 139 to more than 140 to 149 also, only systolic is considered as a stage 2 hypertension. If patient is having systolic BP is normal, but his diastolic BP is more than 90, then it is considered as a stage 2 hypertension. So if in isolated, it is an and or, it is not both, it is and or. So if only systolic hypertension, it is an isolated systolic hypertension. If systolic blood pressure is below 120, but his diastolic blood pressure is on a higher side, more than 90, then it is considered as a stage 2 diastolic hypertension, and isolated diastolic hypertension will be there. And we treat according to the stage 2 guideline. We are not treating according to his systolic guideline, we are treating according to his diastolic guidelines. That's it. Thank you so much, sir.
Now next question in another talk, because we have all 2 talks on hypertension only. Please come, Sanjeev sir. As we all know, in young patient we see diastolic high blood pressure, and in old age we see high systolic pressure. So as per the age we have to take, but normal 140/90 that has to be considered, and above 140/90 has to be treated. But it has to be confirmed by measuring 3 times at different time.
I would like to invite Dr. Dhruv Jadeja for second lecture on women and hypertension.
Before Dr. Dhruv started his talk, there is one announcement. Post lunch at 2 o'clock, there is a big IPL between different teams of India, and I request all of you to remain present. It's called 6-a-side competition. Different teams from different area are taking part in it. The questions will be given to them, and 6 persons from each team is going to ask differently. So I request all of you to attend that 6-a-side competition. It will start sharp at 2 o'clock. So please come in time.
Good afternoon, everyone. Respected dignitaries, chairpersons, and dignitaries on the stage, respected audience, thank you for having me today and giving me this wonderful opportunity on a national platform. So it is a moment of respect and a pride for me as a cardiologist to present to such an audience. The topic for my presentation is women and hypertension. As my colleague has already suggested that hypertension is poorly controlled in India and particularly in female, because the females are not very much, they are not very concerned about their own health. As we see practically, it is not done in any study, but they are less compliant with the treatment and generally they don't go to the hospital till the symptoms are very much advanced. So this is just a flow chart. So how hypertension comes across the life cycle of a woman. Generally, it starts from teen up to the pregnancy, menopause and older age. And the different stages of the woman life cycle, there will be different causes of hypertension entity. Generally, we don't treat the woman separately. We don't have separate medicines to treat women in the hypertension segment. Then why it is necessary to just give a lecture on women and hypertension? Because the hormones and the life cycle of women is very much precise, and there are different causes of different life cycles and hypertension across the whole stage of women's life. To get sensitized over this issue, our woman has to be treated and respected as a patient of hypertension and to consider it as a special person because of the underlying physiologies that are different in women. So we need to throw some light over these issues. Common risk factors, these are all both common in men and women. What are the secondary causes? These are, although they are rare causes, but these are very important because when we diagnose this kind of causes, we can able to treat the patient completely and we can make the patient free of medicines. So these all causes are very important, particularly because I am a cardiologist and an interventional cardiologist. So first our whole focus will be on anatomical causes, what we can treat with stents and all this. So those causes will be coarctation of aorta, fibromuscular dysplasia, renal artery stenosis also rarely, if there is a bilateral renal artery stenosis, Turner syndrome, then patient with endocrine causes like hyperaldosteronism and Cushing syndrome is also causes of hypertension, in particularly young women. And a very important cause is Takayasu arthritis. Takayasu arthritis is a common cause, particularly in some regions of India, not very much in this part of India, but in South India, in Northeast India, there are very common causes of young hypertensive females. And the treatment and identifying the causes will be very important in those persons because they make a very great difference in treating the patients. Not only with the medicine but also in the interventional aspects. So coming to the main highlight of my session, because there is a most common clinical scenarios when the patient who is a young female will come to you as a hypertensive patient will be during pregnancy, during or around the pregnancy. So this is the definition of pregnancy hypertension, gestational hypertension. Generally, it is a common, more than 140 to 160 is a diagnostic cutoff for the hypertension. But in pregnancy, unlike the normal individuals, it is not the 180 cutoff for severe hypertension. It is lesser because we consider that if the person is having pregnancy, is having more than 160 Vp, the end organ complications will be much more higher than the patient with having 140 to 160. So we need to take the BP measurement seriously in the pregnancy, and we have to take a low threshold for treating the patients. So as we all know, pre-eclampsia and eclampsia are the very much important topics, and pre-eclampsia generally is defined as hypertension in pregnancy after the 20 weeks of pregnancy. That is the most important highlight of the pre-eclampsia. If the person is diagnosed as having hypertension before 20 weeks, it is not considered to be a pre-eclampsia. If it is after 20 weeks, then only it is a pre-eclampsia. And eclampsia, as we all know, it is an associated seizures, generalized tonic-clonic seizures associated with accelerated hypertension in a pregnant women. So the treatment of each and every part of the gestational hypertension is different. So we have to understand each and everything. Essential and secondary hypertension, as I already told, both are different, and secondary hypertension is essentially curable, so it is more important to diagnose these causes. And common complications associated with hypertension, as we all know, we don't need to go in details. I want to keep this lecture as brief and as interactive as possible. So just we will focus on the main highlights. So the targets of treatment is to minimize the maternal and fetal risk with safety both to the mother and fetus during pregnancy. So pregnancy is a unique situation where if we treat one, we can endanger the second. So we have to take both lives into aspect, and we cannot just focus on mother and forget the child, or only for child and not the mother. So we have to treat. So ARBs should not be given during pregnancy because it has a high risk of fetal complication and fetal renal disorders and other things. Teratogenicity is the highest in ARB and ACE inhibitors. Rest all in some or other combinations are relatively safe, like beta blockers, diuretics and calcium channel blockers. And for the management of pregnancy hypertension, we generally use some combination of this. So there will be two aspects: acute blood pressure control and long-term control. Acute will be like an emergency, like eclampsia, pre-eclampsia, or some end organ damage associated with the pregnancy hypertension. Whereas the long-term is once the patient is in a stable hemodynamics and is an OPD patient, then the control of blood pressure. So as a cardiologist, I see less of an acute hypertensive emergency in pregnancy. I see more of a long-term blood pressure OPD patients, and generally we give oral medicines for that. But for the knowledge sake, we discuss both the things. And first line, as we all know, in the pregnancy is always a beta blocker in form of labetalol. Labetalol is a wonderful drug, and it is a time-tested drug. It is used in IV as well as oral formulations both, and its safety is fantastic. The patient and maternal safety is very well established in labetalol. Some patients do not respond to labetalol, then we have to titrate, upgrade the medicines to either calcium channel blockers or diuretics, and then we control the blood pressure and reduce the complication rate. Second line pharmacological therapies are esmolol, nicardipine, labetalol and nitroprusside. So methyl dopa nowadays it is not very commonly available, but labetalol of course it is available, and nifedipine is also available. Diuretics, particularly thiazide diuretics, are the only medication which is to be given during pregnancy-induced hypertension. So the urgent management I will not give in detail, but just to give an overview. If there is an emergency, we have to first manage with the injectable labetalol, 20 milligram direct bolus and followed by infusion. The maximum dose should not exceed 300 milligrams of labetalol. If still it is not controlled, we can use a nitroglycerin also and nitroprusside also. Nitroprusside is also less available, but nitroglycerin is freely available. And if it is still not getting control, then we have to think of other modalities like hydralazine and nitroprussides and nicardipine infusions. So as I already told, drugs to avoid are angiotensin receptors blockers and AC inhibitors because of the fetal renal agenesis and dysfunction. These are the guidelines to improve the outcomes. Frequent BP monitoring, once in 2 weeks or once in week follow-up for the patient who has hypertension during the pregnancy, and management beyond the blood pressure control. Diet is also very important. Diet management, salt restriction, these are all has to be implemented thoroughly in the pregnancy hypertensive patients. So target range is less than 140 and less than 90. So as we have already told, these all medications, once the patient is out of the emergency, we can give as an OPD prescription, labetalol 200 to 1200 milligram in 2 divided dosage. Nifedipine is up to 120 milligram per day. So we can give 20 milligram 3 tablets in a day, or generally we give 220 milligram 1 TDS like that prescription in oral. And other medication is hydralazine, is also available as isolazine. So we can give it as a 1 TDS dosage, what we use practice in clinical practice. The delivery decision has to be taken along with the gynecologist, but generally if the patient is having severe preeclampsia and has completed 34 weeks, the ideal decision is to do a cesarean section to control the blood pressure and to save the life of mother. And as far as the eclampsia is concerned, magnesium is the first line of therapy. Eclampsia, total of 14 gram of magnesium should be given, out of which 4 gram should be given as a direct bolus in 20 minutes IV. Another 5 gram can be given intramuscularly in each buttock. So total 14 milligram magnesium should be given. And it is a wonderful drug to reduce the convulsion. Also it will reduce the blood pressure too. And if still it is not controlled, then early cesarean or induction of labor is recommended. Post-delivery management, we have to see the liver enzyme for HELLP syndrome. We have to tackle the postpartum hemorrhage, pulmonary edema. So menopause and hypertension, as we all know, after the menopause there will be a change in the sex steroid ratio. So testosterone will be higher in the postmenopausal women, and because of that there will be a surge of blood pressure after the menopause. So we have to target those population. We have to be aggressive on blood pressure monitoring and treatment also, because the complication will be higher. And cognitive impairment is one aspect which I have to highlight. It is also common in the older women, because there will be less stringent control, and the microvascular damage which occur with the hypertension is common in female. The clinical trials, some clinical trials are there, DASH trial, LIFE trial, NORDIL trial. This all, they don't particularly have a specific recommendation for female, but in one trial that was seen that losartan is not well tolerated in lifetime. So losartan generally we avoid in women. Summary, as I already told, she has to be considered as a different individual, particularly in pregnancy. There are 2 lives at stake. We have to be more on our toes to control the blood pressure. And thank you all for having me and listening to me carefully. And I will give mic to sir.
Thanks, sir. Thanks.
Is there any question to Dr. Dhruv?
Sir, as the newer invention of CCBs, the usage of nifedipine has decreased.
Yes.
So is it really or obsolete?
No, sir, it is not obsolete in refractory hypertension, and particularly if we are talking about women, it's used in pregnancy more. But otherwise, when the creatinine is high, patient's creatinine is high, nifedipine is generally preferred over the other modalities because it is a safe drug to be given in a CKD patient. Yeah, it has come out of favor recently because the newer developments of cilnidipine and this newer drugs. But nifedipine is a good drug because it is a short-acting agent, and we can give it as an SOS basis. We can give it will reduce the blood pressure very immediately. So whenever there is a surgical patient or some other emergencies, nifedipine is used very much commonly.
So retail preparation is more safe to use than short acting.
Yes, sir, because it will reduce the reflex tachycardia and there will be less tolerance to the drugs overall concentration in the body. So retard preparation is ideal for a stable patient. But if you don't have a retard preparation and you need to control blood pressure immediately, you can give short acting also. The dapine also can be given.
Thank you, sir.
Thank you, sir.
Any other question? GDM?
Gestational diabetes and hypertension. Gestational diabetes patients generally they are not considered as a separate patient for a hypertension population. But yes, because there are two entities involved, there is already an impaired metabolic environment inside the body. There will be an underlying metabolic X syndrome, or there will be an obesity. Uncontrolled, it will cause proteinuria, and that can lead to a problem in the later part of the her woman's life. So, but there is no particular drug which has to be given or which has to be avoided with the patient having a gestational diabetes and gestational hypertension. Preferred drug is labetalol, but labetalol, if it is a HbA1c is too high, so sugar, it generally raises sugar labetalol. So we can give second line drugs like isolazine, or we can give a Nicardia that are relatively safe on the diabetic profile patients. But if it is still not controlled, then labetalol has to be used. It's not a problem. Yes, sir. It can be given.
Sir, this is not a question regarding hypertension in women, but this is very commonly seen conditions. Like we first of all see a patient who is having blood pressure of 200 by 120, right? So we have two terms called hypertensive emergency and hypertensive crisis, where end organ damage is already there. So in this condition, at the when we see the patient of blood pressure having 200 by 120, what should we see in that patient, and when to refer that patient?
So particularly this topic is the next for Dr. Utsav, but just I will give an overview that if patient is having symptoms like having a visual loss or headache, impending headache or renal failure, or any end organ damage, is if you suspect that, then you have to give IV therapy. If it is feasible in your center, best to admit the patient and give an IV indoor treatment. If the patient is totally asymptomatic, patient does not have any symptoms, you can manage as an outpatient patient also, but with some watchful monitoring, like you have to keep him in the hospital for half an hour, 1 hour, give a medicine and wait for 1 hour, recheck the blood pressure. If the the blood pressure is still high, you can give options for getting admission. And in our residency time, they used to say that you have to use an ophthalmoscope. In any patient who is having more than 180 blood pressure, you have to see the the retina, to see the for papilloedema, because it's a very early sign to develop a stroke or developing an detachment of a retina. So the one thing can be added as an ophthalmoscope, and if you have practiced ophthalmoscope using and you are well versed with it, definitely it has to be seen. And also renal parameters. We have to see urine routine, spot creatinine ratio. These all are telltale signs of patient having an emergency or urgency.
So the conclusion is.
Sorry, sir. It can be used. There are no trials of amlodipine in pregnancy because after 1980, I think, the trials on pregnant lady was banned in US and UK because of the ethical issues. There has no been data whether amlodipine is harmful to patients or not. But generally, the practice suggests that if CCB has to be given, first choice is nifedipine. If nifedipine patient is not able to tolerate, then we have to think of amlodipine also. It is not harmful. First 3 months we have to be a little bit careful because the organogenesis of the fetus. But after 3 months, generally we have to consider mother first, then the child.
Okay.
Dr. Om Prakash will present a moment to Dr.
Conclusion of my question, hypertensive emergency, we see many a times because we are seeing patient of blood pressure having 200 by 120 but they don't have any end organ damage as sir has said like visual disturbance or any edema or any breathlessness. So at that time this condition is emergency, not crisis, but we have to make the patient understand about the disease. We don't have to afraid the patient. We have to measure his blood pressure regularly. We have to educate the patient regarding hypertension. We have to evaluate every needed investigation in that patient so that patient remain restricted to us and take medicines regularly. Next.
Our next speaker, Dr. Utsav Unarkat. Please come to the dais, and the subject is refractory hypertension. Please start.
Thank you. Good afternoon, everyone. Thank you for inviting me here. Thank you, respected members. And thank you, AFPA and NATCON, for giving me this opportunity to speak on this in front of this august audience. So my topic is one that is we got a lot of questions, Dr. Sanjeev and Dhruv. I'll try to shed some light on that. And it's a very complex topic that involves a multidisciplinary approach. A cardiologist may be required, a nephrologist may be required, an endocrinologist may be required. So let's have a brief discussion about this. So there are a few things that we know about hypertension. One is essential hypertension, uncontrolled hypertension, pseudo-resistant hypertension, resistant hypertension, refractory hypertension, secondary hypertension, renovascular hypertension, and malignant hypertension. We have to understand these key words and try to understand what is going on as of now and what we have to deal with. So basically, first thing first, we have to have a proper BP measurement. The patient should be sitting comfortably on a chair with back supported and in a relaxed pose. No talking during and between measurements. Cuff should fit the arm. Small, usual, large, different sizes are available. And arm should be resting on the tabletop, and it should not be, in a muscular activity, should be zero at that time. Patient should be in a quiet room. The patient as well as the measuring person should be relaxed. No smoking or caffeine or exercise 30 minutes prior. Empty bladder. Patient should sit for at least around 10 minutes and then get the BP measured. Take 3 measurements at 1 minute intervals. See, these all things are definitely required, but not all of them are being followed in our day-to-day practice because of the patient load and what other parameters that we have. So we have to make sure that whenever patient is having a high blood pressure, a recheck is ordered after say around 10 minutes once the patient is a bit relaxed, and we have to make sure the patient is in a proper posture and the BP machine is well calibrated. So this is basic stuff. 5 phases of blood pressure measurement. Phase 1 is swing tipping that starts at when we bring the mercury level down. Phase 2 is swishing sound. Phase 3 is loud knocking sound that we have. Phase 4 is muffled, and then phase 5 is silence. So we have to make sure that we understand when the diastolic cutoff is. So there are some cases like aortic regurgitation when we have a false cutoff early. So we have to make sure that we diagnose them very well. I think Dr. Sanjeev has gone through these, so I will not go into detail. One thing that I would like to say is the International Society of Hypertension in 2020 came up with a definition for ambulatory blood pressure monitoring criteria. 24-hour average of more than equal to 130 and or more than equal to 80. This is again and or as Dr. Sanjeev pointed out. Daytime average more than equal to 135 and or more than equal to 85. Nighttime average more than equal to 120 and or more than equal to 70. And home blood pressure monitoring that the patient is doing regularly more than equal to 135 and or more than equal to 85. So basically nighttime dipping is important for ambulatory blood pressure monitoring. If nighttime dipping does not happen, it confers additional cardiovascular mortality, and we have to include a evening or night dose of antihypertensive medication for their control. The main thing that we have in our day-to-day practice is white coat hypertension. What is it? It is just when the patient gets agitated by being in the hospital environment and the blood pressure goes high, and it can be diagnosed by home BP monitoring or ambulatory blood pressure monitoring. The good thing is target organ damage is minimal in this case. The second thing is pseudohypertension, like in old age, postural pseudohypertension when the arteries become calcified and they are uncompressible, and there is BP measurement that is on the higher side all the time. And without resting, when the BP is measured, they can also be higher side readings, and we might treat them falsely. The most common thing in our practice, Indian practice, is non-adherence to treatment. Patients are, pill burden is too much, and patients are, very resistant to taking medicine. So this has to be ruled out. We have to either ask them very clearly, are they taking or not? If they are saying yes, then we have to make a family member monitor them when they are taking medicine, or they have to give them in person so that we can make adherence better. And this is what makes a lot of difference in our Indian day-to-day practice. Ambulatory blood pressure monitoring, I have already said. Non-compliance of treatment, again the same thing I have said in detail. We have to admit and administer if the patient is alone, or the relatives are also not willing to make the patient take medicines, or there is no monitoring person. So basically, when a patient exceeds individual target by more than 3 medications, we have to follow this flow chart. If yes, the patient is taking medication regularly, then ask for if any recreational drugs are going on, like cocaine or marijuana, or if the patient is having high alcohol intake. We have to make them understand that this is not good, and they have to stop it. And if there is no substance abuse, then is a diuretic added to the regimen? If not, add it. If a diuretic is also there, then we have to find out if there is any secondary cause of hypertension, like hyperaldosteronism. I will be going through in detail a bit. So renal artery stenosis, there are a lot of secondary causes. If there are no secondary causes, then it is called resistant hypertension. So basically this flow chart helps us to rule out most of the things that we are going to come across in our day-to-day practice. So in a compliant patient who is having no BP, not on target, who is on 3 drugs, most commonly it is ACE inhibitors or ARBs plus a calcium channel blocker, plus a diuretic. So these are all 3 different classes of drugs at maximal tolerated doses or optimal dosing. Maximal tolerated means then the patient might not be able to tolerate the highest possible dose, but the patient has to be tolerating as much as possible. So if 3 drugs, one of them diuretic, 3 different classes, one of them diuretic at optimal dosage, if the patient is still having BP on the higher side with good adherence, then it is labeled as resistant hypertension. Clinical markers, most commonly it will be on advancing, patient will be on the higher end of age, high baseline blood pressure, obesity and overweight, BMI on the higher side, excessive dietary salt intake or alcoholism, chronic kidney disease. More than 30% of patients in one study of chronic kidney disease were having resistant hypertension. Diabetes, left ventricular hypertrophy, black race of female gender. Black race is again very commonly associated with resistant hypertension. Medication interaction with antihypertensives like NSAIDs, aspirin, selective COX-2 inhibitors, sympathomimetic agents like decongestants that the patient is using regularly, diet pills, cocaine, stimulants like amphetamine and methylphenidate, alcohol intake of more than 30 ml per day, ossicles, very commonly being associated with hypertension now in ladies, steroids, anabolic steroids, cyclosporin, erythropoietin, and licorice. Genetics, there are ACE gene mutation most commonly associated with genetically resistant hypertension. Second is CYP3A5 mutation, and ENaC, that is epithelial sodium channel beta and gamma mutation, or that is associated with Liddle syndrome. These patients have more of resistant hypertension. So whom should we watch for secondary hypertension? Most commonly seen in young hypertensive, first time hypertension after 60 years, and when controlled but now out of control. So something new has come up that needs to be investigated. So these I've already said. Strong associates will be high diabetes, BMI more than 30, obstructive sleep apnea. We have not gone through this. So obstructive sleep apnea is very commonly associated with resistant hypertension, and as well as CKD patients. CKD patients generally require more than 3 drugs for control of their blood pressure, as we all know. Why? As Dr. Sanjeev has said, the more the number of risk factors, the higher the risk of further target organ damage. So we have to be the more the number of risk factors, we have to be more stricter in control of blood pressure. Secondary and resistant hypertension, around 5% will have secondary causes of hypertension, and resistant hypertension will be in 30%. Primary aldosteronism, pheochromocytoma, Cushing's, and renal artery disease, 4 main causes of secondary hypertension. Renal hypertension generally is due to either 2 causes, renal artery stenosis or CKD. Renal artery stenosis can be due to 2 causes: fibromuscular dysplasia or atherosclerosis causing stenosis of the renal artery. Fibromuscular dysplasia can be treated with renal angioplasty alone, and stents may be put if required. Atherosclerotic renal artery stenosis generally is a multi-system disease and will require stenting. As we can see over here, this is fibromuscular dysplasia. A string of beads appearance is seen, and it is very amenable to balloon angioplasty. So this is after putting the stent in case of atherosclerotic renal artery stenosis. So renal parenchymal CKD is very commonly associated with resistant hypertension, as we all know, because underlying intravascular volume is pretty high in these patients, and salt intake also restriction might not be possible always, but definitely indicated. Secondary hypertension, adrenal causes. This can be either glucocorticoid or mineralocorticoid. Mineralocorticoid excess will be in case of Cushing disease. Glucocorticoid will be primary hyperaldosteronism. 20% of cases of resistant hypertension will have primary aldosteronism, and these can be very amenable for treatment with MR antagonists like spironolactone or eplerenone. Pheochromocytoma, especially in young patients, we should look for this. 24 hours methamphetamine, VMA, estimation is the diagnostic modality in this case. And if it is diagnosed, we have to do adrenal vein sampling to see whether it is bilateral or unilateral, and treatment can be done accordingly. Other cause of secondary hypertension will be biological, coarctation, polyarteritis nodosa, and aortitis. Dr. Dhruv has gone into detail with that. Obstructive sleep apnea, very common, and especially in obese patients and metabolic syndrome. This is very common, obstructive sleep apnea. It should be looked for in each and every case who is having metabolic syndrome. Acromegaly PCOD, and hypo or hyperthyroidism can have resistant hypertension. Exogenous will be prolonged use of external agents like steroids, excess licorice, excess alcohol. So physical examination, we have to do a few things: BP measurement, weight, waist circumference, BMI, peripheral pulses, ABI, bruits, carotid bruit, very commonly we have to see renal bruit also. Cardiovascular examination to see whether any kind of murmur is there, any kind of valvular regurgitation is there, aortic stenosis, aortic regurgitation, and abdomen should be seen for renal bruit, masses, aortic pulsation. This I have already gone through. So secondary hypertension evaluation will be by angiography or DSA for in case of renal artery stenosis. MRI, CT or USG can be used as a screening tool, and the lifestyle management will be the first thing that we do in any case. DASH diet, it is shown to reduce blood pressure by 5 to 20 millimeters of mercury for every 10 kg weight loss. Reduce dietary sodium 2 to 8 millimeters of mercury. Increase physical activity 4 to 9 millimeters mercury. Moderate alcohol intake 2 to 4 millimeters mercury from high alcohol intake. Increase potassium intake, and alternative approaches can have variable effect. So drug treatment, basically, if a secondary cause is found, treat it. Aggressive drug therapy has to be started in these cases, because the longer the BP stays up, the more end organ damage that will happen. So dialysis, diabetic has to be there, preferably chlorothalidone, which is longer acting. Hydrochlorothiazide also can be given. Most of our fixed dose combinations have hydrochlorothiazide, but chlorothalidone, due to its longer half-life and better BP control, should be preferred. Hydrazine or minoxidil in case of patients who are having black race, they have a very good control with hydrazine, isolazine that we have now. Beta blocker in case of coronary artery disease will help in heart rate control, and this is to be preferred in case of coronary artery disease patients. Consider plasma renin measurement in case of patients who are diagnosed with primary aldosteronism, to find out whether there is a role of MR antagonist in these cases. So basically, in 20% of cases who are not diagnosed with primary aldosteronism, if you start MR antagonist like spironolactone, they will have a dramatic result. So spironolactone has to be a fourth or fifth drug in line for you to start if there is a potassium level less than 4.5 and if you are suspecting primary aldosteronism. So future options can be direct renin inhibitors, aliskiren. This has fallen into disrepute a bit because of a lot of side effects like coughing and everything. Neural endopeptidase inhibitors like omeprazole, clonidine, extended release, aldosterone synthase inhibitors, endothelin antagonists, and novel combination algorithms. Few invasive procedures can be done if the patient is not medically well managed, like implantable pulse generators, carotid artery stimulation, renal denervation in case of resistant hypertension, particularly those with renal origin of the disease. Promising results have been found with this. Carotid artery stimulation and carotid bulb nitinol stent placement. This stretches the carotid bulb, and this causes beneficial effect on the blood pressure control. And endovascular AV fistula creation, like from the iliac vein side we go to the iliac artery and create an AV fistula. But there is more venous stenosis with this, so this has to be done in a very planned way. So thank you. This is there are few things about resistant hypertension.
one or two questions, if any question is there.
Go ahead, sir.
Can you elaborate on the night surge and
We have a quiz, please be seated. Don't run for lunch.
night surge and early morning surge of hypertension and its management?
Early morning surge, definitely sir. These patients need to first, I think, better to get ambulatory blood pressure monitoring done. This will tell us what the nighttime pattern of blood pressure control is like. If they are non-dipping, then nighttime dosing will help in these cases. Early morning surge, I think better to counsel our patients that once they get up in the morning, just after having brushing their teeth, they should take medicines, because sometimes people take medicine early morning after 2 to 3 hours of getting up. So the catecholamine surge that is going to happen once everybody wakes up is not controlled. So early morning medicines just after brushing their teeth should be counseled, and obviously ambulatory blood pressure monitoring and obstructive sleep apnea has to be ruled out definitely.
Sir,
Yes.
we have given ACE or ARP to the patient, CCB to the patient, beta blocker to the patient. Still hypertension is around 160. So should we add alpha blocker, or that patient is not symptomatic with this type of blood pressure, we should tolerate too?
No, I think first thing that we need to add now is a diabetic, sir.
We have given, sir.
Okay, diabetic is not there. It is given, so I think better switch diabetic to spironolactone. Primary aldosteronism might be there, so first thing that you should do is add spironolactone. If the patient is, what is the patient profile like? If there are multiple risk factors, better control the blood pressure. Bring them to the target range to avoid target organ damage. But spironolactone should be the next medicine in line, because alpha blockers will not have any kind of cardiovascular benefit. MR antagonist is going to protect the heart and the kidneys as well.
So just to reduce hypertension will not be benefited in that case.
Yes. Now, in this era, focus is switching from just controlling BP or diabetes to giving medicines that benefit the kidney as well as the heart. So all the drugs that are going to come now will have a cardiovascular outcome trial. So they should have a beneficial effect on the cardiovascular mortality of the patient to have a higher, indication level. So I think better to give medications that are going to help the kidney and the heart more.
Thank you, sir.
Thank you, sir.
Refractory and hypertension and resistant are the same?
Yes, they are related, they can be used interchangeably. Okay.
Now it's quiz time. Please open your website. And I request Dr. Chirag Bhai to give a memento to Dr. Utsav Bhai. And I request all the three cardiologists to come on the stage. Dr. Dhruv and Dr. Sanjeev Bhai, you all come on the stage. Please open the site, and question number 3 is coming. It's this question is little bit tricky, so you have to read all the answers properly and then you have to give the answer. So we are giving 1 minute. It's a good question. And so we are putting the question. Madam.
Excuse me, sir.
So please go through the question. We are giving 1 minute.
Excuse me, sir. Namin jao.
Our 3 cardiologists are team members of Dr. Jai Shah. We are unfortunate to have Dr. Jai Shah with us, but we are thankful to all the 3 cardiologists. So we end the time now, and now I request to give the prize to the winner. Winner is Dr. Rajendra Kaikeni. Dr. Rajendra Kaikeni come on the stage, and Dr. Dhruv will give prize to him because the question was from Dr. Dhruv. Question was, a young female with secondary cause of hypertension undergoes a blood profile. Which of the following combination is more likely to be present in her electrolyte levels? This was the question. So question was little long and the answer was very much confusing. There were 4 answers: hyperkalemia, hypernatremia, hyperkalemia, hyponatremia, hypokalemia, hyponatremia, and last one was hypokalemia, hypernatremia. The answer was hypokalemia, hypernatremia. D was the answer. So I congratulate Dr. Rajendra Kaikeni for giving his correct answer and quick one. And I thanks all the cardiologists. So we end up this third session. As I have said that the 4th lecture was from Dr. Ved Prakash Mishra, but unfortunately we keep this lecture on post lunch. Now I request all the delegates here
हाँ आम्ही किती ते नहीं हम स्लाइड कर रहे हैं
Alone the camera.
Right? 6 teams are there. One from Indore, one from Gurgaon, one from Mumbai, one Surat, one Rajkot and one Vadodara. There are 6 teams. Each team has got 6 members. Right? Then we had already beforehand, we had given the topics. Totally 18 topics were given to them to prepare. How to prepare? Each and every member has to speak for 1 minute on the given topic. Right? Suppose a topic is chest pain indispensable. Patient comes with the chest pain indispensable. So what you do? When patient comes to you with chest pain, complaint of chest pain, what you do? So you write down the points and then you distribute among your team members. No repetition should be there from any member. And each team member will be given 1 minute only. In 1 minute they have to represent. So this way they will, after that, before 2 days, we had a draw in Ahmedabad at our meeting, and in the draw, whatever the subject is given, it is already given beforehand. So 2 days back to the whole team, and they have prepared nicely. They can prepare nicely, and that's why it was done. Otherwise, it is always an instant one. That here only the draw is done, and you have to select one. You have to draw one chip. But this is for the first time in our conference. We have declared it before 2 days. So we hope that everybody of you had already prepared so nicely that everybody will be enjoyed. And believe me, here all the members, whatever the topic is given, they will speak. What we have to do from the audience side? We have to support them. We have to just say hello. Please do again. So that will be a fun, totally a fun, right? We have already decided to give 2 prizes. The judges will be there. The timekeeper will be there. So he will just monitor the time, and 1 minute to each member. So in this way, this IPL will be given 2 prizes, and because it is the first event, and the first time event is organized, all the other members who are not the winner will be also given the token prize. Right? So to take a part in such a contest is a winner and nothing else. Right? So we are just waiting for our expert and this idea from which he has given us, Dr. Urman Dhruv. He is a physician, consulting physician and diabetologist, and actually speaking, he is our teacher. He is a mentor brother. He is our teacher. Up till now, we have kept so many lectures with him, and he is just coming, and he will tell you the further things, because the minute preparations and minute things are already been he has already decided. I also don't know, and he will just tell you, right? બધા ફોટો પાડજો ભાઈ અહીંયા. One point, suppose team Rajkot, going Rajkot, not only Rajkot, sorry. One more thing I forgot to tell you, that the team from each city has been given the name like IPL. You all can see. Going Rajkot, Suti Sweetener. Let us see how sweet they are.
Then we got Vadodara, like we got Kohli, Mumbai Majestic. Mumbai is always Majestic, and irresistible Indore, and one more team is coming, and that is from Bengaluru, where Bengaluru, right? So these are the 6 teams. The most important part, suppose the topic given to Indore, and the person is speaking something, and if whatever he is speaking or he is giving the point, and if the person in the other team he feels that it is not right, then they can take objection. And our judges will decide whether the objection is sustained or ruled out. If it is sustained, they will get one bonus point. If it is ruled out, one minus point. Right? Not doing. No problem. See, I have told that after he finishes 1 minute, then you have to keep. Objection you have to raise after he finishes his 1 minute. Right? See.
We welcome our mentor, Dr. Urman Dhruv. He is Dr. Urman Dhruv. He is our mentor. Sir, मैं प्राइमर के अंदर समझाया हुआ है और तुम्हारा फाइनल
So, everyone is ready? Everyone is ready on this side? Yes. Because it is you who are going to get the entertainment with information. So this is one of its kind where there would be entertainment with information. Rules have been already explained to you. I would once again tell you, when a team comes for the performance, they would pick up the lot and they would get 6 numbers, 1, 2, 3, 4, 5, 6. And in that order they would to speak continuously for 6 minutes, 1 minute every person. And the transition from one person to another person should not be with hesitation. The marks would be given by the judges as follows. There would be 5 marks for each performance. For hesitation, especially during transition, 0.5%, 0.5 marks would be cut. For wrong information, 2 marks will be cut. And for lack of continuity, 1 mark will be cut. Right? So you will be getting those marks. If you don't have those things, you will be getting 5 out of 5. Once all 6 teams would perform, then we will have 2 finalists who will go into the final with the same format. So, so there is no final, you will perform. Okay. will be. Okay. Now, those who cheer the most is also going to get a prize as per. It's not a joke, sir. Really, those who cheer the most, who shouts more, will get a prize. And there would be at least 2 prizes for finding out mistakes which he will not tell. But at the end of each team's performance, we will be asking the audience, was there any mistake? And if anybody finds out that this was a mistake, in the medical mistake, then he or she will get a prize. So be alert. Okay? They don't get only 1 minute. Not more, not less. Less is not allowed. Now, we'll be having then total 6 minutes should happen. No issue. One can repeat himself. One can repeat yourself. But at the end, not in between. Okay? Yeah, further પછી 1 મિનિટ આખી પતી જાય પછી 6 મિનિટ પતી જાય પછી we'll be asking the teams after 6 minutes. We don't want to interrupt them anywhere. It would cause chaos. So after 6 minutes, we'll be asking teams. Every minute they will be. Okay, everything is clear.
Team all, is there any question to ask? Yes. ટીમ બેંગલુરુ હમણાં આવી છે તમને ઇંગ્લિશમાં જરા ફરીથી એકવાર રૂલ્સ કહી દો ને. ટીમ બેંગલુરુ પ્લીઝ બી સીટેડ.
I am speaking out all the rules again. Till then, Dr. Abhay is coming out with a draw. Who will be first? Which team will be first? And the first team would have to pick up the 6 teams. So, Bengaluru, you have been given your topic. Your draw, your turn would be decided by a draw. Which team comes first, second, third, fourth, fifth. And once your turn comes, you will be picking up the numbers. That would be the number of people. So, she may not be first, she may be second, you may be first, that would be by a draw. So that everybody has to be ready for everything. You will be asked to speak for 1 minute and then yeah. Topic has already been given to you. Topic has been given to you. Are you ready if you are given the topic just now, because rest of the people have received the topic 48 hours back? So, 3 cheers for Bengaluru team. They are ready to join. Okay, Rajkot people will come and pick up punches. Only one. So you will be first to perform. Fast. the cheat patient. Which is the number? 2. તમે આમ જતા. Next. So we have got Rajkot as number 1, Surat as number 2, then number 3 is Indore, number 4 would be Vadodara, I presume. Number 5 is Mumbai and number 6 is Brave Bengaluru. Okay, so we are now starting. Timekeeper is there, judges are there, and we go ahead with the 6th side. Okay, now Rajkot people will come and pick up the chief. Yeah. Polling is there, so don't get afraid. Away chief here. So come and pick up. So if the man is good for you.
Hello.
So who is number 1? Everybody would be in the queue because you have to immediately join. Right? 2, 3, 4, 5, 6. So ready? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Let's play.
My topic is dyspnea. And patient comes to me, સાહેબ મને બહુ શ્વાસ ચડ્યો like that. Now I will ask the question. કફ છે તમને, ઉધરસ શરદી છે, કાંઈ છાતીમાં દુખે છે, શોર્ટનેસ ઓફ ધ બ્રેથ કેવું છે, એ સિવાય ઉલટી ઉબકા થાય છે, કાંઈ કફ નીકળે છે કે કફ નથી નીકળતો, એ સિવાય ચક્કર આવે છે કે નહીં, કાંઈ એ સિવાય દુખાવો જે છે રેડિયેશન ટુ પેઇન કંઈનો છે કે નહીં, દુખાવો કંઈ ડાબા બાજુ હાથમાં જાય છે કે નહીં, આ રીતના. એ સિવાય તાવ હતો, પહેલાં તાવ આવે છે, એટલે એના ઉપરથી આપણે નિદાન કરવાનું છે કે પલ્મોનરી એડીમા છે, કાર્ડિયાક એડીમા છે. કાર્ડિયાક એડીમા હોય જે
There dyspnea classification, cardiac, pulmonary, cardiopulmonary and other causes. Cardiac causes we all know, congestive heart failure, left ventricular failure, cardiomyopathy, these all are cardiac and acute myocardial infarction. Respiratory failure, respiratory causes are bronchial asthma, acute bronchial asthma, COPD, pneumothorax and massive pleural effusion. Other causes are anemia, diabetic ketoacidosis disease and psychological causes there. And the other causes is the gas, exposure to gas, especially chlorine and hydrogen sulfide. These are the common causes of the pleural effusion.
I examine the patient with stethoscope, his bronchi, crepitation, or do the history of any allergic condition, or chest pain, or palpitation, taking history about the dyspnea on rest, exertion, or any position of the body, exposure of the atmosphere, psychosomatic condition, then differentiate which type of the dyspnea. And then do the simple investigation like X-ray chest, echocardiography, ECG, and CBC, CRP, blood investigation. So, as per our level, I know the these types of dyspnea.
इन्वेस्टिगेशन में सर किधर ये ना सिविल अपन हाँ यदि रेस्पिरेटरी है तो उसको डी डाइमर करना चाहिए, सोनोग्राफी करना चाहिए चेस्ट का, सीटी स्कैन कर सकते हैं, डी डाइमर के साथ साथ पेट स्कैन कर सकते हैं और एंजियोग्राफी रेस्पिरेटरी के सिवाय जो कार्डियक की तो वो एंजियोग्राफी कर सकते हैं और डिफरेंशियल डायग्नोसिस में भी हम देख सकते हैं कि कोई रेस्पिरेटरी है तो उसमें घबराहट के नहीं हो सकता, चेस्ट पे नहीं तो उसमें पर्सपिरेशन नहीं होता है, ऐसा होता है।
Good afternoon, friends. Some of my colleagues have told something about dyspnea, whether it is pulmonary or whether it is cardiac. I'll start with a definition of dyspnea to make it simple. Dyspnea is defined as a perceived laborious breathing. See, it is a perceived, so it could be psychosomatic. It could be because of some physiological condition, it could be because of some pathological condition. Usually it is either pulmonary origin or it is cardiac origin because dyspnea results because of the gas exchange pathology. If carbon dioxide accumulates, then it will lead to breathlessness. So, how can this happen? If there is an allergic condition, then the windpipes will become thick, will become edematous, will become more hard to get the oxygen transferred to the hemoglobin. Similarly, if heart is not in a condition, okay, sorry.
My old friends have described clinical examination, investigation. Now I will say something about management of dyspnea. Management of dyspnea first depends on the diagnosis, but considering the lack of oxygenation at our general practitioner clinic, the best is to take the SpO2, measure the oxygen saturation and give oxygen, and whatever is the toxic material or gas, he should be deprived of that and that should be ventilated in the room. Considering the medical management, according to the cause, we have to treat the patient. If the diagnosis is acute left ventricular failure, then we have to give diuretics in form of Lasix, 80 milligram IV state in the bolus form, and if there are changes in the ECG suggestive of coronary condition, then we have to give aspirin, clopidogrel, and sorbitrate sublingually. If the cause is COPD or bronchial asthma, start with the nebulizer. Thank you.
So, 3 cheers for Rajkot team. They tried really very well. We'll go on number 1. Any suggestion from you about the mistakes or anything? We'll be very quick. 3. Do you want to find out anything? Yeah, 4, 5. Okay. Anything that was wrong? Anything that was wrong? Okay. Any mistakes will be
repetition is okay, but any mistake anybody has done.
and P.
Okay, fair enough. That is omission. That is act of
That was
omission.
omitted.
Will not consider the act of omission. Will consider only the act of commission. So now, as a judge, just for this group, I'll say it is going to be advantageous to the rest of the people. I'm sorry about it, but there was a lot of repetition, as we all know. Everybody would agree between 3 and 4 number, and even number 6. So everybody should think that you should be in sequence and don't repeat the things, right? Otherwise, we are giving the marks. You have got ample marks, so don't get worried about it. Rest of the 2 judges are also putting it. So that is the first wicket that we see. Now we call for the second batsman.
Audience, anybody noted anything wrong?
Okay, let's give chance to audience. Okay, now one more chance to audience. We have got 45 minutes at least, no? Okay, one chance to audience.
Examination, pulse and BP तो किसी ने बोला ही नहीं.
There was
Anything wrong? Anything wrong?
There was lots of misses, but any.
I think somebody has told sonography of chest.
Yeah.
Yeah. That was wrong. I noted sonography of chest. Who is doing?
Okay. Now for the audience, rather than finding out mistake, we are giving one opportunity. Any one of you can get up and speak for 2 minutes on this topic. Only one. Any one of you can raise the hand and speak on this topic for 2 minutes. Anyone?
You said that there was one mistake, that in the case of dyspnea, sonography is not needed. I strongly object. See, in some of the cases of X-ray chest, there is a
We have not considered. Don't get me. We have not considered.
Correction.
We have not considered. Anyone? આપણે બધા ભૂલો કરવા તૈયાર છે. Are we ready to do 2 minutes? Anyone about this? 1 minute. Yeah, go ahead.
We must declare it like a pulmonary cause and any other cause.
For 1 minute. Are you talking?
You are going to speak on dyspnea for 1 minute.
You talk 1 minute on dyspnea as a new. Totally.
As if you are a contestant.
Including all.
Yeah, you can.
So we can say like that, dyspnea can be because of our lung, cardiac, and any other extra cardiopulmonary disease. Cardiopulmonary, you say it is because of the asthma or cardiac asthma, heart problems, but none of them they have given a.
Sir, you are a contestant.
Record pulse, BP, or diabetes, or the treatment wise, who can of them.
So, that ends our first wicket. Will now go to Surya. You can pick up the chief. Kindly pick back the chief. Come on, cheers for Surat. And we'll request you to speak in English and at least not in Surti. So you can adjust yourself in Okay, 5,
Hello.
4, 3, 2, 1.
Thank you. Topic given to me is red eye. Red eye is a condition where the eye appears red due to
injury or illness of conjunctiva or adjacent tissue. It is an injection and prominence of the small vessels of the cornea, conjunctiva, and that is due to adjacent tissue. Conjunctivitis and subconjunctival hemorrhage being the most common causes. Other causes are dry eye syndrome, allergic disorder, alcohol and substance intoxication, but episcleritis also. But other condition where the urgent intervention is needed is like scleritis. Okay.
Second most important thing is to take proper history. Apart from taking proper history, routine history, first of all I would like to ask for a history of any injury, severe pain. Is there any loss of visual acuity or loss of vision? Is there any comorbidities like diabetes or hypertension? Is there any history of taking any drugs like antiplatelet, anticoagulant drugs? Is there any history of sitting in front of computer for a very long time? Is there any history of dry eye using contact lens for excessive amount of time? Is there any history of fever, joint pain along with red eye? These are the most important points in the history.
Yeah, after history taking, there are certain points which we should always consider. That can be considered as red signs of the red eye. And they are, the first of all, the loss of vision or decreased visual activity, because in conjunctivitis or subconjunctival hemorrhage, which are benign causes, there won't be any loss of vision or decreased vision. But if it is there, it can be due to acute iridocyclitis or glaucoma or injury like that. Same way, if there is corneal opacity, it's a red sign. If there is a pupillary abnormality, it is a very important red sign, because in acute iridocyclitis, the pupil of the affected side will be constricted. If there is glaucoma, then there will be fixed pupil of medium size which is sluggishly reacting to light. Same way, if there is an increased intraocular pressure, that is a red sign, all these diseases requires the urgent intervention or urgent referrals. Otherwise, all other conjunctivitis and subconjunctival hemorrhage or other benign causes, they won't have these sort of warning signs. One more warning sign is corneal opacity. Thank you.
For red eye, one of the most common signs is conjunctivitis. Conjunctivitis is more common for a red eye. It causes irritation of eye, excessive watering of the eye, sometimes pain, purulent discharge, and it causes is sometimes allergic, viral, bacterial or chemical exposures. The diagnosis is obviously on observation you can see clinically. The treatment part is allergic and viral conjunctivitis. Tears drops is the only treatment, and for bacterial infection you can give an antibiotic also. Steroid is contraindicated for conjunctivitis. For chemical exposures, the single active solution is the only treatment for that chemical exposures.
Red eye is the most important topic given to us, in which the allergic conjunctivitis is the more or less more affecting the peoples or affecting the peoples. What is the inflammations of the conjunctiva is called due to the allergy is called allergic conjunctivitis, in which there is irritations, watering of the eye, then itchings. And one of the most important things, the red eye is also on the both side of the eye. So we can, it is repeatedly in the content that is in common cold things is in this season. We always look out for the allergy content. This is most important part is the pollen. Pollen which is given to this allergic conjunctivitis. and signs obvious itching, irritation, water is and symptoms. Signs is the papillary edemas, conjunctival.
Subconjunctival hemorrhage is bleeding from the small vessels in the white of the eye. It results in red spot in the white eye. Usually there is no pain or there may be little pain. Only one eye is affected. No vision is lost. The main causes are due to coughing, straining or passing hard stool, or there may be direct impact or accident on the eye. The risk factors include diabetes mellitus, hypertension, blood thinners, old age. And diagnosis is based on appearance. Usually there is no treatment for this and it recovers in 2 to 3 weeks. And for irritation we prescribe tear drops. And a differential diagnosis is retrobulbar hematoma, conjunctivitis and pterygium. Thank you.
Any queries from any team? Rajkot?
First thing is that we strongly feel that steroids are not contraindicated in conjunctivitis. If it is allergic, we can give it. Second problem is that he said that heart defecation leads to subconjunctival hemorrhage. I think that must have been at least stones to develop subconjunctival hemorrhage.
Okay. Indoor.
We can counter argue for this. Later on.
Later on. First lesson finished. Indoor and Vadodara.
Sir, act of omission, just a suggestion that in history one very important question they should ask is what is your occupation? Because what we see is red eyes are very common in the vendors. So if they are not being given the ultraviolet filtering glasses, they are definitely continuing.
That was omission.
Repetitions, allergic rhinitis, watering of
We want only act of commission.
Anything wrong they have told.
Only wrong content. Okay. Now coming to the audience. Anybody is ready to speak about red eye for 1 minute? Only one person. Anyone?
Only just I would like to have a wrong use of the contact lens as well as the overuse of.
It has already been discussed. That was it. We want only one person who can speak about. See, fari હું કહું છું આપણે ભૂલો કાઢવા માટે તૈયાર છે. Yeah. Who is there?
The subject was red eye, and we all know that what is red eye. And the speakers already discussed about the red eye, that what is the reason of it. Most of the cases are allergic, infection, injury, corneal use of cornea, etc. But what my experience, I will add 2 things. One, high fever also causes red of the eye, and hypertension or angriness, upset, flush also show some red eyes, and the temperature up down and not sound sleep also cause red eye. Thank you.
At least somebody has guts to come up and speak for 1 minute. Full marks to him. I wish they would be giving some. Yeah, go ahead.
1 minute?
No. Yeah.
So first query was about the steroids, but actually this whenever he talked about steroid, it was due to about viral and bacterial conjunctivitis. It is strongly contraindicated. Only thing you can give NSAIDs, otherwise no steroids. That is the bold line. Second query was about the hard stool. Anything which increases the intra-abdominal or intracranial pressure, there can be subconjunctival hemorrhage. So it is not true.
Both are.
Yes. So the query has been answered, I suppose. Yeah.
Agreed. Okay, indoor people can come and pick up the thing.
You are 5 persons. So 1 minute and 12 seconds will be given.
No, one person will repeat himself. One person would
Okay,
repeat.
one person can repeat. Okay. Put up cheat. Who is number one? Number one? You number one?
What's the topic?
Yes, sir. Okay. Thank you very much.
Sir, topic should.
Yes.
Topic.
Our team's topic is inhaler therapy.
Okay. Just wait for it. So we are now indoor. We are going outside Gujarat and going to Madhya Pradesh. So indoor people, let's celebrate. 5, 4, 3, 2, 1.
Inhaler therapy is a magic nowadays, and it's very common in last 2 decades. Previously it was not so common, but inhaler therapy give a magic result. You can give a therapy direct to the part which is affected, direct part, and we can systematically release the drug through inhalation to release the inflammation as well as bronchodilation. By inhalation therapy, within no time, you can get a result, and the patient will come to your clinic. If he is asthmatic or patient COPD, you give an inhaler to him, he will be alright. He will please, and he will give a thanks to you, what magic you did. That's why inhaler therapy is a very important part now it is playing in OPD cases. Right.
Inhalers are used to increase the pulmonary concentration of the drug in minimum possible doses and minimize the side effect. There are various types of inhalers. One is PMDI, pressurized metered dose inhalers. Second is DPI, dry powder inhalers. Third is SMIs, soft mist inhalers. Fourth is nebulizers, and fifth is a new one, smart inhalers. The pressurized metered dose inhalers are having propellant, which produces a high pressure aerosol, which is inhaled. In dry powder inhalers, just like rota inhalers, there is a capsule or there is powder. That powder comes in the form of a puff. And there are SMI, soft mist, in which the soft mist is produced slowly and it lasts longer in the air. And it is considered to be very good. And then fourth is nebulizers, which we are commonly using in hospitals, clinic, and then smart inhalers. Thank you.
We talked about the different types of inhalers. Now, what are the advantages and the disadvantages of individual inhalers amongst themselves? Inhalers per se are supposed to be the newer delivery system for medications. First, we take up the MDIs. Basically, the advantages are it's very compact, easy to carry. The disadvantages are that, and another advantage is that it can be in a fixed dose, fixed delivered dose can be given. The disadvantages are that supposing if a patient is not compliant with the inhalation of that particular drug, the proper drug cannot be delivered to that particular patient. For that reason, you need to give in another type of inhaler. Second is you need a propellant which might cause few allergic symptoms to a particular patient. We move on to the powdered PDIs, the dry powder inhalers. Dry powders, they give
we would now, where are these inhalers used? Normally inhalers are used in the treatment of bronchial asthma, COPD and ACOS. Bronchial asthma, we all know, is a disease which yet has not been described as a disease. The classification has not been defined, but is a disease where there is a hyper sensitive to air and there is an inflammation of the bronchial airways. And inhalers are used to deliver
corticosteroids directly into the bronchia, so that they act better. If in the first stages, those attacks of bronchial asthma may be not very frequent, then short-acting bronchodilators are considered. If the attacks are more common, frequent, then we add steroids, inhaled steroids. Even then, if we find that it is not responding, then long-acting beta agonists are added to this. This is what is about bronchial asthma.
Next. The second pulmonary disease which we'll discuss is the COPD. COPD delivered a wrong drug. The commonest LABA drugs are salmeterol and formoterol, and LABA drugs are usually which are apratropium and glycopyridine.
Picture of symptoms of both the conditions, and one may predominate, either the asthma predominate or the COPD symptoms are predominate. The treatment of choice is basically ICA, that is the caustic corticosteroid, or if you want, you may add LABA or LAMA accordingly. The inhaler therapy is also being used for the antibiotics inhalation. It's a very newer concept, especially when there is cystic fibrosis or bronchiectasis, or the disease is caused by multi-resistant bacteria, then the antibiotic is given by inhalation. The tobramycin has been now introduced and the formulation is formed for treating all these diseases. We have all discussed about the inhaler therapy, but take home message is that there are many myths about the inhaler therapy in the community, and we should try to reduce those myths. Thank you.
Well done, really well done. Any positive mistakes that you want to enumerate? Rajkot, Surat, yeah.
Somebody says that there is a no time effect of inhalation therapy. So this is the wrong information.
Okay, fair. Nothing. Okay. Rather than going for asking the mistakes, I'll go for two questions for audience. You have to raise them, just don't answer. One is, which is the most important instruction that you will give to a person on a chronic inhaler therapy? Yeah, anyone? Yeah, go ahead. Go ahead. Absolutely perfect. So we want to go up with a definite message. Gargling after every inhalation therapy. That's very, very important. Otherwise it would cause fungal infection. And one more question. What is the test of choice in bronchial asthma, by which you can diagnose it, definitely? Any? Yeah, stand up please. Spirometry, pulmonary function test. Fine. 3 cheers for our audience. Well done. You can pick up the chief next.
बोलो दीपक भाई. हाँ तो वहाँ एना पर तो बड़ी बात नहीं जानी चाहिए. इसने क्या वीडियो रूम चालू.
Okay, so standing queue 1, 2, 3, 4, 5, 6. You are ready?
Yeah, I'm ready.
Okay, so once again we are back to Gujarat and Vadodara is coming. So I think there should be more cheers. Of course, you have performed very well. So, 5, 4, 3, 2, 1, let's play. Go ahead.
Good afternoon from team Virat Vadodara. Our topic is malaria. So malaria is a vector-borne disease and it is transmitted by the bite of infected female Anopheles mosquito. And the mosquito typically bites during the twilight or in the night hours. And there are 5 species of malaria which have been identified. Falciparum ovale vivax knowleski. The malaria is endemic in certain areas of the world, like African countries, and it is completely eliminated in some countries like China. The incubation period of malaria is till 1 month, so that's why the prophylaxis is also advised on those guidelines. The 25th April is celebrated as World Malaria Day, and June is declared as Malaria Month. Government of India has a national malaria eradication program.
Symptoms of malaria include fever with chills, especially on alternate day. The associated symptoms are vomiting, nausea, myalgia, arthralgia, dizziness, and some patients may present with the abdominal pain, diarrhea. That's all the symptoms of the malaria.
Now, how to diagnose malaria? We will diagnose it all knows by peripheral smear examination, thin smear and thick smear, and then recent advances is a rapid diagnostic test which is antigen based test, and for further diagnosis we can also do PCR test. For complications of to find out the complications, we can go for CBC, liver profile, renal profile, and if necessary we can go for further investigation.
Now I will talk about the treatment part. For malaria positive patient, first we have to see the hydration part of the patient. We should give antipyretic and then simultaneously antimalarial should be synthesized. Antimalarial, the first choice is always chloroquine. Chloroquine should be given 150 mg BT for 3 days followed by primaquine 14 days in P. virus malaria. And for P. falciparum, still chloroquine is sensitive. In that case, chloroquine should be the first choice with primaquine. 50 mg 3 doses should be given on the second day. But now government national malaria control program, India has divided India into 2 parts, northeastern part and the rest of the country. In northeastern part the drug of choice is ACT with LM, and in other countries government is now giving ACP with SP medicine. So we should, before giving primaquine, we should see its contraindications. Like in case of the pregnancy with malaria, one should avoid ACT. And first choice is the quinine. In first trimester of the pregnancy, quinine is the drug of choice, and second and third trimester of the pregnancy, ACT is the given, artemisinin derivatives are given, and after that, clindamycin is given for up to 7 days for the radicular cure. For gametocyte control, to avoid the recurrence of the malaria, primaquine is the drug of choice. If it is contraindicated, one should give doxycycline or clindamycin for 7 days.
Regarding the complication of the malaria, now it is dictum that the vivax malaria is no more benign. We are frequently finds in day-to-day practice in vivax malaria with the malaria with ARDS, and in falciparum malaria we all know there is cough, ARDS, DIC, cerebral malaria, hematuria, renal failure, like that are very common. And for the complicated malaria, P. falciparum malaria, treatment is advised is quinine 20 mg the dose to start with the first dose and followed by 10 milligram per kg for the 7 days, or the artesunate 2.4 milligram IVBD for 1 day followed by 1.5 milligram IV for next 4 days.
Objection. About the dose of chloroquine, madam told 150 milligram. It should be 10 milligram.
Hello, the dose. Hello, the correct dose of chloroquine for P. vivax malaria is 10 milligram, followed by 5 milligram per kg body weight after 6 hours, and then 5 milligram BD for 2 more days.
Incubation period, the madam told 30 days.
Both the mistakes are.
एक मिनट सर, according to new guidelines, national guidelines, chloroquine 250 milligram first day on first day, 200 milligram first day on second day, and 250 milligram 2 tablet on the third day. This is national guidelines. And one minute. And before starting remarking, everybody has to go for G6PD depression test. If it is not possible in the rural area, always ask the health worker to ask for the urination.
No, they had spoken artisanate SP. They said artisanate SP. Both of them said artisanate SP. That's okay. But rest of the mistakes are valid.
Sir, for SP, sir, always look for the Stevenson-Johnson syndrome.
Agreed. That's not a mistake.
You have to say
Okay.
Dose of chloroquine.
That has already been discussed.
And the duration.
That's been discussed. Okay, it has been rectified. Fair enough, but even then I would say that Vadodara has really, sorry, not Vadodara, Vadodara has done really very well, equal to Indore, and the competition is really getting tough. Question for the audience. Generally, people coming from abroad, that is Western countries, are given a particular drug for prophylaxis. Anyone? That's not actually a question. Now, the question comes now. And just raise your hand, don't answer. Mefloquine has to be given generally with fruit juice. Why? Mefloquine has been recommended to be given with fruit juice. If you read the brochure, they have written. Any idea why? Raise your hand. Raise your hand. It's not hypoglycemia. Anyone? It's because of hypokalemia. Right? It causes hypokalemia. So we are learning something from here today again. Okay, we go ahead for the next time. Ready? What's the topic?
Acute cough in OPD.
Acute cough in outpatient department is the topic of Mumbai Majestic. तो ये रोहित शर्मा की टीम है या फिर ईशान किशन की टीम है. ज्यादा बिकने वाले की बात करें 18 करोड़ वाली. तो 15 करोड़. Okay. So let's start. 5, 4, 3, 2, 1. Let's play.
In OPD basis, whenever patient comes to us with acute cough, it can be pediatrics, below the age of 3 years, it may be adults, it may be geriatric patients. If a small child comes, you have to find out what is the history for last 1 week, 10 days, 15 days,
and he had a measles, he just swallowed anything, foreign body, which also use acute cough, or he is getting running of nose, which can also use acute cough. It is adult. Adult can come out with acute cough, and he may have history. You have to ask him history of bronchial asthma, any drugs he is taking, maybe aspirin, maybe amidovirin, or any other drugs. You have to find out the history of the drug. Then he has any history of taking ACE inhibitors. Then you have to find out any history of cardiac history. You have to find out any history of COPD, any history of his occupation, because occupation does do this. Any exposure to
is he a smoker, active or passive? Then any history of allergy is there, any chest pain is associated, breathlessness is there, any vomiting is there, anybody in the family is having any respiratory disease or allergy. On examination, I will see the vital signs like the temperature, pulse, respiratory rate and BP. And then I will check on the nose if there are secretions, there is coryza, and then the throat, whether there is any redness, there is any folliculitis. I'll check the cervical glands, whether any glands are seen or palpable, and then on the chest. I'll see the chest, whether there are movements of the chest proper, and then I will see I'll do percussion, and whether there is any dulma, whether it is pleural effusion or pneumonia. On auscultation, I'll see sounds, air entries there or restricted, or there is any bronchi. Then I'll think in terms of bronchial asthma, if it is crepitations, I'll think of and if there is bronchial breathing, it is pneumonia. And if I feel a pleurisy could be there, I will also check the and I will also see any edema is there, and I will do a pulse oximetry and do a pulse flow meter to see what is the situation of the patient. Hello? Now that we have completed the history and examination, now can OPD basis we will be thinking of what investigation we need to carry out. First of all, we will be doing the basic investigations like CBC, ESR. That will be very important. If in CBC, if we find, say, leukocytosis, we will think in more in terms of is it a bacterial infection. If there is eosinophilia, is more we think in terms of allergic or bronchial asthma. If it is leukopenia, it could be acute viral or coryza. And also later on we can think in terms of, depending on the cough, we will be doing pulse examination, sputum examination to find out is there any organisms we can find out. And chest X-ray will be very important in these cases. Chest X-ray might show either consolidation, it might show some like patches of proptosis, also it can show little pleural effusion that can give rise to cough. And also we can do because if you're thinking in terms of acute NBF, we need to do ECG and later on in our clinic and later on 2D echo definitely. And another one later on CT scan we can do.
One more thing in blood test was pro-BNP they need to do. Treatment depending on age, if it's a pediatric group, below 3 years, in acute coryza, the mother should do suction with the 2 ml syringe, suction with the 2 ml syringe and put at the same time after the solution for sodium nasomist to clear the blocked nose. In adult patient, we go according to the cause. If it's acute coryza, we need a symptomatic treatment because usually it's a viral disease. Like steam inhalation, first generation antihistamine and decongestant, salt water gargle, washing hands, hygiene, and wearing mask, both doctor and patient. And in acute bronchitis, also if it's viral, we don't
Bronchial exacerbation of bronchial asthma, which is cough for 3 weeks. We have to give the inhaler. Either you give a short acting like salbutamol and then you can switch over to formitol, the long acting. To tide over the crisis, we give steroid. in exacerbation of bronchial either you give any steroid called methylprednisolone 4 mg twice a day, minimum 5 days, maximum 10 days. And on the long term, you can give the darbepoetin if patient is having a breathlessness, can take for a long time. And if the person is having exacerbation of bronchiectasis, then of course we have to give the antibiotic. And the antibiotic can be given either the augmentin or you can give ceftriaxone, or depending upon the culture we decide the treatment, posterior drainage to drain out the phlegm, and we give a mucolytic agent like a bromhexine or guanfacine to take out the phlegm. And if it is an acute left ventricular failure giving rise to cough and a breathlessness, then of course,
So, if we think, depending upon the history, the examination, the investigation, now we think, if we suppose we are suspecting that this is post-viral dry cough, which is common in influenza or post-COVID, we will give a cough suppressant in the form of dextromethorphan or codeine with an antihistaminic like levocetirizine or fexofenadine. But if it is a productive cough, then we will give a mucolytic, which sir has already said. The other thing could be that the cough is because the viral upper respiratory tract has led to viral pneumonia. So if we are suspecting a viral pneumonia, then again we will give the cough suppressants and an antibiotic depending upon the CBC, whether it shows leukocytosis. Most of the time it could be leukopenia with lymphocytosis.
Any mistakes the last sentence? Obviously leukopenia with leukocytosis. That's okay. Anything else? Yeah.
The first one was acute illness. Acute always means it is within 24 to 48 hours. The definition was wrong from the first question.
But
and the second one was
the
first
answer
generation.
is first answer. Even in bronchial asthma, there can be acute cough, and the acute exacerbation has been defined as change in the cough frequency, change in the cough quality, or change in cough severity. So that can be acute. Yeah, that can be acute. Patient was stable and then he developed, so it's not anything.
And then second one was, one of them told us first generation antihistaminics, which is not true, which was corrected by the second one, where they said second generation antihistaminics.
True.
So first generations are no more used except CPR.
Agree. Okay, it's not a valid point. Anyone else? Okay, question for the audience. How does a pathologist differentiate? How does a pathologist differentiate between saliva and an expectorant? They would send you the phone, okay, it is saliva only. No pH, no dissolved in water. Yes? No, not color, not food particle. The answer is similar for urine also.
Smell.
Presence of which cells? Presence of epithelial cells. Presence of epithelial cells in urine suggests contamination. Presence of epithelial cells more than 20 in a specimen suggests more of saliva and less of it. The pathologist should not do it. Okay? Yeah.
Because aluminum cells also epithelial cell, the blood cells is also epithelial cell, which is present in secretion. It is only squamous epithelial cell.
Agree. True. Absolutely perfect. You have a second. Thank you. So, at least I have also learned today. In fact, very nice. I think they should get at least 1 plus point from my side. So we have got our last contestant with us. For rather than starting from 5, we'll start from 10 because they are the last minute entry. They did not know the topic. So for Bengaluru, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Go ahead.
Good afternoon. My topic is management of diabetes in hypertensive patients. So when a patient comes to me who's already hypertensive and he's a newly detected diabetes, to start his management, I will first think of what he's already hypertensive. So he may be having already existing other factors contributing. So first of all, I will see if he has an advanced cardiovascular problem. If there's cardiovascular problems, I have certain drugs which I will prefer, like SGLT2, DP4, GLP analogs. Suppose he is having a renal disease. So if he is having renal disease, I will rule out the drugs which will cause worsening of the renal disease and will not give him these drugs. Like metformin cannot be given, and in severe cases, gliptins also, only linagliptin is given if it is less than 30. Then if he is obese, I will think of drugs which will help him to lose weight along with his other controls like maintaining glucose and his BP. So I will give him SGLT2, GLP-1 analogs. Suppose he is economically burdened, so I will think of simple drugs. And all said and done, the first drug to be given will be metformin.
Okay, complication in diabetes either occurs due to macrovascular and microvascular complications. So macrovascular complication is mostly cardiac, then comes renal, micro comes either eye and peripheral vascular disease. More cardiac accounts for about 40%, then I think kidney accounts for 30%. There are in micro, eye accounts for the major stake and peripheral vascular accounts for the minor stake.
Mine is screening in diabetes in hypertension. Usually with hypertension patient, we should screen for fasting blood sugar, post-prandial blood sugar. If he's a diabetic, once in 3 months HbA1c, regular checkup. And then for microvascular, urinary microalbuminuria and macroalbuminuria, creatinine and cholesterol, regular checkups has to be done. Next, quickly.
Any hypertensive patient walking into my clinic, I will check for diabetes because diabetes is common in a hypertensive patient. So we look for polydipsia, polyuria, frequent urination, especially in the night, and also loss of weight. Without any cause, hypertension, we do not have loss of weight, but unexplained loss of weight, tiredness, we look for these things. Signs, we could already present, we have known diabetes patients presenting with a retinopathy in the first visit itself or with a foot ulcer. So when you examine any hypertensive patient, keep in mind these factors and thorough examination from head to toe of the patient so that we do not miss. Pedal edema also has to be checked to see that they may be already having chronic kidney disease, and diabetes worsens the chronic kidney disease in a patient.
In a situation where a person has hypertension with diabetes and he lands up with insulin treatment, the chosen insulin at present are basal insulins. Amongst them, the List Pro is the one which is more common, and if the patient is a businessman who should take only weekly twice or thrice, then we go on to Digludac. So we can have short-term insulins of these insulin analogs which have got more advantages, like they do not cause hypoglycemia and also can be taken just before or just after food. Whereas the other conventional insulins or the human insulin should be taken at least half an hour before food and they last long for 8 hours, so we can expect certain amount of hypoglycemia also. So the monitoring is required with the other insulins rather than the insulin analogs, and the hindrance is only the cost with these insulin analogs than the other insulins. Amongst these, the insulin apart from type 1 diabetes, we do have in GDM, the insulin analogs now are preferred, preferably the insulin aspart.
Hello. So they all explained about the diseases. Now I am coming for a very important thing. That is prevention. How to prevent and how the lifestyle you have to maintain it. So ask the patient or the diabetes first follow food criteria. What the foods he has to take. We have seen people taking some sweets and say we take one more glucose injection or like that. That to be avoided because they have to follow what the doctor gives the prescription. That is to be followed. Then only we can control the diabetes and its complications. Otherwise, we are seeing so many cases of kidney diseases and kidney failures. If they are not following it, they will go into the. So we have a lot of kidney failures and kidney dialysis centers are opening. So it is better. We have to advise them for proper food, water, rest, sleep, and tension-free. If all these things they follow, that immediately or it can be controlled diabetes with its complications. Thank you.
Well done. Very well. What was exactly the topic of the day? No objection. Management of diabetes in hypertension. Okay, fair enough. Okay, so I think that's where we conclude. Excellent effort by all our participants. And I've been speaking for last 40 minutes. So it's time for the rest of two judges to have few words and then the Dhiren.
Actually, among the family physicians conference, this is the first trial which is conducted here, and with the help of Dr. Urban Bhai, he is doing since so many years in the RSS, PI and NATCON. So he has advised us, he has guided us, and he has really carried a very helpful to all of us. And I think all of you must have learned so many things, and you have enjoyed also. So we have learned these are not competitors, these are our friends. And I always say what I learned from my mistake. So this is the common mistakes what we are doing, not they are doing, just we also are doing the same mistakes, and we have to learn from that. Thank you so much. And thanks a lot to all of you, thanks a lot to all the team, and of course, thanks a lot to Dr. Urban Bhai.
Before the results are declared, couple of things for the audience and for the participants. All of you have done very well. Remember, this is for the first time we have played this game. We have played many different games, but this was altogether more enjoyable. All the participants are requested to take the results sportively. All three judges have been really very sincere. We have evaluated very sincerely, but even then, भूल सभी से होती है, कौन है जिसने ना ठोकर खाई. So don't take it very seriously. You all have performed well. We'll end up.
You commented that you are also learned today.
Stop learning people. Stop being the.
So, I hope that you all have enjoyed it.
Yes, sir. Yes, sir.
And one more thing, that take a message from this thing, that in your branch, in your unit, you always do this thing, exactly, and that is the way. The only thing that I want to really know, that how many of you have really read everything? Yes, very true. See, madam, I have told Dr. Harish Kumar, it was the mistake of Bengaluru branch. Right? I have just shown.
Accepted. We have had absolutely
only one thing, judges are preparing the results. Quiz 1 minute. The judges are preparing the result. The first number and second number will be given prize, and all the other will be given token prize. Right? But for token prize, I request the captain of all the other 4 teams that you please come inside and take their team members' prize from me. Okay?
So we compliment the organizers for thinking of this really innovative idea.
All credit goes to him.
Do you know what is the lesson today? You must have read a WhatsApp message that is going on for years together. What is the significance of 1 year? Ask such and such person. What's the significance of 1 month? What's the significance of 1 millimeter? To ask a runner who has lost it by a couple of minutes. Same way today we have learned the importance of 1 minute. How difficult it is to speak for 1 minute, that too in a sequence. And second thing that we should learn, and that was probably lacking in most of the teams, was coordination. It should have been just like handover to one, and it should come in sequence. Obviously people were not prepared for the numbers that we added at the last moment, and that was the reason why we added. But we need to learn 2 things. Significance of 1 minute. Start speaking for 1 minute in English. It's a part of our job, right? So everybody should do it. They did it successfully. We will not be able to do it. And number 2, importance of a team event. It was a team event, and most of them did very well. Thank you very much.
So it's exciting to declare the result, and Team Mumbai Majestic is the winner and getting 50.5 out of 60. And the second runner-up is second runner-up is Team Indore, and they have also done very good. They scored 49.5 out of 60, so only 1 mark difference is there. This everything also depends on the subjects they are given.
One more thing about the Bangalore team, even though they were not aware of their topics, but they have done a very good performance against Kerala.
Gujarat being the host, we can safely say, महिमा जो हमारा होता है, वो जान से प्यारा होता है.
Now you will be also eager to know other results of other teams. Surti Sweetener is also getting 48 out of 60. So there is a very small difference of mark between second and third. Team Bengaluru also get 45 marks out of 60. So they are having 4th rank. Team Vadodara is getting 44 out of 60. Not giving rank to your team Rajkot. Try your luck next time. Please stand here. We are having a group photo. Please come here. We are having a group photo, and we end the session. Please come. We are also giving the other teams prizes. Abhay bhai, please come on the stage. Abhay bhai. Within a short while, we are starting our fourth session. Thank you all. Please collect your prizes. All those who have taken part, please take your.
Please be in the hall and we are going to start the next session, scientific session. For this session, I would like to invite Dr. Kirit Gadvi as a reporter. Dr. Kirit Gadvi, sir.
I'm keeping it here. Early bird.
एक मिनट जानो सो
For this session, I will invite chairperson Dr. Ashok Rasalkar from Mumbai and Dr. Falgun Shah from Delhi.
Good afternoon. May I request Dr. Karthik Shukla to speak on robotic knee surgery?
Ôi cho một lôi program
Hello. Good afternoon.
થોડુંક ચાલુ થાય ને બેસો નહીં બાજુ સીધો ભરી
Okay. So everyone must be knowing about the patterns of arthritis and its line of treatment.
એ પ્રકારની ખુરશી મને નહોતી મળી.
Silence, please.
સર ના
Excuse me. To remain silent.
Silence, please. I request, please, silence, please.
So we are going with the two modalities of treatment very fast. Number one is when the patient comes early with some early stage of arthritis, there is a better option for patient. And then the recent advances in knee surgery we are going to talk about. We have a team of 4 orthopedic surgeons working at SJP Holistic Hospital and looking for orthopedics and joint replacement department. So if we understand the concept of microplasty, what exactly is the word microplasty is derived from, no one is going to watch the Bharatanatyam or the traditional music or dance unless someone is interested in understanding. So that is the intellectual part of a knee arthritis, the staging, grading, identification. And the second is the technical part, that is your surgical expertise, that you cannot learn this kind of dance overnight, it takes a time. So it is intellectually exciting but technically demanding procedure. So that is going to be conceptualized this very easily. This is our own learning and our own progress in the field of microplasty. We started in almost 2014. We are under very limited number of patients we are seeking expertise, we have our own fear, our questions, our concern of longevity, and we have now understand it quite better over 10 years of experience with our optimized surgical team, and we have definitely more patients. So now in last 1 decade you can say we have 4,500 patients, and less than 1% patients are unhappy patients. So the all criteria, the previous criteria which was preventing the procedure is very stiff deformities, numbers, weight, activity, but it is not based on the concept of a pathology itself. So which was completely transformed with a philosophy and contemplation which is based on evidence, and it is now a physiological criteria which is where there is no numbers, no pathology, a simple radiological documentations, and preserved physiology is confirmed. Now how to select a right patient, that is very important, and it is very simple because in Western world the diversity is very less, but in our population 70 to 80% patients live in rural India. We cannot deny this fact. Our customs, our religion, our habits, our festivals, which demands a different kind of functions on the knee, and another class of patients or population that live is urban area with lot of different hobbies, habits, lifestyle, and definitely the young female patients is increasing with osteoarthritis, and definitely obesity is giving a problem to treat the patients. As it was a COVID time, we designed this understanding of identification of a 3-layer. So number 1, rule out the hip and spine. So it's a knee problem, first layer. Second layer, whether it's an osteoarthritis, so you need to rule out rheumatoid arthritis or inflammatory arthritis. And how you can be very sure that this is anteromedial osteoarthritis. For I think I have prepared this slide very easy to understand. If the AP X-ray, which is a standing X-ray, has to be a standing X-ray, that is very important. When we try to evaluate arthritis, it has to be standing X-ray. If it is completely bone-on-bone arthritis, your job is done. If it is not bone-on-bone, then you need to demonstrate it through a varus stress view. You need one more X-ray and it will confirm your diagnosis. If you feel the arthritis is more severe, then you just need a valgus stress view. So 3 X-rays will do the job. Very simple to practice in day-to-day life. No fancy investigation. So early osteoarthritis in one compartment will come like this, second will come like this, and third will come like this, but this all doesn't need knee replacement surgery. These are the one compartment isolated osteoarthritis. So this is just a progression of a disease, you can say. We all know, I'm not going to enumerate or describe the advantages or benefits of this thing. You can just compare. This is a total knee replacement needed with an exposure, and this is just a microplasty. In most of the world center, it's a daycare procedure. So the basic difference, if you do a knee replacement surgery, you have to sacrifice few ligaments, and whatever you get at the end is an implant guided motion. That is very important to understand. Whatever the implant is going to give you, that kind of motion you are going to get. While here it's a motion guided implant. As your knee moves, the implant can move within the knee with natural kinematics and better functional outcome. Sometimes it is claimed we cannot correct deformities with it. If you put your implant in proper alignment internally, definitely you are going to get external alignment automatically. You don't need to bother for that. It can never be undercorrected, it can never be overcorrected. It should fall in the exact axis. So if you see this, this is most important to understand balancing, because you are putting just a poly free inside the knee, needs meticulous surgical execution and very well trained team working together. This is just a demonstration. You can see this poly, just you have to slip it in. It's very easy. You can just place. Evaluated through proper X-rays. It's a simple knee and you just get away with microplasty procedure. Obesity, lots of obese patients. In totally, it's a problem sometimes because you need a strong bone, you need a rod, augments and wedges. Here you don't need that. We have lots of obese patients and this is a routinely seen. Only need is a meticulous positioning, and that's why the teamwork is so important. Nothing is forgiving when you operate this such kind of obese patient, but it's very easy when you operate this patient because this is done in a hanging leg position. You don't need a total knee position on this. So this is wonderful to say. In India, we are second in population, but we are not in 25 worldwide. So we have a lot of comorbid people. And if you see the senior citizens, we have a dual comorbid condition which is so prevalent in India. So safety of total knee is well documented in healthy society, but for our patients I think we should think in a different way. This is a wonderful paper mentioning bilateral procedures of microplasty rather with less complication in all perspectives than a single total knee surgery. So it indirectly motivates the surgeon and the society to go for a better and safer option. If you see preoperatively, no fancy investigation, preoperative only X-rays and basic workup that we need. Less duration, less operative people, less blood transfusion, and everything is very less post-operatively in terms of readmissions, rehab, hospital visits, and very early return to work. So this is what you have routinely seen by the patient, what they are doing after the surgery. So it is initially very amazing to us, but now this is very routinely seen. A person walking very fantastically without pain, because again the anesthetist is very key person to look after the post-operative pain period as well. So natural function, we have lots of slides. I am just going very fast. So this is like if we say the diversity, these are all teachers. These are all teachers. One is a yoga teacher, another one is a school teacher, another one is a dance teacher. The demands are very different. One is obese, one is very thin, one is very health conscious. But irrespective of this diversity, the end result doesn't vary. They all have a wonderful results. So that is what we say reproducibility. Now if you go to the robotic knee replacement surgery, so what exactly we need when we want to use a robot? Why we need a robot in our OT? So it is a very simple understanding. We need a precise data. We in more one dimension. Rather than the 2D, we want 3D interpretation of the object. We need something which guides us for planning, that is artificial intelligence. And third is a robotic accuracy to reduce the human error. So it's always a concert between a machine and a man to go to a next level of thought process and execution. Let's understand this very simply. So robotics is number one AI, that is artificial intelligence. Second is a human intelligence, always a well-trained, well-experienced surgeon and a team of people, always necessary. And the third one, that is integrated action, that whatever you have planned, what you have got, now you want to execute on table without error. These are the three pillars of robotic surgery. If you go for AI, what system we have is a CT-based system. So number one, the data is also checked. If you have a wrong data, your RMSE value goes wrong. So that CT is not accepted by the software. It should be less than 1 millimeter. And then you can have the auto segmentation. It saves a lot of time. Then definitely you can see this on screen, a 3D model of the knee anything you want to see, osteophytes, the notch, the defects, the interactions of bone with the bone, everything you can see, and you can play with the model with a virtual surgery you do on table before surgery in a surgeon's room. You can plan very well every millimeter, every degree on a 3D model, and then you will have a report that will go inside the robotic system. So human intelligence is nothing like a robot cannot do everything. It's a surgeon, well-trained surgeon, because soft tissue is a surgeon's issue. So robot cannot help you with the soft tissues. So well-trained team is always necessary. This is very interesting to see. So this is the system which helps very well. That is what we call as integrated action. So now what you have designed, you planned, you want to execute on a patient, and this is where the robotic arm will do everything precisely in a way you want it to do. So these are the demonstrations of various bone cuts the robotic arm is doing very precisely, very accurately, and from superficial to the deep, including the peg holes, the finest implant positioning, you can plan and you can execute. So this is a self done by the robotic system, no human hand is needed at this time. So the concern of human error that comes in a picture is completely zero in this. So benefits, what exactly again, what will the outcome? Number one is the precision. At the end, whatever the robotic system we are using, we need precision, and that can be done through planning. That is the best possible planning you do with the system, whatever you have. The second important thing you want is the preservation of bones and soft tissues inside the joint. Third is a providence, that is a long-term results. You want your patients to be very happy and functioning after decades. And number four, performance, that is the range of motion, stability, and their confidence in their day-to-day activity. So it can be done through the robotic. This is a robotic picture. Anyone can appreciate the book picture kind of things through system. So the take-home message would be microplasty is a better and safer option for AMOA. Only neglected knee and the rheumatoid patients need totally. It can be robotic as well. Reproducibility is a key. This is a key word in our medical science, that how much reproducible we are. Anything that helps, it should be incorporated in practice. And microplasty is a philosophy and not just a procedure. More we understand, more it is appreciated. And last but not least, robotics in knee is an effort to explore artificial intelligence through human intelligence, and integrated action of a human and robot can prevent human error in joint replacement surgery. Thank you.
Thank you, Dr. Karthik Shukla. May I request Dr. Karthik Shukla to be felicitated on this topic? And now you invite Dr. Krishna Kishore Goyal for his topic on imaging and debulking therapy in the treatment of cat.
Good afternoon, everyone. Really enjoyed the session. I was there in the whole session of the academic 6-a-side session. Continuing with the innovations what Dr. Karthik sir has told, I am going to tell some real innovations in the field of cardiology. So, since angioplasty has been done since 1977, the first angioplasty has been done in 1977. There have been not many innovations has been done, and these are some of this rotablation, IVL, IVS OCT we are discussing today. These are the imaging and the angioplasty in the heavily calcified vessels. So what should be done? Around 25% of the coronary artery patients are heavily calcific, and in these heavily calcific lesions, doing angioplasty in earlier days were rare when we used to send the patient for the bypass surgery. Because of the risk of stent failure and stent under expansion. So nowadays with rota ablation and the newest therapy of shock wave, that is intravascular lithotripsy, which has come up from the renal lithotripsy. The results have now gone wonderful in the coronary. The percutaneous techniques have given the very good results. This is a rota ablation system. This is a diamond. There is a diamond drill. There is a burr is made of a diamond drill, and there is an endovascular procedure. Actually, it is available since last 3 decades, but still we are not using much. It is used in less than 1% to 10% in selected centers only. And this has actually innovated from apart from earlier there you can see a foot pedal and a foot, hand and eye coordination. But nowadays this has also gone up to one more level. We only need a hand and eye coordination. The foot has now been removed. So what are the indications for this? This single vessel coronary artery disease with stenosis that can pass to the guide wire, and multivessels, which is high risk for bypass, and those who have a restenosis in earlier and less than 25 millimeter length, and in whom it can't be done. The patient with a thrombus or dissection, those who have a earlier bypass done, and in the vein graft, and the occlusions in which the guide wire will not pass, and if the LV ejection fraction is very low. So in whom we should take precautions. Those who are not, in which it can be done, but those who are not candidates for bypass surgery, severe triple vessel disease, ejection fraction less than 30%, lesions longer than 25 millimeter. I will show you a case. This is an 86-year-old male, definitely high risk for bypass surgery, and who definitely wants some intervention. He doesn't want only with medical management. In this 86-year-old, there is a very tight calcific lesion in the LAD, in the proximal LAD. This is the system of rota ablation. This is the drills the calcium, so that the calcium is broken, and then there is a deployment of stent, and the stent expands well. The stent has been placed, and I will show the final result. So in this 86-year-old, it would have been difficult otherwise if you would have not done the rota. The guidelines also say that this is a class 2 indication for fibrotic or heavily calcific lesions, but it is definitely not needed in all the calcific lesions, for de novo lesions or instant restenosis. Now IVL is this is a novel technique, definitely established after the success of renal calculate treatment by multiple lithotripsies. This is the same technique of delivering the pulsatile sonic pressure waves to circumferentially modify the vascular calcium. You can see the lithotripsy emitters with which there is the balloon is actually melting the calcium. There are lot many trials which have shown that the angiographically good result without any complications. This is a 78-year-old triple vessel disease. As you can see, the RCA is filled up with the LAD. So there is a very risky rota ablation. In this, IVL is a better option. This is heavily calcific. This is the IVL balloon which is inflating. And after IVL, there is easy deployment of stent, and this is a final picture of the stent. This the disrupt CAD 1, 2, 3, 4. All of them have shown that the severe coronary artery calcification, which require coronary revascularization, IVL was safely performed with high procedure success and minimal complications. Now coming to the imaging techniques. IVS and OCT. OCT is the imaging modality which uses the near infrared light to provide high definition images of the artery for precision for a measurement of the stent selection size, placement and deployment. This uses the MLD and max, pre-angioplasty morphology, length and diameter, and post OCT the dissection to see if there is any dissection, stent is well apposed or expanded or not. It can be done in all cases like direct stenting to IVL or non-compliant balloon. This is the case of 58-year-old male. Whereas the ostial LED, they are difficult placing a stent in ostium if you don't know the exact anatomy. So in the ostial LED, after the stent is placed and it is post-dilated, we check the OCT. We can this is the OCT view of post stenting. We can see the stents actually whether it is well opposed or not, if there is any dissection or thrombosis or not, and the exact location. In this case, we wanted to see whether it is exactly from ostium or not. So the exact location can be known from this OCT. So accurate ostial LED stent placement verified by OCT. These are some of the various trials, and you can see the naked eye imaging versus naked eye angiography versus imaging. You can see the 1 year revascularization, the mace rates are definitely much less in those patients in whom the imaging has been done. Now coming to the other modality of imaging, that is intravascular ultrasound. So what are the reasons in whom we do the IVUS? IVUS is a diagnostic IVUS assessment. Otherwise the angiography is a 2D image only, and IVUS will get a 3-dimensional view. And we know the exact characteristic of the lesion, and this will impact the treatment choices, the pre-dilatation, plaque modification, stent selection and sizes. Another one is angiographically indeterminate. Suppose the lesion is around just 60 to 70%, whether it is important or not, we can know after we do the IVUS. If it is 60-72%, but if we do the IVUS and it tells that it is the plaque burden is more than 70%, then we definitely should stent it. Otherwise, we can leave this. Guidance of stenting, we can be known from the IVUS. This is the surface area which we know by IVUS whether it is important to stent or not. And even after stenting, the post high pressure stent deployment, whether it is proper or not. After stenting, many times there are thrombosis in the vessels that can be well recognized by the IVUS, and even the restenosis also can be known. So the assessment of complex patients and the lesions through the IVUS, and it is actually very beneficial in some subsets of patients like renal failure, in which you have to use less number of dye, and this is helpful in diabetes, poor LV function, and for high risk subsets as well. And for the assessment of complications such as major or minor dissection. This is helpful in peripheral interventions, just like in IVC filter placement, renal artery imaging, AVAR, TEVAR, aortic dissections as well, and peripheral angioplasty. So this is a case of IVUS in an 81-year-old male. This is the IVUS catheter, and this is the IVUS images. So this IVUS image shows that there is only 2.03%, 2.03 square millimeter is the area with a plaque burden of 74. That means we should definitely stent it. And this is after stenting, the area is well increased to 10.4. Guidelines also tell that this IVUS for indeterminate left main coronary artery disease and IVUS and angiography are reasonably 4 to 6 weeks and 1 year after cardiac transplantation, and to determine the mechanism of stent restenosis. IVUS should not be used routinely in all angioplasties. That is a class 3 indication. And clinical use of IVUS imaging in Europe, the European expert consensus, thus IVUS and OCT are equivalent and superior to angiography in guiding and optimizing the PCI, the stent expansion, apposition and complications. So the take-home message is not to show off the what we are doing, because the message is here that the problem is so much that we should take care of our own, and then we take care of our patients. In flight also that is told that first you take care of yourself and then use the mask oxygen for others. So if you will be knowing that there is modalities like IVUS and OCT, so we will definitely tell our patients to go ahead with that. And the problem with calcium coronaries is increasing day by day with the increasing risk of diabetes and CKD. And multimodality imaging techniques and the use of dedicated devices key to improve patient outcomes. Thank you.
Thank you, Dr. Goyal. Next speaker is Dr. Sagar Vithai in the exciting feature ahead in the field of neurosciences, imaging and debulking therapeutic treatment. No, that's in the field of neuroscience.
Good afternoon and thank you so much all the dignitaries present here to inviting us, the whole hospital of SJVP to this conference, and after the IPL, so time for some studies. So the reason why I have chosen this topic in a more broad sense is that we always relate neurology as very less treatable and more of degenerative and chronic issues which are not so rewarding to diagnose and treat. So that was the case a few decades back, but the things have remarkably changed over the last few decades, and it's very rewarding to diagnose now many diseases because the treatment is quite good and the results are good, and the disability of the patients can be reduced significantly, sometimes to normal as well, depending on the presentation time from the onset of the disease. Such was the picture in say like 4 to 5 decades back, and it's not very old. Most of us were even born in these times, already there in the world, 1970s and 80s. So there were pneumoencephalograms for diagnosing hydrocephalus, X-rays, I mean not even CT scans, right? If the patient had stroke, मजाक ऐसे होता था कि अगर पेशेंट बच जाए तो इस्केमिक स्ट्रोक है और नहीं बचे तो हेमरेजिक स्ट्रोक है. That used to be the level of our because that was the only thing possible, right? So lumbar puncture करके उसमें blood आए तो we could call it hemorrhage. So that was the level of care which was available at that time. Parkinson disease तो मतलब only dopamine, and epilepsy तो only phenytoin, and genetic disorders were not even diagnosed. They were very expensive evaluation. Even 20 साल पहले तक 40-50 हज़ार के जीन पैनल्स होते थे. So they were very unaffordable at that point of time, and no cure. So hence these were very unrewarding things. And then I would say ghost disease. Ghost disease मतलब कि जो diseases थे पर उसकी diagnosis का आता पता कुछ अभी नहीं था. Like autoimmune encephalitis, multiple sclerosis, neuromyelitis optica. They were not even there in picture. They were already there, but not even diagnosed because there were no tools to diagnose that. So what has changed now? So why are these untreatable diseases now getting treatable? So neurology from being non-treatable chronic disabling conditions has become now much more rewarding and treatable because the imaging techniques have improved. There are molecular diagnostic tests which are getting cheaper and cheaper by the day. In few thousand rupees now these tests are being done, which are not very expensive. And there are medicines which act on these molecular deficiencies, like IVIG has come in recent years. Rituximab is one of the very remarkable drugs, like steroids. It's very impactful, high impact drug. And genetic conditions, जो diagnostic था genetics पहले, now genetics is in now therapeutics as well. कि जो gene deficiency है, now those genes are being replaced as well, like muscular dystrophy. So if diagnosed on time, spinal muscular atrophy. So these are genetic conditions where gene replacement therapy has also come up now. Although it is expensive still, but it's getting done. More and more diseases are being treated that way, and it will get cheaper as time passes in next 10 or 20 years. So I'll be focusing mainly on what is the future ahead. हम conventionally सोचते हैं कि दवाई से ही कोई बीमारी ठीक होती है. That's how we study, right? The tool of a physician is pharmacotherapy, medicines. So now the time has come that even technology has been progressing so fast. The speed of development of technology has been faster than the medical science actually. इसीलिए now even the so what we call is brain technology interface, where brain literally physically connects to technology and produces results and bypasses the pharmacotherapy. So that time has already come. It's not a future. It already is happening, not just in US or Europe. I mean, it's even coming now to India, and we would be surprised that this is not a science fiction. This is the reality which is already happening. It has started, and it's quite in affordable range as well for many middle class, upper middle class patients as well, right? So what is brain technology interface? एक होता है brain computer interface, जो directly computer operate कर सकते हैं from the brain. In very simple terms, right? Of course, it's more complicated than this, but I'm just trying to make it more simple. And second is the brain device interface. Small electrode devices are put in the brain at specific locations, जहाँ से जिसको stimulate करके जो brain का area deficient है, which is dysfunctional, hypofunctional, it can be stimulated. जो role medicines करती हैं, neurotransmitters secrete करके, same चीज these electrodes do and stimulate that part of the brain and the function of the neural circuit starts. So that's the wonder which has happened in last one decade and still evolving very, very quickly. So we call it neuromodulation. The whole field is called neuromodulation, right? And it is treatment beyond just medicines. So we have to think our way of analyzing things. पढ़ाई में हम सिर्फ मेडिसिन पे ध्यान देते हैं क्योंकि फिजिशियन का टूल इज मेडिसिन, ओनली मेडिसिन, राइट? This is the new tool which is there and which is the future. जब medicines काम नहीं करती, मतलब refractory diseases, this is the thing which works beyond medicines. जब medicines काम करना बंद करती हैं, neuromodulation comes into picture. And in neuromodulation, the main thing is DBS. We call it deep brain stimulation, right? So deep because deep inside the brain, in thalamus and basal ganglia, the electrodes are implanted. And brain stimulation, it's literally electric stimulation in microvolts which stimulates that part of the brain and the function starts again. So in Parkinson disease, जब bedbound हो जाता है patient after 5-10 years of illness, when medicines don't work, so DBS literally it's like a magic, and the patient gets up and can be able to walk normally and lead a normal life for next 10-15 years with this electrodes. Same goes for essential tremors, where medicines don't work, disabling tremors, मानो पानी नहीं पी पा रहा, हाथ हिल रहा है उतना, medicines are not working. This is the thing which works. So thalamus में the implants of these electrodes, they work like magic. They are put inside the operation theatre. Patient comes out, operation from the operation theatre, walking with steady hand. That's the magic of the these DBS surgeries. And we would be surprised that US FDA, which is the main governing body for all medicines and technologies, it has already approved in so many indications the DBS that we don't even think of that. Let aside practicing it, we don't even think of that. हम सोचते हैं मेडिसिन काम नहीं कर रही, you're bad luck, go home, सेवा करवाओ, we can't help, sorry for that. But that's not the case now, right? So it works in, as I told, Parkinson's, essential tremors, obsessive compulsive disorder, refractory epilepsies, right? severe depression, diabetic neuropathy. When diabetic neuropathy is disabling and not being treated by medicines, patient को रात को नींद भी ना आए, उतना तक जब pain होता है. So this is the thing which works when the spinal cord is stimulated and the spinal thalamic tract, which carry the pain sensations, they are modulated such that the pain is not carried to the brain and it is stopped right to the level of spinal cord without cutting the spinal cord. That's the whole beauty of this treatment. And these are already approved. What I mentioned is already approved. And in line are so many other indications which are continuously being experimented, and over 10 years, I am sure that in our own lifetime, right, we would be still alive to see all these things that is being approved in many, many diseases in neurology and even things beyond neurology. So another interesting term is functional neurosurgery. हम सोचते हैं functional neurosurgery होता है anatomy and physician के हाथ में होता है physiology. So anatomical lesions हैं like lump है, tumor है, hemorrhage है, hydrocephalus है. That is treated by surgery, right? That's what we know. MRI normal हो, so can a surgeon perform a surgery in the brain? No, right? Anatomically normal brain, surgeon के पास क्या है ऑपरेट करने के लिए? This is not an anatomical surgery. This is a functional surgery. We are treating the software of the brain, not the hardware of the brain, when we say about functional neurosurgery. So that time has come where the neural circuits are modulated by the surgery and corrected. So DBS is one of the functional neurosurgery. And like DBS, there are many other functional neurosurgeries which are done on apparently normal brain, and the patient can get better in all the conditions which I already mentioned. So the next thing, the whole area which has come new in last 20 years is neuroimmunological disorders, which has come a big way. Multiple sclerosis, neuromyelitis optica, autoimmune encephalitis, myasthenia, inflammatory demyelinating polyneuropathies. They are all disabling conditions. खास बात सबकी ये है कि इनमें जो रूटीन टेस्ट कराते हैं वो सब नेगेटिव आते हैं. Imaging is normal. Only specific tests would diagnose all these conditions, right? So मानो कि NMO antibody नहीं कराया तो neuromyelitis optica का diagnosis मुमकिन नहीं है. So these are very specific diseases, specific tests to be done. And the great part is कि वो late stage में भी आते हैं तो भी after treatment these can be reversed to like almost normal or at least functionally independent condition. So that's the wonderful thing. In last 15-20 years, all these things have come up even after we passed out, right? And in stroke, आप सबको मालूम होगा ही कि now जैसे myocardial infarction में जैसे heart attack है वही same चीज़ अब हो रही है brain attack में कि stroke में golden hours का importance उतना ही है. 4.5 घंटे for intravenous thrombolysis, 6 घंटे for intra-arterial mechanical thrombectomy. जो पामी होती है हार्ट में, same चीज़ thrombectomy brain में होती है. There is no difference in that. Same principle, same treatment. And कुछ cases में even up to 12 to 24 hours thrombectomy can be possible. And one interesting thing is that in SGVP in our hospital, we have made a very strong stroke team. We have trained them so that the patient जैसे ही आता है, door to needle time can be as minimum as possible, up to 20 minutes, 15 minutes. We are trying hard all the time कि जैसे ही patient touches the door, should be given the treatment as soon as possible if he is eligible for the stroke treatment to reduce the disability for the long term. So ये सब के बाद, what is the way forward now? What are we doing at SGVP to change the future of the neurosciences, right? So what we have got is the brain lab, which is the best state-of-the-art lab for the functional neurosurgery, which I already mentioned, DBS and all. That has been there with us now, and in 2023, I would be happy to tell you that in next 12 months, we will be coming up with the functional neurosurgery department and neuromodulation to upgrade our skills and go beyond just medicines and beyond the refractory patients, which cannot be treated by anything else, would be treated by the brain lab. And to sum up the neurology and neurosurgery, the neurosciences department of SGVP, I would say we have a brain lab, which would have DBS and functional surgeries. We would have epilepsy.
Sir, 2 minutes left.
Sure. We would have epilepsy surgeries, which are refractory to epilepsy medicines. Even the surgeries for epilepsy, like DBS, Vagal nerve stimulation is another new treatment which has come up for epilepsy surgeries in patients in whom medicine don't act. We have the stroke team as I mentioned, we have the cath lab, so intravenous, intraarterial, both treatment can be easily done and we do it already. And T for technological transformation. We make sure that जो conventional medicine से practice करेंगे ही साथ में, but technology से updated रहेंगे. Whatever comes next, we should be the one who would be learning and practicing the same thing. And hence BEST best. Right? So this is our hospital, our beautiful campus.
Thank you, sir. Very informative. And neuroscience is amazing.
Question to ask us. One, the role of DBS in Parkinson's when the patient is not adequate or imbalance. And second, the thermal ablation of global pallidum.
Correct. Sure. I would be happy to answer this. जब बैलेंस ठीक नहीं होता, आई थिंक आपका सवाल ये है कि बैलेंस ठीक ना हो तो क्या करनी चाहिए कि नहीं करनी चाहिए, राइट? सो देन देयर आर टू सिनेरियो सर. एक सिनेरियो है कि वो पार्किंसन प्लस सिंड्रोम हो, मतलब कि कन्वेंशनल पार्किंसनिज्म ना होके पार्किंसन प्लस सिंड्रोम है जिसमें बैलेंस की डेफिशिएंसी शुरुआत से होती है. इन दोस केसेस DBS is not the patient is not eligible for the DBS. In the patient who have Parkinson disease, conventional Parkinson disease, जिसमें eligibility होती है, उसमें imbalance आता है बहुत late stage पे. So बीच में बहुत सारे साल होते हैं जिसमें DBS मुमकिन होता है. So it should be done much before the balance deficiency when it happens. So in Parkinson plus syndrome, not eligible. In routine Parkinson patients, it should be done before the imbalance comes. Yes, sir. And the second question, the ablation treatment of globus pallidus, it is useful for only one hand and one leg. So दोनों तरफ करने में there are side effects. So better we do it on one side only, or left or right. Say patient right-handed person है, तो I would do it on the left side. To the right हाथ में उसको फायदा मिलेगा. He can be independent for the work. It cannot be done on both the sides. Benefit of ablation is that it is quite cheap compared to the DBS surgeries. अब मानो कि 1/6 कॉस्ट में हो जाता है compared to the DBS, 1/6 या 1/7 कॉस्ट में हो जाता है. So benefit is that, but the side effect is that it's not bilateral, it's only unilateral. ऐसा है. So patient can choose, so it can be done even in not affording patients. It's possible in some 2 lakhs to maximum 2.5 lakhs, and it's a permanent cure. I mean, so it's a very worth it surgery.
Any vaccine in the pipeline, sir? Recently,
no vaccine, no, not effective. I wish it was, but
I have read the article, sir. I will just meet you later.
Okay, sir.
Thank you, sir.
Dystonia, cervical dystonia, especially.
जी sir.
DBS in dystonia, cervical dystonia.
Sir, cervical dystonia, writing tremors, writing dystonia, musician cramps. It is effective in many conditions. Movement disorders मैंने पूरा नहीं बताया क्योंकि I thought कि not to bombard with lot of information, but it's effective in so many things. Chorea, many things.
To what extent quality of life?
Right facial involuntary movement.
जी sir.
Right facial involuntary movement.
No sir, facial movement में नहीं करना.
Okay, thank you sir so much. I request Dr. Kapadia to felicitate Dr. Kapadia. Thank you so much, sir.
Next, Dr. Ravijay, RIRS subject. Retrograde intrarenal surgery.
Good evening, respected chairpersons, respected faculties and delegates, and thank you AFPA for giving me this opportunity, and I continue the tradition of presenting the latest in the medical technology from SVP Holistic Hospital. We started with robotics and knee replacement and cardiology and neurology, and now it's the time for urology. So RIRS, the game changer in kidney stone surgery. RIRS, if we have a stone, this is a stone, but for a urologist, he is like Bahubali, he has to take care of all the stones. And there is nothing permanent except change. So if we have progressed from pager to the landline, to the mobile phone, yes, definitely we should evolve in terms of stone surgery as also. So it started with lithotripsy, all of you must be familiar with it. PCNL, very standard procedure, but the new boy, the baby, is RIRS, retrograde intrarenal surgery. So what is RIRS, or it's also known as flexible ureteroscopy? It is the latest and most invasive, minimally invasive laser stone surgery. No puncture in the kidney. Successful stone clearance. Least risk of bleeding, which is especially there with PCNL. Least risk of renal injury, possible with both ESWL and PCNL. And the patient is discharged next day. So I begin with a case for RIRS for a 16 mm lower calaceal stone. So 16 mm lower calaceal stone, he was a 62-year male patient. Patient had a history of open surgery and multiple times stone surgery is done. The lower calaceal stone is usually a difficult case, and you can see here it's a 16 mm with a very narrow infundibulum, which is again a difficult case for RIRS or flexible scopy. And the patient was on antiplatelets, so we stopped the antiplatelets for 5 days. We took the consent that we might have to go for PCNL if not possible. This is the ureteric access sheet which is being advanced, and these are the different, nowadays the flexible scopes are available, the disposable scopes are available, excellent vision. This is a digital scope, and you can see I am now into the kidney, and you can appreciate that I can see all the calyces of the kidney, upper, middle, lower, and lower calyx stones, mind you friends, mind you respected delegates, it's always a difficult case. So here in this case, I can see the stone, and I'm trying now to dust the stone with the help of laser. But lower calyx stone is always a difficult stone. Sometimes I cannot fragment the stone or dust the stone. So in this case, the challenge is very hard stone, difficult angle of the scope in the lower calyx, difficult lasing. Hence, I changed my strategy. I plan to fragment the stone first, grab the fragments and put them into the appropriate upper or middle calyx. Usually I prefer dusting the stone because the stone is converted into so fine dust that I really don't bother to remove the fragments or the dust. Here I am fragmenting the stone, picking up all the fragments and putting them into the appropriate upper calyx so that there I can successfully dust the stone. As you can see, I am basketing all the fragments from the lower to the upper calyx. Now I will start laser dusting of the stone. We have got the thulium fiber laser. It is the most advanced laser in the world market today. The thulium fiber laser, excellent dusting is obtained with the help of the thulium fiber laser. And the beauty here is that there is no bleeding, absolutely no bleeding, because even though the patient was on antiplatelets, I really didn't bother. There is no risk of bleeding post-operatively as well. And most of our patients, even these days, we treat up to 2, 2.5, even 3 centimeter stones, and we get fantastic results with the help of the thulium fiber laser. Now you can see the stone is being converted into very, very fine dust. At the end of the procedure, normally a fragment, the center of the fragment is very, very hard. So we remove the fragment. Now I'm popcorning the stone. I will remove the fragment and I will show you how small, how minute that's. The laser fiber is 200 microns fiber, and we create the dust less than that. So it is practically less than 0.2 millimeter size. You can see the fragment. I'm removing the fragment. Then I will go into each and every calyx of the kidney, confirm there is no residual stone left anywhere in the kidney, be it the lower, the upper or the middle calyx. See, I am inspecting all the calyces of the kidney. This is the contrast or the dye which we use to confirm that there is no residual radio opacity. And Now you can see the X-ray picture. I am going into each and every calyx, the lower, the middle, the upper, to confirm I have not created any injury, I have not left any result. These you can appreciate. The smallest, the biggest fragment was this size. So procedure was done within 1 hour 15 minutes. Next day discharge, no sepsis recorded, no hematuria, no complications. This case particularly was a difficult case, hence I have demonstrated for this conference. Second is another case. If time permits, I will go to this case. So I would like to discuss few challenging cases in RIRS which we have been able to do. This patient is a solitary kidney patient, CKD patient. You can appreciate the lung. He has just a solitary lung and a duplex moiety. You can understand if I do a PCNL and the patient lands up in a pleural complication, it can be a disaster for the patient. So I am able to do completely in a single sitting for this patient. Second case is a calycial diverticulum case, an upper calyx diverticulum. Very, very difficult case. An upper calyx diverticulum cannot be treated by PCNL. RIRS is the answer to it. A third case again in a malnutrited kidney. RIRS is a boon for patients with malnutrited kidney, solitary kidney, CKD patients. And here again there is a diverticulum, so I could do it with the flexible ureteroscopy or RIRS. Fourth case of a lower calycial diverticulum. I have done several cases of post-PCNL residual stones where surgeons keep giving lithotripsy, stone doesn't get cleared and we just bother what is the problem. Another case of an ectopic kidney. Here the patient is having a pelvic ectopic kidney with a duplex moiety. And here also, and another case of a transplant patient, post-transplant, the patient has developed stones in the ureter, and again here, flexible ureteroscopy is the answer. So, few of you may be thinking, why RIRS? So, I will like to answer, why not RIRS? If you don't have any pleural complications like PCNL, if you don't have bowel complications, no bleeding, and least post-operative pain, why not RIRS? And why RIRS? Because yes, it is ideal for high-risk patients, cardiac patients, recurrent stone formation. Who would like to get a puncture in the kidney? Nobody would like to get a puncture in the kidney. Ideal for the complex cases, solitary kidney patients, pelvic ectopic kidney, etc. patients. RIRS is the answer. So, has anything changed in RIRS? RIRS is also a technology which is evolving, and we all know from ISRO, we are in Ahmedabad Management Association, the place of Vikram Sarabhai. So if ISRO has progressed from this picture to Mangalyaan, yes, RIRS has also changed. It has got the thulium fiber laser. Previously we used to have the holmium YAG laser, now it's a TFL laser, which is the most advanced, and we boast of TFL laser at SVP Holistic Hospital. And the disposable digital scopes has really changed our vision, our understanding of the kidney. You could see beautifully the whole kidney. So disposable scopes. So TFL laser, this is just one of the cases, a 3 centimeter stone, an ideal case for PCNL. I had done this case in a live operative workshop with a very hydronephrotic kidney, and you can see at the end a complete clearance in this procedure. So RIRS is now gradually replacing PCNL. PCNL is definitely the gold standard for very big stones, stack-on stones, but these days up to 2.5, 3 centimeter stones also, RIRS is giving the answer. So in a nutshell, RIRS is ideal for kidney and upper ureteric stones, minimal invasive, least risk of bleeding, least risk of organ injury. It's ideal for recurrent stones. How many times would you like to get a puncture in the kidney? It is ideal for residual stones, stack-on stones, post-PCNL, residual stones. It's ideal. Ideal for all the complex medical cases, patients on comorbidities like antiplatelets, patients with comorbidities like CKD, patients with complex surgical cases, and these days thulium fiber laser is the game changer. So if I ask you, who is the game changer? I will say we just had the FIFA World Cup football and everybody of them is great. He is also great. But if it really comes to be the game changer, we know how Argentina lost initially and how it took up the World Cup. Yes, it is Messi, and similarly RIRS is changing the game these days of kidney stone surgeries, and I would like to help you with if any of our relatives or any of our patients have got problems with the kidney stones or any urological problems, we would definitely be happy to help you at SVP Holistic Hospital. Thank you.
Thank you, sir. I will request Dr. Parth Desai to give memento to Dr. Ravijay.
Every function is not important.
No, sir. Because it doesn't involve any function.
Blood investigation is important after.
Blood investigation, routine preoperative profile, CT, IVP, so routine investigation before any kidney stone surgery.
Excuse me, how much is the cost for a
We can have a cup of coffee. We will have a cup of coffee together.
At a minimum, how much millimeter stone you will like to explain?
Sir, minimum or maximum?
Maximum.
Stone burden up to 3 centimeters. Because of the thulium fiber laser, we have increased our threshold up to 3 centimeters.
Okay, now we are Hello. Dr. Mukesh Bhatt and Dr. Sanjay Deore requested to come on this dais as a chairperson. Dr. Mukesh Bhatt. Dr. Sanjay Deore. Yes. Dhirendra will be momented to Dr. Gadi Sahib.
I invite Dr. Ravindra Shukla, please.
First of all, I would like to invite Dr. Rajni Shah. Yes, already. Okay.
Thank the organizers for allowing me to choose a topic of my own interest, and that is primary hypothyroidism. Now, one thing which I've learned over years and which is kind of thing is over the years, whenever we are getting thyroid, or primary hypothyroidism, thyroid function tests are of least importance, because what should be the ideal TSH, T3 and T4 depends on each person to person, and even in same person it depends on season to season. That's what. So every person at unique point has its own unique TFT, thyroid profile. But yes, there are three types of primary, secondary and tertiary hypothyroidism. Primary hypothyroidism is what mostly would be dead, and 95% of all patients are having primary hypothyroidism. This is a complicated diagram, but it serves to tell that there is three kinds of hormones, which thyroid hormones. One is TSH, T3 and T4. Unfortunately, most of the time only TSH is done, the T3, T4 is not done. Also, unfortunately, T4 is the one which is given as a tablet. We do not have, for example, tablet to give TSH. We do not have tablet to give T3. So this is what is, in a nutshell, a problem in seeing a thyroid patient. Now, this is an algorithm well known. I would like to concentrate on the left side of this algorithm. If TSH is high, just see the free T4. If it is low, call it hypothyroidism. If it is normal, again it can be hypothyroidism. Name given is subclinical, but again, even if P84 is normal, just on TSH, patient could have a problem. Now, what are the symptoms? We'll take in next slides, but this is something. The fact that with normal TSH, normal P84 also patient could have hypothyroidism is what which has created confusion among the clinician in general. Because a lot of these patients will not benefit. Whenever we give levothyroxine tablet, they will not benefit. Some of them will benefit. Now these are congenital hypothyroidism and why it is caused. So what are the causes? The only causes which we see, 95% again as I told is something called Hashimoto thyroiditis. It's a Japanese name and very few of us we are aware why Hashimoto, what is there. It's an autoimmune. I think like in the previous lectures also we were discussing about immunological diseases which leads to neurological problems. So this is actually an autoimmune disease. It's not an endocrine disease. So giving a hormone for an autoimmune disease is not going to work. You have to treat the antibodies, autoimmunity. Various drugs they can also lead to, including the iodine, including the contrast given for CT scans. Okay, a lot of time I have seen patients after COVID, during COVID, gone for CT and then they have developed. So viral infection with the contrast exposure is huge risk factor for getting hypothyroidism, and this is what we call Hashimoto thyroiditis. As I told viral, after COVID, the rise, and we do not have data from India, but at least from one country we have data, that is Italy, that after COVID the chances of getting new onset hypothyroidism will increase. Now this is very important. A lot of the patients, a challenging patient is the one who is having normal thyroid profile and is having these symptoms: muscle weakness, fatigue, this and that. And what the error is made is that we only look at the thyroid function. We don't look at the patient, and the first thing of clinical medicine is to look at the patient, ask the patient if the thyroid function are normal, patient is still having fatigue. That is a challenging patient which I would like to see. And I always tell and see, and there will always be a reason for that, and sometimes some of the modifications which we will make, and that we'll see later on, what we can do for these patients. There is very less, still new drugs are coming for these patients, not much we can do. The puffiness of face, voice hoarseness, brittle health, especially those who are losing hairs, the middle-aged, especially females and the males as well. So it's partly related to something called atopic dermatitis, part of the spectrum of that. But we have seen that whenever we supplement levothyroxine, there is some benefit in that. So along with the zinc and all that, we try to treat such patients. Then there is some pain in muscles. That's a very defined. May not be post-viral. Always, doctors label these patients as post-viral. Okay, post-viral leads to this post-viral syndrome, but it also leads to thyroid dysfunction. Okay? And it might take 6 months to 1 year for the axis to recover. So this is a test T3, TSH and T4. What is the normal range? A lot of time these normal range are printed in the reports. The patient sees and the patient comes with the report and the doctor also agrees with the report. But it is not. Never look at this. Always look what was the patient's previous report and how it has changed. If the patient is not having any previous reports and if it seems to be normal, just wait for 3 more months again for comparison. The approach to management is to give levothyroxine tablet, which is very widely available and often given. But it's important that do not give full doses of levothyroxine. Again, we do not know. Most of the patients will not be requiring more than 100 mcg. And those who is requiring more than 100, even after giving 100, the symptoms will not resolve. I can put up a challenge, ask any of your patients who is getting more than 100 mcg of levothyroxine, whether he is having any symptoms or not. All of them will be having symptoms, some of the symptoms. This is because this is a very unusual, unnatural way we treat hypothyroidism. Because T3 has to be given, you have to look for the other axis. And such patients will land up us in our OPD. And these are challenging patients. Increasing dose doesn't help in these patients. So what are the 4 steps? 1 is to confirm the diagnosis, 3 is to ask about the compliance. Till step 4, I think it can be done. After 5, 6, 7 and 8 steps, they are mostly done in the specialist center. So to check for the compliance and check for the bottles and tablets, these are very important parts. It resolves 90% of the problem these patients are having. whatever their pain and the sleep and insomnia, this can be resolved by doing the first 4 things of this checklist. There is something called thyroxine malabsorption, seen whenever patient has gone outside for travel, was in travel, is having gastritis, TSH is 8, but the patient is having a lot of symptoms. The reason is not 8 TSH. Okay, the thyroid dose is decreased, but patient ko adat hai jaise 50, 60, 50 to 100 ki. If you, because of gastritis, the dose absorption has decreased drastically. So patient is effectively receiving only 25. That is getting to stand. So these are the tests we can do for the malabsorption of the GIT. And then there is something called age also. A female who comes 20 years se main ek hi dose mein le rahi hu, it is impossible. With age, the dose should reduce. Somebody who was taking 100 mcg 20 years back should be taking 88 to 75 mcg. Because with age, the turnover decreases. And if you are continuing the same dose, it seems something is wrong. Again, it should come to history, whether you are taking properly, whether you change the brands, whether you are taking a lot of teas, a lot of reasons we can. Pregnancy is a different ball game. I will not discuss much, but in pregnancy, always remember, treat over. Hyperthyroidism will not be disadvantageous to the fetus, but a slight hypothyroidism has been shown to decrease the IQ points in the children by 3 to 5 IQ, and that's huge. 3 IQ point means losing a seat in next or losing your government seat. So I mean, like I'm telling, hyperthyroidism as compared to hypothyroidism is more tolerated in pregnancy. These are the doses, but only for the children. For adults, we are free from 25 mcg to 200. We have a huge range. For children, so we are very clear about whether to take or not. Now, what time it should be taken? I think if I ask all of us, will say that in the morning only we have to take. Yes, we have to take in the morning, but we have to take empty stomach. That's very important. Those who are not exercising much, they have to take at least a gap of 2 hours between, taking rather than just recommended, which is that of 1 hour only. So it is 2 hours. It depends on patient to patient. If somebody is very busy in the morning, then the time of the day, like in the evening also, it can be given. But evening, the patient should not be taking statin. It's very important. If the patient is on statin, aspirin at the night, do not give levothyroxine at night. If patient is not taking any tablets at night, then after dinner time it can be given. Dinner time, bedtime, not dinner time. Non-compliance is something which differs from patient to patient. Often the patient forget. If they have not missed the tablet for 5 days, they will say I have missed only for 2 days. It's very difficult because nobody, except for OC pills, that's the only tablets I've seen. Women are very, they are able to count well, miss the OC pills. Except for OC pills, all the diabetic medication, this and that, the recall value is very poor for all the patients. They are not able to remember when they are lost, and that's why, some of the tablets they come with the pack, 1 day, 2 day, 3. Again, those who are reading high dose, by the high dose I mean more than 200 or more than 175. This patient surely needs a referral. No human being in the world needs 175 mcg of levothyroxine, except if you are living in -10 degree temperature somewhere and you are very young and you are doing outdoor. Nobody needs that dose. So if somebody is needing that high dose, there is a reason why it's needed. Most of the time it's because the brand is not taking care of medicine properly, or the brand is very bad or something like that, or patient is not taking medicine properly, patient is having some gastritis. These are the reasons for high doses. And also there is something called other drugs, interference also, which can lead to these things. So this is a test we should do our clinic, but I think this is not much of importance in that. Follow-up, how long should the patient be followed up? So stable patients can be followed up. In textbook it is written 2 to 3 years, but as an expert I say, because I have hypothyroid OPD, I say that you have to follow at least 6 months. Patients will have complaints. So call the patient, ask them, they will have complaint. So try to find out. A lot of these patients will develop other autoimmune diseases, especially arthritis. We have published a paper on that also in the PLOS later on, that some of the patients will have joint pains and these, and when we treat them with hydroxychloroquine, there is very good response. Otherwise, for stable dose, the patient can be followed up with 6 months. Now, brand is very important. Continue on the same brand again. Some of the brands, they are high. One brand 25 mcg is equal to 75 mcg of other brand. This is what it is there. Some brand 200 mcg is equal to 50 mcg of some brand. So brand equivalence is not there in case of levothyroxine. You have to remember this. All the thyroid patient, hypothyroid patient should undergo anti-TPO antibody, and nobody will criticize you for this test. Anti-TPO antibody, 800-900 rupees test. Instead of getting 5 times thyroid profile test, at least 1 TPO antibody is necessary. And it is important because we can gauge how much would be the dose requirement based on the TPO sometimes. Now subclinical hypothyroidism when TSH is more than 4.5, and again then we are giving, and so that this is pattern I will not take because there is not much time. Yeah. What are the pitfalls? If somebody is taking multivitamin tablets, they contain biotin. Now biotin interferes with the thyroid function test, and that can lead to wrong reports. So again, history, as I told, is very important to ask that history. And biotin is present in all of the multivitamin. It is also a component of the testing kit. So that leads to the interference. And now the diet. It is very important that earlier days when India was iodine deficient, at that time botrytis could have played a role in causing hypothyroidism. At present, most of the botrytis are inactivated by cooking. So that's not a reason. The newer perspective is that we have T3 available, and our own publication shows that hypothyroidism patients have a link to rheumatoid arthritis. I mean, it's not full-blown rheumatoid, only joint pains, and we can treat by giving DHEAS. It's available in India as a supplements, and we are giving to some of the patients. We'll be publishing it shortly, our own report. So DHEAS helps in some of the patients of hypothyroidism. This ends my presentation.
Thank you very much, Dr. Shukla.
Sir, what is the difference between TSH 3T3T4 and TSH T3T4?
Yes. So all of the hormones of our body, including insulin, they are bound to protein. So this is albumin or whatever protein, they are bound to that. So if you measure total T4, it is a T4 which is bound to thyroid binding globulin to the pre-albumin. When you see free T4, it is the T4 which is available in free form. But there is again a crux. Suppose when the blood is taken out, it is in free form, so the test has to be carried out for free T4 within 5-6 hours only. Because blood dynamics will change. It will clot and that will change. So free T4 is very helpful. Most of the time we tend to do free T4, T3 in our institute. But otherwise, if the time duration between taking of the sample is more, I suggest total T4. Free T4 is better.
Okay, thank you sir for the very nice presentation. Now I request Dr. Mukesh bhai to give memento.
For second lecture, I invite Dr. Bhupesh Patel. This is the last lecture of this session.
After completion of this lecture, we will start our inaugural function within a short of time. So please remain here.
Good evening everyone. So we are running a little late. I will not use too many time. So the today topic is full endoscopic spine surgery. Is it really a beginning of new era? Because we are since long we are adapted to laparoscopic surgery. Now when we were in medical college, people used to say laparoscopic surgery it's new at that time. So surgeons when they adapt it, they are taking almost long time to just finish surgery. At that time when the senior surgeon they will say, okay, we can finish the open surgery in half an hour, 1 hour. Why to do a laparoscopy? But nowadays trend is totally reversed. So now if you are doing open surgery, if surgeon is giving advice to open surgery, people don't adopt. Most of the people want now laparoscopic surgery. So similarly, we are in spine now. Way back around 5, 6 years, 7 years back, when we are saying endoscopic spine surgery, people used to laugh. But now it's a new way to treat the patient. So what are the advantages? Basically, it's the least invasive. So many times when you opt for the spine surgery, doctor or spine surgeon cut your back, cut the all muscle and bone. But here, without cutting anything, we just put the nick on the skin, and we can treat almost all the kind of pathology with endoscopic surgery. It is a day-care procedure like tooth extraction. So we have around 23 discs in the spine. So if your L4-5 disc is causing problem, you can treat that disc in a daycare procedure. And again, if some disc, again after 5 years, some other disc giving a problem, you can deal it. So it is like we are doing under local anesthesia or sensory epidural analgesia. So again, patient can go same day home. Again, no muscle cut, so fibrosis and back pain after surgeries are at least very minimal. Again, we don't do any bone resection here, or if at all we need minor resection. So after surgery, the chances of instabilities are there. So putting a screw is not an answer for every screen. Yes, if there is instability, we need to put a screw. But if you can manage without putting screw, it's the best. Again, you have magnification, so minimum handling of neural structure. So chances of neural injuries are very rare. Bleeding also very less because we are not cutting anything. So epidural fibrosis, again post-surgery failed back surgery syndrome, very common with spine. Now we can almost avoid that surgery syndrome. Again, magnification, you can allow your hair is like 1 millimeter structure. It can see under endoscope almost 10 millimeter. So complete chances of complete decompression and injury to neural structure are very rare. And most important, surgery is being done under sensory epidural analgesia. So here we are not giving any full anesthesia. So in old age, patient with comorbid syndrome, we can easily get away with the surgery. And of course, spine surgeries are most commonly done in old age patient after 50-60 years, most commonly degenerative spine. And again, one more advantage, when there is sensory effect, so patient can move limb during surgery. So when you are touched during surgery, when you touch the neural structure, patient can say, can give a feedback. You are touching my structure, you are touching my nerve, please be careful. So even surgeons are getting feedback. So it is awake neuromonitoring. So why I call it the game changer? Because earlier, I'm not saying endoscopy is not happening, but earlier, since 1995, endoscopic surgeries are there, but it are not gaining that much momentum. Why? Because only one approach is there, and that approach has its own limitation, because we can only do for herniation. We cannot treat the lumbar canal stenosis or instability or multi-level degenerative spine. But now, with the advent of interlaminar approach, we can, I think, virtually we can treat every condition with endoscopy. Yeah, 2 or 3 level, multiple level, we can do in sitting, 1 or 2 sitting. But without cutting any bone, without cutting any muscle, we can do this surgery. Again, with lumbar canal stenosis in old age population with degenerative scoliosis. At that time, if you go to surgeon, they say put the screw from D11 to S1, 20-30 screw you need to put. But actually the problem causing level are also 1 or 2 level. But because you need to correct your spine, that you need to put the screw from above downward. Again, if you can selectively decompress that nerve root which is pinching your back and giving that to your leg symptom and back symptom, this is a blessing for that patient. So selection of best approach, again these are the different approach. I say transfemoral approach and its modification is best suited for L4-5 disc and above till D12-L1. Even thoracic D6 we can do endoscopic discectomy. Interlaminar approach, if L5-S1 I choose interlaminar because wide interlaminar window you don't need to cut, actually only 5 mm of flavum splitting you can remove the disc. Even post-op MRI people don't say you have surgery, they say pre-operatively you have disc, now you don't have disc. But I can't see any evidence of surgery in your back. Again, stenoscopic surgery, interlaminar stenoscopy for biportal endoscopy, UBE, unilateral biportal endoscopy. Lumbar canal stenosis, we can easily treat lateral discs, central canal and calcified disc. Transforaminal, foraminal, extraforaminal stenosis and symptomatic instability. If your vertebrae is moving forth and back, you can fix with endoscope also. This is what is a transforaminal approach. So you have heard endoscopic discectomy, and transforaminal is one of the approach. Here what you do, 6 to 7 millimeter incision around 12 to 14 centimeter from the midline. You don't cut any structure in the midline, you go side of the back under epidural analgesia. We introduce needle, our guide wire, dilator, cannula. Under cannula we introduce our scope. So here we don't need to cut any muscle, any bone. We just perform decompression, discectomy, single stitch, or sometimes we may not need to do any stitch. Same day we can discharge after 4 hours. So these are one of the examples. You see 32-year-old male with low back pain and right leg pain. You can see huge L4-5 disc herniation. Here if you go to some open surgeon, they say you need to put 4 screws and cage and we'll decompress everything. But if there is no instability, you don't need to put anything. We can easily treat with endoscopic discectomy. So we go around 12 cm from midline. This is our approach and this is the video. This is a small illustration of how we do. So first we go inside the disc. It's an inside-out approach. We just debulk the intra-discal part. So we find out the annular tear where actually herniation goes from the disc into the epidural space. So this is a Holmium-Yark side-firing laser. When there is a hard calcified structure, we need to do with a laser. So this is again a radio frequency device. We call it energy device. We are just finding out where actually herniation is. So you can see the cotton fluffy like fragment. This is a herniated portion. So actual nuclear herniated part of nucleus pulposus goes into the epidural space. We just remove with our endoscopic grasper. So again this is a laser. So you can see post-op MRI, beautifully decompressed thecal sac. In sagittal and axial also you can see here is a pre-op fragment was here. We completely removed and this is a white structure is neural tube. And our incision, if patient comes 15-20 days post-op, even you cannot recognize whether you have done surgery or not. It's a muscular scratching kind of incision. This is a post-operative patient. They say they are lifting almost 20 kg of weight after 3 months of surgery and he is doing all his routine day-to-day farming activity. So this is a newer approach is uniportal interlaminar approach. So this approach we are doing from midline. What we are actually doing open surgery, we are doing from midline, but we just put a skin incision around 6 to 7 millimeter and we, without cutting any muscle and bone, we just put our first dilator and then over that cannula and scope. So we just need to split the 5 mm ligamentum flavum for discectomy alpha without cutting any bone. And if we want to do lumbar canal stenosis, we need to resect the bone minimally till we reach the flavum edge, and we remove the ligamentum flavum from lateral, central as well as foraminal edges, and we decompress the thecal sac. Again, this is an example of this surgery. 85-year-old male with severe bilateral leg pain, not able to stand since 15 days. He was bedridden. He has lost his urinary control because of severe lumbar canal stenosis. He had a bilateral lower limb numbness and pain, constipation. So he has a bowel bladder difficulty. You can see there is a huge epidural cyst at the L4-5 level. And it's compressing thecal sac and it's descending sacral nerve root also. So he had a urinary complaint also.
Sir, 2 minutes left.
Okay. Yeah. So we did on arrival. We found it patient had almost BP silent MI. We treated in ICU. Again we did local anesthesia. We did endoscopy. This is a post-op picture of same patient you can see. And patient is moving his limb during when he is lying in prone. So now its fusion is possible. Yes. It's a very novel approach. Here do we percutaneous stabilization, we do endoscopic decompression, we do transforaminal or interlaminar cage insertion. Again no muscle cut, just bone minimal resection where we need to into the disc and single day admission. So again you can see the male, 40-year-old male with severe right leg pain, walk with forward bending, not able to walk. You can see spondylolisthesis here. Again MRI, you can see there is a huge applied disc with spondylolisthesis. So we did a decompression here. This is end plate preparation for cage insertion, and this is a final video of how we exactly look endoscopically cage, putting a cage. So this is a post-op image. Even endoscopically we can fix the spine also. So patient on same day evening, patient can walk easily without having any problem. So in conclude, and when we go back to 2001, when open cholecystectomy considered as a gold standard for a surgeon. But when it was of laparoscopy at that time, when junior surgeon do laparoscopy, the people, senior surgeon used to laugh that I can finish in 30-40 minutes, why you want to do open laparoscopy? But now in 2023, laparoscopy, in Love and Belly they say laparoscopy is gold standard, laparoscopic cholecystectomy is gold standard for gallbladder surgery. Similarly, endoscopic spine surgery is now considered as a gold standard for endoscopic disc surgery. So we also welcome you our first international conference in Ahmedabad on spine endoscopy in Cork and Marriott. Thank you.
I invited Dr. Ratnibhai Shah to felicitate Dr. Bhupesh. Now I request Dr. Vishnubhai Patel to give memento to our chairperson, Dr. Bhupesh. Now I request Dr. Arvind Bhai to give memento to Ratnibhai Shah.
Now we are starting our inaugural function, but before that, there are some prizes declared by one pharma company stall, Franco India. I call the name and you collect the prize from near the gate or from Franco Indian stall. Dr. Nitin Shah Baroda, if he is not present, then he can, his some of friends can tell him. Lalwani NK Mumbai, Dr. Suresh D. Patil Nasik, Dr. K.N. Patel Rajkot, Dr. N. Devendra Bangalore, Dr. Kamlesh Shah Ahmedabad, Dr. Ashutosh Vyas Ahmedabad, Dr. Dhiren Sanandia Ahmedabad, Dr. Sanjay Kothavde Nasik, Dr. Sunil Jain Mumbai, Dr. Rashmin Prajapati Gandhinagar, Dr. Manoj Rawal Surendranagar, Dr. Bhupesh Surat.
Good evening, Ahmedabad. Good evening. Sir, अभी जाओ ना आगे. अभी जाओ, वैसे जाओ, please. Good evening, my seniors and friends. On behalf of AFPA and NATCON, I, Dr. Mehul Shelat, welcomes you all. Wish you all are enjoying our conference. Because of some unavoidable circumstances, our chief guest, Mr. Minister for Health, Family Welfare is not coming. He sent us a greeting message. Prakash. Thank you very much, sir. One more message from our Chief Minister, Mr. Bhupendra Bhai Patel. Thank you, Prakash. Now, let me invite our guest of honor, Dr. Anil Bhai Nayak, our guest of honor and our special invitee, Dr. Nitin Bhai Shah. I request our National President, Dr. Abhay Dikshit, National Secretary, Dr. Vinod Parikh, to escort our guest of honor. I invite President AFPA, Dr. Kamlesh Nayak, invite our Secretary AFPA, Dr. Pragnesh Vajrajani, COO KD Hospital, Dr. Parth Desai, COO SDVP Hospital, Dr. Hiren Kaswala, Director Epic Hospital, Dr. Anil Bhai Jain, immediate past President of AFPA, Dr. Raj Kishore Bajpai. Oh, sir. Would love to invite on back row our convener conference, myself, Dr. Mehul Shelat, RC Chairman, Dr. Sanjay Bhai Shah, Sanjay Bhai, our Treasurer AFPA, Dr. Dhiren Chandya, our Treasurer FFPAI and Chairman FSS, Dr. Janak Bhai Shah, Dr. Janak Bhai, our Chair Advisory Committee, Dr. Ashwin Bhai Shah, our Chair Scientific Committee, Dr. Dhiren Bhai Mehta, our Vice Chair Advisory Committee, Dr. Jashwant C. Darbar. Please out. Now I request Dr. Keur Bhai Shah for prayer. Dr. Keur Bhai.
इतनी शक्ति हमें दे न दाता, मन का विश्वास कमजोर होना। इतनी शक्ति हमें दे न दाता, मन का विश्वास कमजोर होना। हम चले एक रास्ते पे तुम्हीं से, भूल कर भी कोई भूल होना। एक इतनी शक्ति हमें देन दाता, मन का विश्वास कमजोर होना। दूर अज्ञान के हो अंधेरे, तू हमें ज्ञान की रोशनी दे। दूर अनजान के हो अंधेरे, तू हमें जीवन की रोशनी दे। हर बुराई से बढ़ते रहे हम, जितनी भी दे भली जिंदगी दे। बैर होना किसी का किसी से, भावना में मन में बदले होना। हम चले इस रास्ते पे तुमसे, भूल कर भी कोई भूल होना। इतनी शक्ति हमें देन दाता, मन का विश्वास कमजोर होना।
I must acknowledge the presence of Dr. Didu Shah, President of Ahmedabad Medical Association. Welcome, sir. Very fast, let me introduce or give name of our organizing committee. Very fast. Dr. Abhay Dixit, Dr. Ashwin Bhai, खाली सिर ऊपर थी हाथ ऊंचा कर जो. Dr. Abhay Dixit, Dr. Ashwin Bhai, Dr. Pragnesh, Dr. Kamlesh Nayak, Dr. Dhiren Sanandia, Dr. Amit Bhai, Dr. Arvind Panchal, Dr. Darbar, Dr. Dhiren Mehta, Dr. Kirit Bhai Gadvi, Dr. Hasmukh Bhai, Dr. Hitesh Jirawala, Dr. Imtiaz Vora, Dr. Keyur Shah, Dr. Mukesh Bhai, Dr. Piyush Gandhi, Dr. Pratik Shah, Dr. Ramesh Patel, Dr. Sangvi, Dr. Sanjay Shah, Dr. Suresh Bhai, Dr. Viral Khamar, Dr. Vishnu Bhai, Dr. Pritesh Shah, Dr. Vijay Maurya, Dr. Bokre, Dr. Harish, Dr. Nitin Shah, Dr. Rashmi, Dr. Sadashiv, Dr. Deepak Bhai, Dr. Ramlal and Dr. Preeti Shah. Thank you very much, sir. Now I request our dignitaries on dais for lamp lighting. Now I request our AFPA President Dr. Kamlesh Nayak for his welcome speech. Dr. Kamlesh Nayak.
Good afternoon. First of all, thank you, Mehul. Good afternoon, all of you. On behalf of, as a AFPA, as a president, myself, Dr. Kamlesh Nayak, feel pleasure to welcome all of you as a participant in AFPA NATCON 2023. I welcome today's guest of honor, Dr. Anil Nayak sir. He is the Honorary Secretary of General INA Headquarters. I welcome Dr. Nitin Shah sir. I also welcome our National President Dr. Abhay Dixit sir, National Secretary Vinod Parikh sir, Dr. Treasurer AFPA Dr. Janak Shah sir, and immediate past President of AFPA Dr. Raj Kishore Bajpai sir. I also welcome our Convener Conference Dr. Mehul Shelar and Co-Convener Dr. Dhiren Sandhya and our team also. I also welcome GMC Observer and President and Secretary of GS AMA Dr. Jitubhai Shah sir. And I also welcome here today's eminent speaker as a guest from SGVP, EPIC, KD Hospital and all other past president of NFPI and also past president of AFPA. I hope the conference will be great and successful. I hope you will enjoy the conference. We all are here because of our teamwork. Thanking you for joining us. Thank you very much.
Thank you, Dr. Kamlesh bhai. Now, our FFPI President, Dr. Abhay Dixit, about FFPI.
Good evening, all of you. All the dignitaries on the dais, of the dais, all my colleagues, the RC members, the corporate members, the delegates, spouse members, all the respected faculties. It is a proud and privilege for me to stand before you as a President of Federation of Family Physician Associations of India. I am here standing before you only because of you. It was a 2 years tenure. I enjoyed a lot with your wholehearted support. So, Federation of Family Physicians of India is an organization. It was started in 1986. The headquarters was, at that time also, was Bombay. So with the intention that all the different parts of India are having the family physician associations, and we have to unite. With that intention, this federation was started. And I am glad that at present also, we are having more than 35 units all over India. Though in some part of our country, we are unable to reach to them to join with us. But I think in next 5 years, the scenario will change. So you all know that any basic healthcare system of any country, it always starts from and the first point of contact should be a family physician. When I started my practice, I remember that always the patient comes first to us, and when we refer the patient to the consultant, they go to consultant. Now the thing is changed, and because of the multi-point and multi-centric first point of contact, development of multi-specialties, super-specialties, now patients are choosing their doctors and not the family doctors. So, it's a very sad part that our community of family physicians are declining. My humble request, my humble submission before this August dignitaries that let us have some such thing which can upgrade the family physicians in this thing. In IMA, I am working in IMA since 42 years, and we had many times approached to the government, the medical council, the universities, that it is a time now to start some family medicine department in each and every medical college, each and every hospital. And I think family physician is a specialty by itself. So there are so many specialists, but family physician and family medicine is also a specialty. So it's on behalf of all our community, it is my humble suggestion to you that let us give some inputs to the government, the NMC. Dr. Anilbhai Nayak is here, who is also a member of NMC. And he is a very much and very proud figure of our Gujarat, because he is the first Honorary Secretary General of IMA headquarters from Gujarat. In the history of IMA, it is the first time that Honorary Secretary General of IMA is from Gujarat. So, sir, please look into this matter. Only one more point for Anilbhai Nayak. He is our man. He is a man of the whole medical fraternity with a very good slogan, Haso ane hasao. Smile and keep others smile. I think such a personality, when goes for a big post, there will be a definite change in the whole system. Dr. Nitin Bhai Shah, I can say only one thing: a great man or the great son of a great father. With this, I think now I welcome all of you, and let us hope that FFPI will definitely be little bit more upgraded and updated regularly, and with its upgradation, the whole of all the under units and the other family physician associations will also upgrade. Thank you. Thank you very much.
Thank you, Dr. Abhay Bhai. Now I request Dr. Abhay Bhai to felicitate our guest of honor, Dr. Anil Bhai Nayak with memento. Request Dr. Sanjay Bhai Shah to felicitate Dr. Anil Bhai with shawl. requesting Dr. Amit Vaishya to felicitate our guest of honor and special invitee Dr. Nitin Vaishya with memento. And Dr. Dhiren Mehta to felicitate our Dr. Nitin Vaishya with shop. Requesting Dr. Thank you, sir. Requesting Dr. Anil Bhai to felicitate our President AFPA, Dr. Abhay Bhai Dikshit. Requesting Dr. Ashwin Vaishya to felicitate Director of the Hospital, Dr. Anil Bhai Jain. Dr. Dhiren Bhai Mehta to felicitate COO KD Hospital, Dr. PAREKH Desai. Myself to felicitate Dr. Hiren Kaswala, COO of SDUP Hospital. Requesting Dr. Anil sir to felicitate our Honorary Secretary AFPA, Dr. Vinod Bhai PAREKH. Is not available. Requesting sir to felicitate our AFPA President Team 2022-24, Dr. Pragnesh Shah. Please give a big requesting Dr. Anil sir to felicitate our new installed team, our new installed Secretary of FFPI, Dr. Pragnesh Vajrajan. Requesting Dr. Anil sir to felicitate our Treasurer, Dr. Dhiren Bhai Mehta. Thank you, Dr. Anil sir. I request our guest of honor, Dr. Nitin sir, to felicitate our Vice President FFPAI, Dr. Alok Singh. Dr. Alok Singh.
Dr. Jain, come on, collect on his behalf.
एक मिनट रवि I request Dr. Raj Kishore Bajpai to felicitate our Dr. Praveen Bhai Bhavsar. Sir, please come.
डॉक्टर प्रवीण भावसार आरोग्य भारती के राष्ट्रीय संरक्षक हैं, पूरे देश की हेल्थ पॉलिसी बनाने में आपका योगदान रहता है।
Thank you, Dr. Bhavsar, Dr. Bajpai. And at last, requesting Dr. Nitin sir to felicitate our chairman FSSS, Dr. Janak Bhai Shah. Thank you, sir. Thank you, Dr. Nitin sir. Now, I request Dr. Sanjay Shah to give introduction of our guest of honor. Yes, sir.
Good afternoon, everyone. Dignitaries on the dais, of the dais. First of all, I would like to congratulate the Ahmedabad team for organizing such a great and superb concert. First of all, I would like to know how many of you are FSS member. So I can just count on my fingers. Huh? So I would like to introduce to you about FSS. What is FSS? FSS is Family Social Security Scheme, which is running. Means even IMA branch is also running. GP, every branch is running this. But this is a federation branch. What we are running this FSS. And our motto is basically to cross 10 lakhs. To give it to a person should be nearly 10 lakhs rupees after his demise to the near ones. So I would request all of you to become member of SSS. It is nothing but helping your colleagues and also making arrangement. Some people say we make arrangement for ourselves. No, I say we would like to help our colleagues. This scheme was started for basically to help our colleagues. The founder of the member from the social security scheme was really started by them to help the colleagues. It was like, during in the sanatorium, one of the doctor wanted to help his colleagues, but he said, how much I can help? I can help him 1,000 rupees, I can help him 2,000. But supposing all of us remove 1,000 rupees and give it to me, it becomes a big amount. Immediately it is transferred to the deceased family. And within, I tell you, we are so fast in distributing it. Within 48 hours moment we received, the DC we distributed 48 hours. And even to person who are handicapped, even the doctor who is not able to practice and he becomes sick, bedridden, the money is given to them for his illness. There are so many people and which I have handed over the checks and they were really grateful. I really ask that become member in FSS. Thank you. At present we are giving up nearly about 4 lakhs. But my and Pragnesh's dream is 10 lakhs.
Thank you, sir. Thank you very much. Be a member of FSSS and be a member of CGP. We have on stage our chairman IMA CGP, Dr. Jaswant Darbar. Let me request him to say something about College of General Practice IMA.
Thank you for giving me opportunity to introduce IMA CGP. IMA CGP is there to empower our family physicians. There are so many courses run under IMA Acacia where you can empower your knowledge in any field, diabetes, from diabetes to radiology and everywhere. Even IMA CGP is giving FCGP, a Fellow of College of General Practice degree. If any of the IMA branch want to have FCGP at their center, any 10 MBBS, if there are 10 MBBS people who want to go for examination of FCGP, we can give them center over there and we can conduct the FCGP exam and we can empower them with a fellow of college general practitioner degree. So in South, this IMS CGP is running very well. IMS CGP is conducting many programs for the empowerment of the family physicians. In Western Zone, particularly in Gujarat, we want to empower our family physician under the leadership of Nayak Sahib. So I request, so many are the members of IMS CGP, but they don't know that what is IMS CGP. So those who are not a member of IMS, please become a member. We will have a form over here or with Dr. K.C. Gadvi sir. Just by paying 250 rupees, you can become a member of IMS CGP. And I request the outgoing president and incoming president, let us join FFPI and IMS CGP join hands together to build a good scientific program to empower our family physicians. Thank you.
Thank you, Dr. Darbar. Now it is the time to introduce our guest of honor, Dr. Nitin Shah. I request Dr. Sanjay Shah to give an introduction of our guest of honor.
Good evening, everybody. It is my pride to introduce Dr. Nitin Shah. He is a steward personality. Dr. Nitin Shah is son of Dr. Sumit Shah, a very known consultant physician of Gujarat during 1960 to 1990. Nitin Bhai has done his graduation and post-graduation from BJ Medical College and started his practice as consultant cardiologist and philanthropist in Ahmedabad, opposite Gujarat College. And now he is dedicated to charitable work. For this, he is attached with so many institutions. Few of them are, he is chairman and managing trustee of Indian Heart Foundation and Research Center and Nitin Charitable Trust, president of National Association for Blind, Gujarat Research Society, patron of Public Health Foundation of India, Diabetic Care India. He is trustee of Blind People Association and Arvind Lalbhai Charitable Trust and UTHAN, an institute for mentally challenged people. He is also governing council members of Gujarat Law Society and GCS Medical College. And for AFPA and Ladies Club of AMA, he is in true sense a Bhamasha. As no project was delayed or stopped due to lack of fund, as Nitin Bhai is always there. So we have decided to give our Oration Award in the name of Dr. Nitin Shah Oration Award. And we are very much thankful that he is generously donated a huge amount for our association, and we will remember him for many of years. This time
big thanks for Dr. Nitin Shah. A big thanks. Now I request Dr. Dhiendra Sanandia to give introduction of our guest of honor speech. Guest of honor, Dr. Anil Bhai Nayak.
Good evening, everyone. It's my pride to introduce our guest of honor, Dr. Anil Bhai Nayak. He is a renowned consultant orthopedic surgeon from Mehsana. He is associate professor in Department of Orthopedic Surgery at GMOS Medical College, Palgan. He started his journey as a general secretary at BJ Medical College, Ahmedabad. Then he worked as a senator for Gujarat University and Hemchandra Acharya University, North Gujarat University. He has worked as a president of IMA Gujarat State Branch, Gujarat Orthopedic Association and North Gujarat Orthopedic Association. At present, a member of NMC also. He has also worked for Mehsana District Indian Red Cross Society. He is a trustee of Urban Charitable Trust at Mehsana and worked for the polio diagnostic and surgery camp and operated for more than 5,000 patients free of cost. He is also He is also a trustee of famous Lion General Hospital, Mehsana. He is also worked for various other organizations also. Now I invite our respected guest of honor, Dr. Anil J. Nayak, to say a few words.
Good evening. દીક્ષિત સાહેબે કીધું કે નાયક સાહેબ હસે છે અને હસાવે છે. અધૂરું છે. હું હસું છું, હસાવું છું અને હસી કાઢું છું. હસવું શરૂઆતમાં ગુજરાતી બોલીશ એટલે નહીં તો પાછી આઉટ ઓફ ગુજરાતના ઘણા મેમ્બર્સ હતા, ડેલિગેટ્સ હતા. Although he had given his speech in Gujarati, but government taught us mixopathy. So we have to speak in Gujarati, Hindi, English, every language we know. So please forgive me for my interaction with in multiple languages. Because we learned from our college life when I was General Secretary and for organizing one talent evening or other function, we have to go to the either Kerala or Torrent for advertisement and collection of the funds. In Vijay Medical during my second or third MBBS, students from North Gujarat are difficult to speak in English. Our English was very weak. I mentioned two occasions. One, हम लोग जब जाते थे केरीडा और टोरेंट में, तो we go to with 3 or 4 friends और जाके वहाँ जो मैनेजर है उनको मिलते थे कि सर we are student from विजय मेडिकल कॉलेज और हम लोग एक टैलेंट रीडिंग कर रहे हैं, तो हमारा जाहिरात कॉपी पढ़ते हैं. From our college life, we used to speak in mixopathy. Once, during our Junior Doctor Association strike, the leaders from Baroda Government Medical College came to Vijay Medical College. They gathered in GBM, and the leader of the GDA Baroda given his speech in English. So our leader from Vijay Medical College, Dr. Kanu Patel said, "Saru Baroda में English medium लागे थे." मैं कीधु આપણે English medium માં છીએ, પણ એ બધું ચાલે જાય. સાહેબો આપણા જેવા છે ને સ્ટુડન્ટો આપણા જેવા છે. કારણ કે ઘણી વખત શું થતું હોય, સમટાઈમ્સ એ પ્રોબ્લેમ ઓફ ધ પ્રોનાઉન્સિસ. हमारा एक सीनियर था, एनाटॉमी का वाइवा था, तो उसको पूछा कि वेयर इज द इंसर्शन ऑफ द ट्राइसेप्स मसल. ही सेड इन गुजराती, वाई कड़िया. Sir replied it, why Kadiya means this is olecranon. He understands this is why Kadiya means he said want to give the answer in olecranon, but he is unable to speak why olecranon, so he said what why Kadiya. Such type of mistakes occurred during our college life, and from mistakes we learn many things. So, haso. Kankin lecture, so you have gathered from 9 morning till this 5 p.m. You have done lots of things. Many of consultants, many senior super specialists, especially hammered on your brains. So you are bored. Haso. Laughing is the best medicine, everybody knows. And hasu આવું ગ્રુપમાં ગમે. You should laugh in groups. आप अकेले अकेले हंसोगे लोग पागल समझेंगे। अकेले अकेले आदमी रो सकता है, हंस नहीं सकता। हंसने के लिए ग्रुप चाहिए, हंसने के लिए ग्रुप चाहिए। अदरवाइज ये सब सीनियर को देखता हूँ बगीचे में के जूता हंसते लाफिंग क्लब में जा रहे हैं। नो नीड ऑफ गोइंग टू लाफिंग क्लब। We should interact with each other. And for general practitioner, family physicians, and GP शब्द was old because in short form it was lying GP, and police वाला also write GP, Gujarat Police. Commissioning, what are you doing? I am GP. Oh, you are in Gujarat Police? No, I am general practitioner. Now they have changed the word from GP to family physician. That's why. So, because I don't want to give advice or anything, some people thought that he is now leader, he is the Honorary Secretary General of IMA, so he will give and advise you. But friends, in present era, when you need help, everybody will advise you, and when you need advice, everybody will help you. आपको मदद चाहिए तो आपको एडवाइस देंगे, और आपको हेल्प चाहिए, एडवाइस चाहिए तो सब मदद करेंगे। तो ये नोबडी लाइक एडवाइस, और एडवाइस इतनी दो कि सामने वाला आपका दुश्मन बन जाए। जो हम करते हैं वही बोलने का, जो नहीं करते हैं वो किसी को एडवाइस करोगे तो आपको वो दुश्मन समझने लगेगा। इसलिए आई डोंट वांट गिव एडवाइस, एंड फॉर दैट मैं कभी कभी ऐसे एडवाइस के मुद्दे आते हैं तो मैं एक दो स्टोरियों बातें कहता हूँ। एक बच्चा था, चॉकलेट खा रहा था। मैंने बोला बच्चा चॉकलेट मत खाओ, चॉकलेट खाने से दांत बिगड़ते हैं, टॉन्सिलाइटिस होता है, खांसी होती है, सब कुछ होता है। तो उन्होंने बोला कि मेरे ग्रैंडफादर 100 साल जिए थे। तो मैंने पूछा वो चॉकलेट खाते थे कि नहीं, वो अपने काम से काम रखते थे, किसी को सलाह नहीं देते। और जहाँ जरूरी नहीं हो, कोई जगह भी जरूरी हो, फिर भी हमें एडवाइस देने की हमारी एक हैबिट होती है, तो हमें एडवाइस देने शुरू हो जाते हैं। एक आदमी था सूटेड बूटेड, तो बॉम्बे एयरपोर्ट के बाहर खड़ा था, सिगरेट पी रहा था। एक गांधीवादी आदमी आ गया, थैला लटका हुए, खादी का कुर्ता, खादी का लहंगा पहने, ऊपर गोटी लगाई हुई थी। आके बोला, ओह आर यू स्मोकिंग? आप स्मोकिंग कर रहे हैं? लोग ने हाँ मैं करता हूँ स्मोकिंग, अंदर अलाउ नहीं इसलिए बाहर आके स्मोकिंग कर रहा हूँ। आप कितनी सिगरेट पीते हैं? बोला कि रोज के 3-4 पैकेट में सिगरेट पीता हूँ। कि एक पैकेट में कितनी सिगरेट आती है? कि 20 सिगरेट आती है। कितने साल से पीते हैं? 27-30 साल से पी रहा हो। मैंने बोला हिसाब, एक सिगरेट कितने की आती है? कि रोशनस लाइट है, अब तो वो 40-50 रुपए की एक आती है। तो मैंने पूरा कैलकुलेशन लग दिया, एक सिगरेट का इतना, दिन की इतनी, साल की इतनी, और टोटल लगा के बोला हो आप इतनी सिगरेट पी गए हैं कि अगर आप सिगरेट नहीं पीते तो आपका खुद का प्लेन अंदर होता, आप एयरपोर्ट के बाहर नहीं खड़े होते, आपका खुद का एक प्लेन होता। बोला ठीक है। उसने सामने क्वेश्चन किया, आर यू स्मोकिंग? आप सिगरेट पीते हो? बोला कि नहीं। आपका कोई प्लेन अंदर है? बोला कि नहीं। क्या मैं मिस्टर गोयल हूँ, नरेश गोयल हूँ, और अंदर जेट एयरलाइन की सभी फ्लाइटें मेरी। तो जहाँ जरूरी नहीं हो वहाँ भी हम एडवाइस देंगे तो हमें शर्मिंदा होना पड़ेगा, इसलिए मैं एडवाइस नहीं दूंगा। आपने मुझे बुलाया है इसलिए मुझे कुछ तो बोलना पड़ेगा और आपको सुनना भी पड़ेगा। तो जो लोग बाहर से आए हैं उसको बता दो कि अहमदाबाद, यहाँ का पानी में इतनी ताकत है। अहमदाबाद आप लोग बड़ी सिटी, मेगा सिटी के नाम से, इकोनॉमिक सिटी के नाम से जानते होंगे, लेकिन ये अहमदाबाद का पानी जो पिएगा पूरे विश्व में जाएगा, उसे कोई उल्लू बनाया सकता नहीं। ताकत है पानी. Because I have experience. I was in Vijay Medical from 1982 to 93. 11 साल का पानी का अनुभव है. वो पानी की वजह से आज मैं जहाँ चल रहा हूँ तो ये सब अहमदाबादी हैं. ये लोग मुफ्त में हंसते भी नहीं है. कोई गाली बोलेगा तो कुछ जवाब ही नहीं देगा. बोला कि यार तेरे को गालियां बोला और तू कुछ किया नहीं. वो आप देके गया है, कुछ लेके तो नहीं गया. और अभी तुम होटल पे या कोई बार चाय की लारी पे जाओगे तो चाय के छोटे छोटे कप आने लगे. इट इज बिकॉज ऑफ अहमदाबाद. हम पढ़ते थे बड़े बड़े कप में चाय आती थी, लेकिन 2-3 होटलों में हमने देखा वहां लिखा था कि आधी चाय के 3 भाग नहीं होंगे. आधी चाय में से जो 3 डिवाइड करते थे. तो इसलिए अब होटल वालों ने पैसे इतने रखे पर कब छोटे कर दिए, इसका भाग ही ना हो. बिकॉज ऑफ दिस इज अहमदाबादी. और अहमदाबादी होटल में जाता है, होटल के अंदर साइकिल बार पार करेगा, चाय के होटल में जाएगा, बोलेगा कि 2 गिलास ठंडा पानी लाओ, पंखा चालू करो, साइकिल की गियर रखो और आधी चाय लाओ. और आज का न्यूज पेपर तो लाना ही पड़ेगा. आधी चाय में इतना वो काम कर लेता था. वो अहमदाबाद शहर है. अहमदाबाद मानचेस्टर के नाम से भी जाना जाता. पहले इतनी यहाँ टेक्सटाइल मिल्स थी. टेक्सटाइल इंडस्ट्री का बड़ा नाम था. अगर हम इतिहास में जाएं तो एक करणदेव वन ने, करणदेव करके जो किंग हो गया सोलंकी कुल का, उन्होंने इस शहर को स्थापना की थी. उस टाइम उनका नाम कर्णावती था. बाद में 1411 में अहमद शाह यहाँ आया. उन्होंने देखा एक बड़ा शहर है और उन्होंने एक विचित्र घटना का देखा कि एक कुत्ता जा रहा था, उस पर एक सस्से ने हमला किया, एक रैबिट ने एक डॉग को भगाया. तब उन्हें लगा कि जमीन में पानी में कुछ है. तब बादशाह बोला कि जब कुत्ते पे सस्सा आया तब बादशाह ने शहर बसाया. वो अहमदाबाद की सिटी में जो बाहर से लोग आए हैं उनको मैं स्वागत करता हूँ. यहाँ विजिट करने के लिए महात्मा गांधी को भी प्रेरणा अहमदाबाद में से मिली थी. सरदार वल्लभ भाई पटेल भी यहाँ के कॉरपोरेशन के प्रेसिडेंट रह चुके हैं. यहाँ सीधी सैयद की जाली भी है. बहुत कुछ है अहमदाबाद में देखने के लिए. तो अहमदाबाद में आए तो उसका भरपूर उपयोग करें. और खास फैमिली फिजिशियन आईएमए आज के बहुत टर्मोइल फेज में जा रहा है. मेडिकल फ्रेटर्निटी पूरी. आपने देखा होगा assault on doctors is a routine. Day before yesterday in Maharashtra, one junior resident, 2 junior residents were stabbed by the patients. So assault on doctor is main problem we are facing, and second one is mixopathy. As far as violence against doctor or health organization is intolerable. उसको टॉलरेट करना नहीं है, लेकिन क्या करें? फॉर दैट वी हैव टू यूनाइट. हमें संगठन में शक्ति बनानी पड़ेगी. हमें एक होना पड़ेगा. हम यूनाइट रहेंगे तो किसी की ताकत नहीं कि हमारे सामने देख. हमने देखा था जब पढ़ते थे, हमारे टीचर थे गुजराती शाला में, जब बाल्यावस्था में थे तब बताया था उन्होंने कि बेटा बड़े होके 2 लोगों से कभी बिगाड़ना नहीं. कितना भी बड़ा हो लेकिन 2 लोगों से दुश्मनी मत करना. तो हम सबने पूछा कौन 2 लोग हैं जिससे हमें दुश्मनी नहीं करनी चाहिए. तो वन से वन गॉड, भगवान से कभी दुश्मनी मत करो. दूसरा डॉक्टर. मैंने बोला डॉक्टर और भगवान से दुश्मनी, ठीक है सर. उस टाइम तो हम प्राइमरी में थे, मालूम भी नहीं था कि हम भी डॉक्टर बनेंगे. लेकिन उन्हें बताया मेरी वजह क्या है कि भगवान से जो आप दुश्मनी करोगे तो वो डॉक्टर के पास भेजेगा, आपको बीमार भेजेगा. और डॉक्टर से दुश्मनी करोगे तो आप भगवान के पास भेजेगा. तो डॉक्टर का ये महत्व था पुराने जमाने में. और संस्कृत में भी एक श्लोक था, वैद्यराज नमस्तुभम यमराज सहोदर यमस्तु हरति प्राण तू प्राण धनानी च. कि हेवेंद्रराज, आप यमराज के बड़े भाई हो, आपको प्रणाम करता हूँ। यम तो खाली प्राण ले जाते हैं, आप तो प्राण और धन दोनों ले जाते हैं। ये हमारा डिग्निटी था, हमारा इतिहास था, हमने इतिहास बिगाड़ दिया। अगर हम इतिहास यमराज जैसा रखते, हम यूनाइट रहते, लेकिन ये यूनिटी का प्रॉब्लम अभी से नहीं है, चरक में भी 4000 साल पहले लिखा है। व्याकरणम अति निंदति सर्पानाम भय डरम भयत वैद्यानाम अनेकत्वम तम जीवंती जंतवः। अगर शेर 15-20 घंटे सोता नहीं, वो एक बार खाएगा तो 15-20 घंटे सोएगा, 15 दिन के बाद ही शिकार करने जाएगा। हर रोज खाता नहीं शेर, ज्यादा सोता है। सांप, वो इतने डरपोक होते हैं, बिना छुए वो किसी को काटते भी नहीं। करोड़ों सांप है, लेकिन वो डरते हैं, इसलिए वो सिटी में वगैरह में नहीं आते। और तीसरा वैद्यम अनेकत्वम, वैद्य जो एक होते, तो ये तीनों जो नहीं होता तो कोई पृथ्वी पर एक भी जीव जीव नहीं सकता। हम एक होते, अगर किसी को मर गया, फॉरेंसिक वाला रिपोर्ट कौन बनाएगा? कोई भी मेडिकल का सब हो तो रिपोर्ट हम देने वाले हैं। हम एक होते तो कोई बच नहीं सकता। ऐसा 4000, लेकिन हम एक नहीं हो सकते। हमें एक होने का प्रयत्न करना है, होने वाले नहीं है। 4000 सालों से सब प्रयत्न कर रहे हैं, ट्राई कर रहे हैं, पर कुछ लोग एक हो जाएंगे तो हम 100 में से 80 एक हो गए तो हम फाइट कर सकते हैं। क्योंकि और जनरल प्रैक्टिस के बारे में तो सरकार का प्रोग्राम चला है, सेव टाइगर्स, सेव लायंस, सेव गर्ल्स। नाउ अ डेज वी हैव टू वर्क फॉर सेव जनरल प्रैक्टिस, सेव फैमिली फिजिशियन। आजकल फैमिली फिजिशियन, मैंने महसाना में पिछले 25 साल में एक भी नया फैमिली फिजिशियन बैठा नहीं है, अभी कोई बैठता नहीं है। इतनी पीजी की सीटें खुल गई है, सब कुछ ना कुछ होना है। फैमिली फिजिशियन, सुपर स्पेशलिस्ट, सुपर स्पेशलिस्ट। हम पढ़ते थे तो लोग कहते थे आने वाले समय में नाक का टीपोस का डॉक्टर मिलेगा, कान का टीना का डॉक्टर मिलेगा। अब ये हो रहा है। ऑर्थोपेडिक में सब जनरल था पहले, और स्पाइन के, जॉइंट रिप्लेसमेंट के, आर्थ्रोस्कोपी के, सबके अलग अलग है। हमने एडमिशन लिया तो बोलते मेडिकल में जाओ, बहुत स्कोप है। तो हमने भी ये बात को मालूम पड़ा कि नाक में नाजल स्कोप है, आंख में फंडोस्कोप है, ऑर्थोस्कोप है। एक ओरिफिस बाकी नहीं रखी है और एक कैविटी बाकी नहीं रखी, सभी में स्कोप डाल दिया। हमारा स्कोप कहाँ है वो मुझे अभी तक मिला नहीं। उस टाइम मालूम होता कि ये सब स्कोप है तो शायद नहीं लेता, लेकिन ये सब है। तो हमें यूनाइट रहना है, और यूनाइट रहने के लिए वी नीड स्ट्रेंथ। हमारी स्ट्रेंथ होनी चाहिए। अब भी बोला कि एसएसएस के मेंबर बनो, हमारे आईएमए सीजीपी के मेंबर बनो, आईएमए के मेंबर बनो, जिसके मेंबर बनो। डॉक्टर, मैं एक टीचर का लड़का हूँ, तो मैं देखता था तो फादर के पास 200 रुपया मांगते थे तो 100 या 125 देते थे, कुछ कट कर भी देते थे। हमें बजट ऐसा बनाना पड़ता था कि 500 मांगूंगा तो 300 देंगे। 1 रुपये की 3 अठन्नी वाले होते थे टीचर, तो डॉक्टर 1 रुपये की 5 या 6 अठन्नी है। वो मेडिकल कॉलेज के सिवा, अपने बच्चों के एडमिशन के सिवा कहीं डोनेट करते नहीं। 90% डोनेशन लेने जाओ, डॉक्टर नहीं करते। 10% है, और वो लोग सभी डॉक्टर, नॉट ओनली जनरल प्रैक्टिस, ऑल डॉक्टर्स, those who have taken admission in MBBS from MCH or DM, they are not donors. वो दान नहीं कर सकते। वो मानते हैं कि जो हम मुफ्त में देखते हैं किसी को, वो सेवा ही है ना, वो सेवा मानते हैं उनको। वो सेवा नहीं है, वो क्रिया है, हर एक आदमी करता है। और जो विद्या हम सीखे हैं वो हम पेट पालने के लिए सीखता है। उसको अपने वेदों में अविद्या कहा है कि खाने पीने रहने के लिए, बच्चों के पालन पोषण के लिए जो हम प्रोफेशनल एजुकेशन देते हैं वो विद्या नहीं है, वो अविद्या है। विद्या किसके? जो हम आत्मा के लिए, शरीर के लिए, प्रभु के लिए जो काम करते हैं, उसके लिए जो मेडिटेशन करते हैं, पूजा भक्ति, वो विद्या है। ये अविद्या है, पालन पोषण के लिए करते हैं। तो हमें अविद्या से जो मिला उसका थोड़ा डोनेशन करके, विद्या करके, कर्म ध्यान सभी, ये एसएसएस में मेंबर बनना होता है, चालू होता है जब आप प्रैक्टिस शुरू हो तब सोशल सिक्योरिटी स्कीम में मेंबर बन सकते हैं, लेकिन हमारे डॉक्टर कब बनेंगे? लास्ट डेट कौन सी है? 60 इयर्स के बाद नहीं बन सकते, तो 59 में मेंबर बनेंगे। देखना, आई हैव द रिकॉर्ड्स। ये नहीं करना चाहिए हमें। ये स्कीम कोई एडवांटेज, नफा मुनाफा देने वाली नहीं है। ये हमें अपने कलीग को, अपने फ्रेंड्स को, अपने डॉक्टर मित्र को हेल्प करने के लिए स्कीम है। उसमें मुनाफा और कैलकुलेशन मत करो। और जनरल प्रैक्टिशनर तो हर रोज ये सेंस ऑफ ह्यूमर हर रोज उनको प्रैक्टिस पे मिलता है। एक जनरल प्रैक्टिशनर प्रैक्टिस कर रहा था, एक कॉन्स्टिपेशन का पेशेंट है तो सर 10 दिन से हमें स्टूल पास नहीं हुआ है, टट्टी नहीं हुए, क्या करें? डॉक्टर ने कैलकुलेटर निकाला, एक दवाई की बोरी, एक बाउल निकाला। बोलो कहाँ रहते हो? कि सर नवरंगपुरा में रहता हूँ। और वो डॉक्टर का प्रैक्टिस क्लिनिक था मेमनगर में। ओके, कैलकुलेटर ने किया, 1 चम्मच डाली उसमें बाउल में कि आप वहाँ फ्लैट में रहते हो, खुद का बंगला है, जैसे फ्लैट में रहता हूँ। फ्लैट में कौन से मंजिले पे रहते हो? कि तीसरे मंजिले पे रहते हो। फिर उन्होंने कैलकुलेशन किया कैलकुलेटर में और 1 चम्मच डाली। फिर ऊपर जाने के लिए लिफ्ट है या चल के जाओगे? देखिए लिफ्ट है। ओके, फिर कैलकुलेशन, यहाँ तुम चल के आए हो, बस में आए, स्कूटर लेके आए हो, गाड़ी में आए हो? सर स्कूटर लेके आए। फिर कैलकुलेशन किया, फिर दवाई डाली और ऐसा करके सब पूछ लिया। फिर कैलकुलेशन करके दवा दी, बोलो कि अभी पी लो और भागो, घर पहुंच जाओ। वो तो दवा लेके भागा। 3 दिन बाद आया कि साहब आपकी दवा तो बहुत बढ़िया थी, लेकिन कैलकुलेटर बदलो। तो क्या हुआ? सर लिफ्ट में हो गया। अगर कैलकुलेटर सही गलती करता तो मैं 10 फुट तक पहुंच जाता, लेकिन लिफ्ट में हमारा हो गया। तो ये सब रूटीन होता है। आप पेशेंट के पास जाते हो तो पेशेंट का कंप्लेन, हमारे गुजरात में મહેસાણા में खास संडे को पेशेंट दिखाना था, सब डायरिया हुआ है, केवा થયા છે? એટલે કે પાતળા પાણી જેવા। એટલે કેટલા પાતળા? એટલે કે કોગળા કરે એવા। ના ના એમ નહીં, કેવા છે એટલે કે ખાટા। અરે ભાઈ દેખાવે કેવા? એટલે કે દાળ ઢોકળી જેવા। હવે ઘરે જઈને ડોક્ટર દાળ ઢોકળી ખાઈ શકે? जनरल प्रेक्टिशनर ત્યાં એક પેશન્ટ આવ્યો કોન્સ્ટિપેશનનું। સાહેબે બધું જોયું, બધું નોર્મલ હતું, પછી કે સુઈ જા, પછી પીઆર જેવું જોવા કે ઓ પેન્ટ ખોલી જોઈ, ચોકી મારી, ફટ નહીં સંડાસ થઈ ગયો। પેલો કે સાહેબ હવે ધ્યાન શું રાખવાની? કે સિમેન્ટની કોથળીથી સાફ નહીં કરવાની। जनरल પ્રેક્ટિશનર રોજ બનતું હોય છે, રોજ તમારે આવી સલાહ આપતા હોય છે, પણ આ બધું થતું હોય ત્યારે એન્જોયમેન્ટ, યુ શુડ ટેક એન્જॉयमेंट ऑफ दिस मोमेंट। रूटीनली हमें सेंस ऑफ ह्यूमर हमारी प्रैक्टिस में मिलता है। हमें किसी के पास जाने की जरूरत नहीं है, हम गेदर हो गए, लेकिन स्ट्रेंथ बढ़ाने के लिए। और दूसरा, क्योंकि यूनिटी हमारी होनी चाहिए। हमारी यूनिटी ऐसी होनी चाहिए कि जैसे मत बुरा हो, कुत्ते जैसी नहीं होनी चाहिए। कुत्ते को तुम मारोगे तो भाग जाएगा, दूसरे कुत्ते को लेकिन मधुपुड़े को आप मारोगे, सभी मधुमक्खियां अटैक करेंगे। तो हमारी यूनिटी, हमारे कोई भी हो, आज तुम एडवोकेट को देखो, कोई एडवोकेट को हाथ भी लगा सकता है, उन्होंने किसी को मारा, ये मारा, कोई नहीं कर, बिकॉज यूनाइटेड है। तो हमें थोड़ा यूनाइट होके और स्ट्रेंथ बढ़ाने के हमें मेंबरशिप ड्राइव करनी पड़ी। जितने लोग हैं, अपने बच्चे हैं, सबको हम इसमें काम लगाए। और हम देखते हैं कि आजकल कंप्लेन या मीडिया भी चलाता है कि डॉक्टर कमीशन के धंधे में पड़ गए। हमें फादर वालेस ने कहा था कि आदमी जब पैदा होता है, जन्म लेता है, तो सबसे पहला हाथ किसका लगता है? डॉक्टर का। और जब हॉस्पिटल से वो एक्सपायर्ड होता है, डेथ होता है, तो लास्ट हाथ भी उनका डिक्लेरेशन हम भी करते हैं कि भाई नाउ ही इज नो मोर, ही इज फिनिश्ड। तो भगवान के घर से नीचे आने वाला और ऊपर जाने वाला, दोनों को टच, डायरेक्ट कांटेक्ट विद द गॉड्स हमारा हाथ है। तो ये हाथ को पवित्र रखिए। हमें ये सब कमीशन हो या कट प्रैक्टिस हो या कुछ भी हो, एमआर से मिलता हो, वो नहीं लेने का। बनने जितना हो सके इतना आप प्रयत्न करिए। और हमारा जो एप्रन वाइट दिया है उसमें एक बिकॉज वकीलों को तो काला कोट दिया गया है, वो खून करके आते हैं, उसको भी बचाता है, जिसका खून होता है उसका भी केस लड़ते हैं, उनको दोनों तरफ से होता है, इसलिए व्हाइट शर्ट के अंदर ब्लैक कोट भी दिया हुआ है। हमारे सिर्फ व्हाइट एप्रन है। एक छोटा सा भी डॉक्टर, आप पानी पूरी खाने जाओगे, लारी में भजिए खाने जाओगे तो मुझे डॉक्टर भजिया खाएंगे, डॉक्टर से पानी पूरी खाओगे पूछेगा। दे डोंट कंसिडर एज ए ह्यूमन। हमें तो भगवान मानते हैं और कुछ मानते हैं मालूम नहीं, और भगवान बनने का प्रयत्न भी नहीं करना। भगवान कहे, क्योंकि आपने कोरोना में देखा होगा, पेशेंट आएगा बोलेगा सर आप तो भगवान हो, 2 दिन ठीक होगा बोलेंगे भगवान जैसे हो, और बिल दोगे तो क्या बोलेगा, लूटा रहो तुमने तो भगवान माना था, तुम्हें तो लूटी। तो डोंट गो विद द सेंटेंस और ओपिनियन ऑफ द पब्लिक। आप अपने दिल से, हम अच्छे होने चाहिए, अपने दिल से हमें अच्छा काम करना है, लोगों की सेवा करनी, किसी का सर्टिफिकेट लेने की या भगवान बनने की कोशिश मत करो। भगवान नहीं, हम ह्यूमन है, हम प्रोफेशनल है, हमें प्रोफेशनली हमारा काम करना है और हम करते रहेंगे, ऐसा हम सोचो। दूसरा मिक्सोपैथी का है कि गवर्नमेंट ने अब 6 महीने का जो कोर्स करके आयुर्वेद, होम्योपैथी, अब तो इंटरडिसिप्लिनरी आने वाला है कि नर्सिंग वाला मेडिकल कॉलेज में भी पढ़ने आएगा, मेडिकल वाला डेंटल में पढ़ने जाएगा, डेंटल वाला होम्योपैथी, ये सब हो रहा है। लेकिन हमें प्रोटेक्ट करना है कि हमारी पैथी बचे। हम नहीं कहते कि एलोपैथी के सामने दूसरी पैथी अच्छी नहीं है, वो आयुर्वेद की जगह अच्छी है, होम्योपैथी की जगह अच्छी है, यूनानी की जगह अच्छी है, लेकिन मिक्स मत करो। मिक्स करने से बिगड़ जाएगा। होलिस्टिक अप्रोच रखो, जहां एलोपैथी काम नहीं करती है वहां आयुर्वेद का क्या रोल है, प्रिवेंशन में होम्योपैथी का क्या रोल है, उनकी जो एडवांटेज है, उनका जो लाभ है, वो हमें होलिस्टिक अप्रोच से लेना पड़ेगा। सबका थोड़ा थोड़ा अप्रोच है, लेकिन वो भी एलोपैथी करने जाएंगे, हमें भी करके ऑपरेशन करने की भी छूट दे दी है। वो दांत से मार के पैर का फ्रैक्चर तक का वो ट्रीटमेंट कर सकते, ऐसी भी परमिशन आ गई है। तो हमें थोड़ा रेजिस्ट करना होगा, हम फाइट तो नहीं कर सकते बिकॉज वी आर इन माइनॉरिटी, हमारी इतनी पॉपुलेशन नहीं है कि हम फाइट कर सकते, बट वी हैव टू कन्विंस बाय आवर लीडर्स, आवर रिप्रेजेंटेटिव्स कि सर ये गलत हो रहा है। तो हमें प्रोटेस्ट नहीं करना है, हमें जो भी हमारा पेशेंट कोई पॉलिटिकल पार्टी से हो, कोई ऑफिसर हो, तो उनको समझाना कि इससे ये दुविधा होगी, इससे नुकसान होगा, तो हमें वो कन्विंस करना है। और आने वाले समय में आपके पेशेंट आते हैं, यंग जनरेशन आते हैं, तो उनको भी समझाओ। आजकल के जनरेशन है वो शादी लेट करते हैं, कोई भी लाइन का, मेडिकल वाले तो करते हैं कि बर्थडे में वो तो लेट होता है, वे ज्योतिष उनको मंगल का दोष है वो करे, लेकिन मेडिकल के एजुकेशन की वजह से हमारी शादियां लेट होती है। लेकिन आजकल के न्यू जनरेशन, हम वेस्टर्न कल्चर हो जा रहे हैं, शादी लेट करते हैं, और शादी करने के बाद बच्चे निकालना तो उनको इच्छा ही नहीं होती। पहले तक हम दो हमारे दो, अब तो हम दो हमारे एक, सिंगल पीस कट पीस में करते हैं। आप जानते हो कि महात्मा गांधी उनके फैमिली के चौथे संतान थे, आम्बेडकर उनके फैमिली के 12वें संतान थे, अब्दुल कलाम उनके फैमिली के 14 संतान थे, विवेकानंद 8वीं संतान थे, रविंद्रनाथ टैगोर 9वीं संतान थे। ये एक दो के चक्कर में महान पुरुष पैदा होने बंद हो गए। तुम देखो महापुरुष तो पैदा ही नहीं होता, जो अभी महापुरुष है वो भी तीसरे और चौथे सन है। तो बच्चों को समझाओ कि आप नहीं तो सिंगल पीस में क्या कहेंगे, इसका फॉरेन जैसा हो गया, काका मामी कोई हुआ सब निकल जाएगा, आंटी आ जाएगी और अंकल आ जाएंगे, एक में सब रिलेशन आ गए। तो आप अपने बच्चों को, आपके यंग पेशेंट आए उनको समझाओ कि मिनिमम 2 बच्चे तो चाहिए, मिनिमम देश के लिए जरूरी है। और यहाँ से एक्सपोर्ट बहुत होते हैं, हर एक देश में अपने 40-50 लाख पड़े हुए हैं, चिंता मत करो। भारत का 8 व्यक्ति ऐसा है कि 8 देशों में प्राइम मिनिस्टर भारत का है, हमें विश्व नेता बनना है, विश्व गुरु बनना है, तो हर एक देश में भारतीय का बड़ा प्रधान होना चाहिए। ये जीवन जी है, फैमिली प्लानिंग नहीं, फैमिली प्लानिंग नहीं। यू हैव टू टेक पॉजिटिव। 2 बालकों बस ऐसा था, बस 2 बालकों क्या था। पहले महिलाएं थी 11 बच्चा पैदा करके काम करती थी खेतों में, 99 ईयर्स वो जिंदा रहती थी। तुम देखो पुराने जो हमारे, क्योंकि हम भी, मैं भी, हमारे 5 भाई बहन हैं, मेरे फादर की 5 बहने थे, क्योंकि पहले पीडियाट्रिशियन और इतनी बच्चों के लिए कोई सुविधा नहीं थी, तो वो मानते थे 1-2 बच्चे तो मरने वाले हैं, तो हम तो स्पेयर की वेल की तरह ही पैदा हुए थे। ये तो कभी भी चला जाएगा, ये तो बचेगा, तो आप भी ऐसा 2-3 स्पेयर व्हील पैदा करो। आप उठे हो तो आपके बच्चों को बोलो कि मुझे 2-3 बच्चे चाहिए, ग्रैंड चिल्ड्रन चाहिए, तो भारत विश्व सत्ता बनेगा और बनेगा। तीसरा, खास आप देखते हैं सोशल सिक्योरिटी, प्रोफेशनल सब देखते हैं कि यंग डॉक्टर्स, यंग जनरेशन जल्दी एक्सपायर हो रही है, ज्यादा से ज्यादा मौत यंग डॉक्टर्स की हो रही है बिकॉज ऑफ स्ट्रेस, वर्किंग स्ट्रेस हो, पैसे कमाने की स्ट्रेस हो, कुछ भी स्ट्रेस। तो हम रेगुलर एक्सरसाइज करें, एक्सरसाइज करनी चाहिए। हमारी की प्रैक्टिस में टाइम नहीं मळतो, वी कुडंट फाइंड टाइम। आप जिंदा है तो जहान है, मोदी साहब ने कहा जिंदा है तो जहान है। हम होंगे तो हमारे पेशेंट भी होंगे, हमारे क्लिनिक भी होंगे। तो आप अपने खुद के लिए आधा घंटा 1 घंटा निकालो, एक्सरसाइज करो, वॉकिंग करो। वॉकिंग में भी लोगों ने प्रकार बना दिए, टाइप्स ऑफ वॉकिंग। Walking is walking, but they have find out there are 5 types of walking. One is walking, just routinely हम वॉक करते हैं, उसको वॉकिंग बोलते हैं। दूसरा प्रकार है कि वार्निंग वॉकिंग। अगर आपको CABG अनिल भाई ने कर दिया, डायबिटीज आया और डॉक्टर बोले कि चलना पड़ेगा, नहीं तो दोबारा ऑपरेशन करेगा, दोबारा ब्लॉक होगा, और डर के मारे जो हम करते हैं वॉकिंग, उसको वार्निंग वॉकिंग बोलते हैं। और साहब बैठे हैं, बाईपास के नंबर 1 है गुजरात में, अहमदाबाद में उनका बड़ा नाम है, तो यू शुड शेयर। उनके कार्डियोथोरेसिस सर्जन के हॉस्पिटल के बाहर लिखा था, अगर आप खुल के करते बात अपने यारों से, दोस्तों से, तो यहाँ औजारों के साथ खुलवाना नहीं पड़ता। कार्डियोथोरेसिस सर्जन के बाहर लिखा था। कोई भी प्रॉब्लम हो, कोई भी हंसी खुशी हो, तो अपने दोस्तों, अपने ग्रुप के साथ शेयर करो, खुल के बात करो, तो कभी बाईपास कराने की जरूरत नहीं पड़ेगी। लेकिन साहब के पास एक औरत आई, उसका हस्बैंड का साहब ने बाईपास किया था, साहब उसके दिल में दूसरी कोई नहीं थी ना, आपने बायस किया, हाथ खोला तो देखा होगा ना, साहब थी इसलिए तो बाईपास कर दिया। ऐसा भी होता है। तो कार्डियोथोरेसिस भी सेंस ऑफ ह्यूमर से बाहर नहीं है, चिंता मत करो। तो दूसरा है वार्निंग वॉकिंग, डर के मदद से करते हैं उसको वार्निंग वॉकिंग। तीसरा डार्लिंग वॉकिंग, जो अपने बीवी के साथ, गर्लफ्रेंड के साथ, बॉयफ्रेंड के साथ जो चलने जाते हैं, टहलने जाते हैं, उसको डार्लिंग वॉकिंग कहते हैं। 4th वन इज जेलस और बर्निंग वॉकिंग। हम चलते और देखते हैं कि सलमान खान तो बॉडी बना है, उसकी बॉडी बनानी, इसकी बॉडी अच्छी है, ऐसे बनाना है, उसकी जल्द के मारे ऐसी बॉडी बनाने की जो हम चलते हैं और जिम में जाते हैं, उसको बर्निंग हो गया। आपको जरूरत नहीं, लेकिन आप किसी की बॉडी देखे, उसके जन्म की हिसाब से आप चलने जाते हो, उसको हम बर्निंग वॉकिंग बोलते हैं। और लास्ट बट नॉट लीस्ट टर्निंग वॉकिंग। आप चलते जाते हो, बाजू में से एक अच्छा लड़का या अच्छी लड़की निकले, पीछे मुड़ के देखे, टर्न करके देखे, उसको टर्निंग वॉकिंग करते हैं। कोई भी वॉकिंग में जाओ, 5 में से कोई भी वॉकिंग करो, लेकिन वॉकिंग करो। तो हम लोग MLA और MP तो नहीं है कि असेंबली से वॉकआउट करेंगे, हमें वॉकआउट करना है, वर्कआउट करना है हमारे रोड पे, तो चलना रखो, क्योंकि एवरेज आयुष्य डॉक्टरों का कॉमन मैन से 10 साल कम है। आप देखना, ये रिकॉर्ड है कि हमारा एवरेज आयुष्य 10 साल कम है कॉमन पीपल से। तो हमें स्ट्रेस से रिलीज होना है, हंसना है, एंजॉय करना है लाइफ को। और एक ही शायरी है, क्योंकि बोलने जाओगे तो घड़ियों की कांटे नहीं, पर दो चीज कहूँगा, शायरी मेडिकल प्रैक्टिस में देखो बूढ़े हो जाएंगे भी छोड़ेंगे नहीं। 90 वर्ष का डॉक्टर भी प्रैक्टिस करता होता है, अच्छा है। लेकिन एक शायर ने लिखा है कि मोहब्बत और मेडिकल प्रैक्टिस, मोहब्बत और मेडिकल प्रैक्टिस दोनों एक जैसी होती है। आदमी करता रहेगा, रोता रहेगा और साला छोड़ेगा नहीं। करता रहेगा, रोता रहेगा, प्रेम भी करता रहेगा कि भाव नहीं अपनी भाव नहीं अब तो जो तो नहीं कालो कौन नहीं करे पर छोड़ के नहीं। हाँ मैं मुझे छोड़ेगा नहीं। तो समय आवे छोड़ो, एंजॉय योर लाइफ, गिव योर टाइम, बिकॉज युवानी में हमने प्रैक्टिस पैसे कमाने में हमारा टाइम स्पॉइल किया, हमारा टाइम दे दिया। अब आफ्टर 60 हमारी फैमिली को हमारी जरूरत है, फैमिली के साथ, बीवी के साथ। सैटरडे संडे तो प्रैक्टिस बंद कर दो, जो अबव 60 है वो सैटरडे संडे फैमिली के साथ रहो, क्योंकि उनका क्या गुना है। मैं तो जो पाप करते हैं वो डॉक्टर बनते हैं, और जो पुण्य करते हैं वो डॉक्टर वाले की फैमिली बनते हैं। जो कमाता हुआ है एंजॉय वो लोग करते हैं, हम भी उनके साथ एंजॉयमेंट में जुड़ जाए, ऐसा मेरा रिक्वेस्ट है। और लास्ट बट नॉट लीस्ट, जनरल प्रैक्टिस में गांव में होते थे तो क्या करते, सेठ था उसको पैर पे अल्सर हुआ था, तो एक जनरल प्रैक्टिशनर था, वो रोज उनका ड्रेसिंग करता था और आता था। ऐसा 10 साल से चल रहा था कि नॉन हीलिंग अल्सर है, उसका ठीक नहीं हो रहा। उनका बच्चा डॉक्टर बन के आ गया, तो बोला बच्चा तू आया है तो एक बार वो ड्रेसिंग वेसिंग करना, मैं 1 महीने के लिए अमेरिका घूम के आऊँ। तो आया, 1 महीने के बाद वो वापस आया तो देखा तो बच्चे ने बोला सर पापा वो डॉक्टर सेठ है हमारा, उनका अल्सर को 10 साल से मिला नहीं, मैंने उनको 15 दिन में हील कर दिया। 15 दिन में ठीक नहीं थी, आपने क्या किया था कि बेटा उनके पैसे से तो तू डॉक्टर बना है, तो तू डॉक्टर नहीं बनता। तो ऐसी भी होती है, जैसे भी करो एथिक्स के साथ, यूनिटी के साथ और करेज के साथ प्रैक्टिस करो। और इस प्रोग्राम में क्योंकि मैं बोलने जाऊंगा तो अभी 1 घंटा भी बोल सकता हूँ, जो भी एक लास्ट बोल के जाऊंगा कि आपको एंजॉयमेंट दे, लेकिन टाइम का अभाव है, आप भी बोल रहे हैं इसलिए मैं आपका टाइम स्पॉइल नहीं करूंगा। कि लास्ट कहता हूं कि आपने इस प्रसंग में मुझे बुलाया और मांडविया साहब नहीं आए, नहीं तो मैं इतनी खुल की बात नहीं कर सकता। आई वॉज अंडर सो मच स्ट्रेस कि साहब मैं HSC बना हूँ, साहब इंडियन मिनिस्टर है, उनके सामने मैं कैसे बोलूँगा, क्या बोलूँगा। आई वॉज यस्टरडे हमें फोन आया डॉक्टर दरबार का कि साहब तो नहीं आने वाले। लेकिन वाह भगवान ने मेरी सुन ली। कभी कभी भगवान भी हमारा सुनता है। कोई रोड पर फास्ट बाइक लेते जाता है ना, तो मैं बोलता हूँ कि ये कोई आर्थोपेडिक वाला की गर्भवती काम कर रही है, हमारी अगरबत्ती काम करती है, ऐसे कोई गिरता नहीं है, ऐसे कोई बीमार पड़ता नहीं है। हम अगरबत्ती करते हैं तो आता ही है। तो लास्ट कि हमें एसोल्टन डॉक्टर में बचना है, तो आप लोग जैसे एक फैमिली की तरह पेशेंट के साथ रहते थे, एक फादर मदर के जैसा सीनियर फैमिली फिजिशियन वो नए बच्चों को सिखाए, कुछ सीनियर फिजिशियन को भी दिखाए, को कंसल्टेंट को भी सिखाए हाउ टू बिकम वी लर्न everything in medical college, but not how to behave with the patient, how to behave with the relatives of the patient. ऐसे चरक में लिखा है, आपको बस 2 मिनट में बोल दूं। चरक में 4 प्रकार के पेशेंट बताए, 4 प्रकार के पेशेंट, मैं कहीं भी जगह बोला कि हाउ टू डील विद द पेशेंट एंड पेशेंट रिलेटिव। तो चरक में बताया है कि फर्स्ट टाइप ऑफ पेशेंट इज किंग टाइप, राजा टाइप होगा, दूसरा डेविल टाइप, राक्षस टाइप, तीसरा स्टूपिड टाइप, मूर्ख पेशेंट, और चौथा विदुर टाइप, कॉमन मैन, विदुर टाइप, विदुर जी थे ना ऐसे। तो किंग टाइप पेशेंट मीन्स कि वो आएगा मर्सिडीज गाड़ी में आएगा, उतरेगा, आपको विजिटिंग कार्ड पकड़ा देगा, और बड़े बड़े शहर के जो नाम होंगे वकील या पॉलिटिशियन उनके नाम लेके भाई ये सर तो CM तो हमारे घर रोज आते हैं, हेल्थ मिनिस्टर तो हफ्ते में 2 बार दिखाने आते हैं, बड़ा बड़ा का इंट्रोडक्शन देखा। तो आपको समझ लेना कि ये किंग पेशेंट है। तो उनको कैसे चरक में लिखा है कि उनको रिस्पेक्ट दो, मान आपो, हाउ टू ट्रीट, क्या ट्रीट करना है उसकी उससे कोई बड़ी नहीं। आप कोई भी दवा लिख दो, कोई भी दुआ लिख दो, कुछ चिंता नहीं, उनको रिस्पेक्ट दो कि आई बैठिए, चाय पीजिए, पेपर पढ़िए, जो करना है करो, रिस्पेक्ट देना है। दे डजंट कंसर्न विद द ट्रीटमेंट, दे ओनली वांट रिस्पेक्ट। तो किंग टाइप के पेशेंट है, उनको रिस्पेक्ट दो। दूसरे डेविल, तो आपको सब कुछ पूछेंगे, ये क्यों, ऐसा क्यों, अब तो गूगल आ गया है, सब पढ़ के आते हैं, ये क्यों दिया दवा, ये सब आपके पे भरोसा नहीं करेंगे। आप जो जो करेंगे उसमें वो डाउट करेंगे। आपको कोई भी रिपोर्ट कराएंगे तो भी क्यों कराया, किसका काम आएगा, ये सब कुछ करेंगे, तो आप समझ लेना कि डेविल पेशेंट है। तो डेविल पेशेंट में उन्होंने लिखा है कि उनको सब इंफॉर्मेशन दे दो कि ये रोग है, इसमें ये करना है, ये करना है, ये करना है, ये हो सकता है, सब कॉम्प्लिकेशन सब, और लास्ट में समझाना कभी भी बड़े शहर में या बड़े हाई सेंटर पे शिफ्ट करना होगा। उनको समझाना कि कभी भी उनको ट्रांसफर करना पड़ेगा शिफ्ट करने को, क्योंकि हमारा ये लिखा हुआ है। तो हमें ऐसा लगे कि डेविल पेशेंट है, हमारा ट्रस्ट नहीं करता, क्योंकि मेडिसिन में ट्रस्ट से ज्यादा हीलिंग होता है। भरोसा करके हम डॉक्टर से नहीं, पेशेंट बोलते हैं सर तो खाली नाड़ी पकड़ी मटी जाए, बात करने से मटी जाए, एक गोली आपने मटी, दैट इज द ट्रस्ट इन यू। तो ये दूसरे डेविल टाइप के। तीसरे स्टूपिड पेशेंट होते हैं, वो ऐसे क्वेश्चन पूछेंगे कि आपको लगे कि क्या हुआ। पेशेंट वेंटिलेटर पर होगा और वो पूछेगा सर मच्छर बहुत है, इतना काटेंगे तो खून कितना चला जाएगा, ये है ऐसा। दूसरा पल्मोनरी हेमरेज का पेशेंट होगा, पीडियाट्रिक है, पल्मोनरी हेमरेज है, कोमा में होगा, वेंटिलेटर पर होगा, तो वो पूछेंगे सर उसकी वैक्सीन बाकी है, क्या करें, वैक्सीन का पूछेगा। तो हमें उसको टॉलरेट करना है, बोला मच्छर ज्यादा है, गुड नाइट ले आओ लगा दो, हमें कोई हर्ज नहीं है, वैक्सीन बाकी है दे दो, हमें कोई हर्ज नहीं है। हम ये समझा रहे उनको टॉलरेट करो, सहन करो। लास्ट विदुर पेशेंट होते हैं, विदुर कॉमन मैन, 95% आर विदुर और कॉमन मैन पेशेंट। उनकी 3 लोगों की वजह से हम 95% विदुर कॉमन मैन पेशेंट होते हैं, उसको इनजस्टिस न करे ऐसा हमें देखना है, उनको अच्छी तरह से ट्रीट करे ऐसा हमें देखना है। हम ऐसा करेंगे तो असॉल्ट ऑन डॉक्टर, रीएस्टैब्लिशमेंट बिटवीन ट्रस्ट बिटवीन डॉक्टर्स एंड पेशेंट आएगा, तो असॉल्ट ऑन डॉक्टर चलाया जाएगा। कानून लाने की हम कोशिश करें, लेकिन कानून सबके है, मर्डर के भी है, रेप के सबके, कोई उसको हमें वी हैव टू प्रिवेंशन, वी हैव टू प्रिवेंट, हाउ टू इंक्रीज ट्रस्ट बिटवीन डॉक्टर्स एंड पेशेंट, ये हमें काम करना है। इसके लिए फैमिली फिजिशियन इज द बेस्ट ग्राउंड, बेस्ट पर्सन, वो फैमिली के साथ टच है, फैमिली को समझा सकता है। तो फैमिली फिजिशियन आप डॉक्टर्स और पेशेंट के बीच में जो ब्रिज टूट गया है उसको बांधने की कोशिश करो, वो ट्रस्ट रीएस्टैब्लिशमेंट करने की कोशिश करो, यही हमारी प्रार्थना है। और आज इस ओकेजन में मुझे बुलाया, आप सबको मिलने का मौका किया और मुझे आपने आधा घंटा सहन किया, इसलिए आपको प्रणाम करता हूँ। आयुर्वेद आदमी हूँ, काउंसिल में भी हूँ, इसलिए गुजराती में खेली शायरी कही कि नजर में वसीए थे जरा याद करजो, नजर में वसीए थे जरा याद करजो, कभी कहीं काम पड़े तो साथ करजो। हमने तो आदत पड़ी है भाषण करवानी, तकलीफ पड़ी है तो माफ कर दो।
Thank you very much, sir. A big hand. Keur bhai, I request Dr. Keur bhai to come on stage and request Dr. Anil bhai Nayak to felicitate him for prayer. Jaldi Keur bhai. Before inviting for vote of thanks by our always charming, always smiling, always looks like at 25-30, always full of ideas, a best human being, best husband for Mayuri, best son of parents, best father of Tirth and Devam, always a good friend for all, and best friend of mine, and lots more. બધા શબ્દો ઓછા પડે. Not a single conference is completed without a teamwork, but want to add one golden sentence. Not a single conference can be completed without our team leader like Dr. Pragnesh Vajrayana. A big hand for Dr. Pragnesh Vajrayana, please.
Thank you, Mehul. Today's banquet is sponsored by the organizing committee, not by me. Will not much take time, only 60 seconds. First of all, I am thankful to Dr. Anil Nayak for sparing his valuable time and be with us as guest of honor. Dr. Nitin Shah, who has already left because of a prior commitment. So we are thankful to both of today's guest of honor. Then the stalwarts on the stage, other stalwarts on the stage, CEOs of Dr. Anil Jain, Dr. Parth Desai and Dr. Hiren for supporting us and being one of the main pillars because of whom we could do this conference on this mega sphere. Because you know Ahmedabad is already said, Nakat Narayan ke bina kuch nahi kar sakte. So we are grateful to our sponsors, SDVP Hospital, Epic Hospital, KD Hospital, Sterling Hospital, Apollo Hospital, Arna Hospital, RSSTI Gujarat Chapter, Krish Heart Care, Feederfly, Novel Gastro, Hemato-Oncology Associates, and of course the gift sponsor, the Heart Foundation. So we are thankful to all of them. A special thanks to Dr. Praveen Bhavsar and Dr. Bajpai sir, who has done a tremendous efforts to mobilize and invite Shri Mansukh Mandavia for today's inauguration function. But as due to some unknown commitments, he could not come at the last moment. But still, they managed to get us a message for them. So we are thankful to both of them. And last few minutes about the new responsibilities that I have been assigned today, along with Dr. Pragnesh Shah for FFPI. So I am thankful to all the EC committee members of FFPI, especially Dr. Vinod Parikh, Dr. Janak Shah and Mumbai team and all the past presidents. We have got 7 past presidents joining us today for our conference. So I welcome all of them heartily. Thank you sir for coming to attend this conference and enlightening us. So I am thankful to all the stalwarts, all the seniors and for guiding us, and definitely they will be our guiding force in future. And I am happy to share that now the new headquarters of FFPI is Ahmedabad. So in coming time also, please be with us, and whenever the time comes, Tapli Marjo, this thing is not supposed to be done, and do promote us when we are doing right. So we need participation and active guidance of all the eminent past president and senior members all the time. And last but not the least, I invite you, all of you, to join us for banquet dinner today at 8 p.m. at Gwalia Banquet. The venue is already circulated. So do join us for a musical evening with obviously fantastic food by Gwalias. And last but not the least, again to the delegates who have come from far across India, from all major cities of India. We have got delegates are visiting here in large numbers from Nasik, Indore, Kolkata, Mumbai, Surat. Of course, Gujarat, we have got a lot of colleagues from Gujarat, Surat, Vadodara, Rajkot and all. Please pardon me if I forget to mention a few of the names, but it's in real sense, on behalf of organizing committee, I am thankful to making it a real annual conference with full of participation. Thank you very much. And as a part of conference, the multifaceted activities that we have planned, we have started with a cycle rally on Thursday, and this 2 days conference today, immediately after concluding this program, we are organizing a public awareness seminar for on lifestyle disease, and Dr. Deepak Torawala and Dr. Abhay Dixit will be talking about lifestyle diseases and adult vaccination. So I request all of you to join for that public awareness program also. Thank you very much. And if at all you have faced any difficulties in registration, in collecting early bird gift or any small things, do get in touch with us at 9 a.m. tomorrow. Thank you very much. Yes. Sir, out. Sir, you know, out. Sir,
દીપકભાઈ